Good morning. Thank you so much for joining us today. Thank you for everyone who is here in person, and thank you for all of us joining on Zoom. We're delighted to welcome you to Health Law and Advancing Equitable Access to Care for Youth. I'm Manian. I'm a professor of law and faculty director of the Health Law and Policy program here at American University Washington College of Law. The Health Law and Policy program at WCL is a top-ranked program at the forefront of preparing our students to embrace meaningful careers in this dynamic field of health law and policy and compliance. At WCL and at AU, we strive to champion what matters in health law and policy. We have a focus on practice-oriented education, so we provide extensive opportunities to engage in real-world experiential learning, including our internships, our healthcare compliance certificate, publishing opportunities with our health law and policy brief, participation in national competitions, and more. And our wonderful faculty in health law who are here today are thought leaders across health law domains, including in health equity, reproductive health, food and drug law, bioethics, compliance, fraud and abuse, liability, pharmaceutical patents, and much, much more. Our faculty's diverse perspectives create a rich and collaborative learning environment for our students. And beyond the classroom, our innovative programming brings together practitioners and scholars across the nation, like we have here today, to examine trends, challenges, and opportunities in the continually shifting and complicated healthcare landscape. Just a few logistical matters I'm going to quickly note before we get started. AU is committed to accessibility, so we are providing live captioning for those who are participating on Zoom. This entire symposium is being recorded. It will be available in a few days on our Health Law and Policy Program YouTube page. We have hosted numerous programs this year that you can find recordings on our YouTube page. We've covered so many different topics this year, including the intersection of climate change and health, maternal health inequities, navigating the politicization of reproductive health, public health and pandemic preparedness, gender equality and how sidelining women's stories perpetuates injustice, and today's topic of health law and youth health equity. So we hope you'll check out all of these programs and follow us on social media, including on LinkedIn and on YouTube under our AUWCL Health Law and Policy Program tag. So you can stay connected with us and learn about our future programming as well. I also want to extend a few thanks to all the people who made today's event possible. Putting together a symposium like this relies on the support of many people. We'd like to extend our deepest gratitude to the American University Center on Health, Risk, and Society. They are generously supporting this symposium, and we're so grateful for their collaboration on this and other events. Many thanks to Professor Tracy Weitz, who directs the center, and to Program Coordinator Wendy Anderson. I would especially like to thank our Health Law Policy Program Director, Asha Shelzo, and our Program Coordinator, Tamina Asif. Their tireless efforts and considerable work these past few months have helped to pull this event together. And also thanks to our wonderful support staff, especially catering, who will keep us nourished throughout the day, our facilities team, our audiovisual team, including Ryan Say, and our special events team, including Courtney Watson. So finally, I want to take a moment to especially express our deepest appreciation for our panelists and for our moderators, many of whom have traveled from near and far to be with us today. You'll find their bios on our conference webpage, and they truly represent a stellar group of experts from across the fields of politics, law, public health, sociology, medicine, and more. And I am especially grateful for their willingness to speak out today, given the deeply chilling environment we are all facing from our federal government. In this moment, showing up and speaking takes real courage. And I think it's important to acknowledge that. I wanted to know that particularly around some of the topics that we are covering today, individuals that we had invited and who really, really wanted to speak ultimately had to withdraw. After January 20th, some were told by their institutions that they could no longer speak publicly. And let me be clear, this isn't a criticism of those individuals or their institutions. We understand the very real threats, especially that many hospitals, clinics, healthcare providers, universities are facing, threats to funding and then ultimately to their ability to continue providing the care to the community that they want to provide. So it's a shadow hanging over us, but I want to keep that in mind to also say we are still doing this and we are profoundly grateful for those who are here with us today. Your voices matter and your presence really means more than we can say. So I'm so appreciative for everyone who's showing up today. I just want to say a few things about why we picked this topic and sort of how we came to bring this wonderful group of people together. We chose to focus this year's symposium on youth access to healthcare because this is a population that is too often overlooked in conversations about our increasingly complex health law and policy landscape. Public health researchers have made it very clear across the US, access to healthcare varies widely and unjustly along lines of race, class, gender, ability, sexual orientation, and gender identity, among other issues. But within each of these marginalized groups, children and adolescents face even greater vulnerability. So our hope today is that by bringing together all these experts from across disciplines, we can deepen our understanding of the barriers to equitable access to care for youth. And also we can come away with new insights and new strategies and new tools to help address those barriers. So throughout the day, we'll be exploring a range of interconnected policy challenges, from improving access to youth mental health services, to understanding how social determinants and educational systems shape health outcomes, to navigating the changing landscape of reproductive healthcare post-Dobbs, especially for adolescents. And of course, we'll also focus on challenges and solutions for LGBTQ+ youth who especially face obstacles in accessing affirming care. So, we structured the panels with these 4 topics and in this linear timeline, but of course the real world challenges we're discussing are anything but linear. So to help us better visualize how today's topics and ideas are interconnected, I am very grateful to Professor Tamar Pearson-Brown, who has generously created a systems map of the symposium, an interactive mind map that will track the themes and speakers throughout the day. So if you're here in person, you'll find a printed copy of the map on your desk and QR codes around the room if you want to download it. If you're joining us virtually, the map is available on our conference website and the link will also be posted in our Zoom chat. So everyone should be able to access this map. And we invite you to use this as a tool for interactive engagement throughout the day. So as each panelist speaks, you can feel free to jot down words or big ideas in the boxes next to the session title and to the speakers. And as the day goes on, you can draw arrows and connections and links between the different themes. So that way you can create your own visual guide to how these different systems overlap and interconnect and how they all together shape youth healthcare access and equity. So by the end of the day, our hope is you'll have not just a set of notes from this conference, but a snapshot of how all these complex issues are interconnected and how we can see a bigger picture to move forward more effectively together. So thank you all again for being here, for joining us in the ongoing work of ensuring that all young people, regardless of their background, have the opportunity to be healthy, to be safe, and to thrive. So it is now my honor and pleasure to introduce Professor Tracy Weitz for her welcome remarks. Tracy joined American University as a professor of sociology and director of the Center on Health, Risk, and Society in 2022, which is also when I came here. She also serves as a senior fellow at the Center for American Progress, a nonpartisan policy institute based in Washington, D.C. Prior to that, Tracy served as the U.S. Programs Director for the Susan Thompson Buffett Foundation in Omaha, Nebraska. And prior to that, she also served on the faculty of the Department of Obstetrics, Gynecology, and Reproductive Services at UCSF, University of California, San Francisco, where she was the co-founder and director of Advancing New Standards in Reproductive Health, a leading research program. Tracy has received numerous accolades throughout her distinguished career, including the 2012 UCSF Academic Senate Distinction in Mentoring Award and the 2021 Charles S. Schultz Lifetime Achievement Award from the American Public Health Association. In 2015, she and her wife were honored with the Roger Baldwin Civil Libertarians of the Year Award from the ACLU of Nebraska for their role in challenging the state's ban on same-sex marriage. It's an honor to turn the program over to Tracy to provide her welcome. Thank you, Tracy.
Thank you very much, Professor Manian, and thank you all for being here. It is wonderful to see people in the room today, but also I know we are joined by many people online. I couldn't stress enough that it is a critical time for us to work together to advance equitable access to care for youth. As Dr. Manian said, I am the director of the American University Center on Health, Risk, and Society, and one of your co-hosts for today's event. And our mission at CRIS, as we call ourselves, is to support a thriving multidisciplinary community of scholars that conduct research on health and health-related issues. Our emphasis at CRIS is on the social and structural dimensions of health and risk. We believe that addressing health and healthcare inequities requires understanding health as constructed by social, cultural, economic, political, and historical processes. And today we find ourselves facing active efforts to ignore or erase decades of work to understand the impact of these processes, and most particularly the structures of the gender binary and racialization. These erasures produce unique harms for young people, and that is the purpose of your gathering today. Over the course of today, you'll hear expert panelists and moderators examine a range of interconnected policy challenges for youth access to healthcare, including how the social factors and educational systems shape youth health outcomes. And as a member of the LGBT queer community, I cannot thank you enough for addressing and paying attention to the youth in our community who find themselves even more vulnerable in this moment. I have worked on the issue of abortion for over 50 decades, and I never thought I would stand and say that was a less controversial issue than the issue of race. But that is where we find ourselves. I believe that the solution to today's challenges may seem daunting, but it is through the praxis of scholarship and activism that we will find proactive ways to continue to advance the health of the youth in our society. Have a wonderful day today. Hold each other tightly. Be bold in your moment. I will leave you briefly to go teach at the undergraduate campus, and then I will rejoin you this afternoon. But I cannot thank you all enough for standing up and being here today, and for you for your leadership in this moment. So thank you. And welcome.
Oh.
So I'm thrilled to kick us off with our first panel on the youth mental health crisis and equitable access to care. This panel will be moderated by my wonderful colleague, Professor Thomas Williams. Professor Williams is an assistant professor of law here at WCL. His work focuses on the integrative analysis of health law, bioethics, and entrepreneurship. Thomas has taught many different courses, including on food and drug law, the regulation of human subjects research, contracts, entrepreneurship, and the role of film and literary narrative in the construction of government institutions, as well as our survey health law course. His recent work considers the role entrepreneurs can play in the mitigation of health inequities and disparities. Thank you so much.
Thank you, Professor Manian, for that wonderful welcome, Director Weitz. What a moment for us to be thinking about these questions and the folks who are unseen in the narratives around health. Thank you for making this day happen. A huge thank you to the staff. Again, those unseen folks who make these things possible. Of course, Professor Scelzo, Tamina, again, we can't have these gatherings without folks who are doing work behind the scenes. The panelists and I are very excited to kick off this first panel of the day, which is going to focus on access to mental health services and providers for young people. We're going to start with each of the panelists giving some brief remarks about their work and how it fits into the larger context of our conversation. And I will just provide another plug for you to be thinking about the mind map that's in front of you and how these threads fit together. Thank you, Dr. Pearson. I'm already losing my words.
No, it's okay. Thank you.
The panelists and I hope to spend a good chunk of time answering your questions about the theme and access for young people to mental health. And we hope that you as an audience are going to really raise some questions and pull some themes out of our conversation. With that being said, I hope I can spend just a few minutes framing the conversation with a few data points that I think might help illustrate the need for a conversation on the topic. So according to the most recent data available from the CDC, 1 in 7 children in the United States had a diagnosed mental health or behavioral health condition. Anxiety problems, depression, and behavioral problems are the most frequently seen in children from the ages of 3 to 17. 1 in 3 of those children exhibited more than one of these conditions, which also may include things like attention deficit hyperactivity disorder or ADHD, autism spectrum disorders, or Tourette syndrome, to name a few. The likelihood of treatment increased with age, but across the board, far fewer young people are accessing treatment than the number of them who are diagnosed. Among adolescents, as you might guess, the stressors increase, as do the range of mental health concerns amongst the population. 40% of high school students surveyed reported persistent feelings of sadness or hopelessness in the past year, right? And that is before the moment that we find ourselves in. 20% reported seriously considering attempting suicide in the past year, and 16% reported making a suicide plan in the past year, with 9% actually attempting to take their own lives. Even so, just over half of children with mental health diagnoses are receiving treatment from a mental health professional. You can find more data on youth mental health on the CDC website, from the Kaiser Family Foundation and other sites, but I wanted to give you some kind of a picture for why this conversation is important and who is being left behind. I will add to this that research conducted over the past several decades has helped us to better understand the role that adverse childhood experiences play in long-term mental health. You may know the term ACEs. And I would say that we find ourselves, to mirror the comments of Professor Manian, engaging in this conversation in a moment in which the context of the world we live in is exerting pressures that we may find morally existential, economically existential, and that many of the adults in this room are feeling overwhelmed by and unable to process and meaningfully navigate. I have to imagine that this moment is even harder for young people to make sense of, and it comes on the heels of a worldwide pandemic that fundamentally altered childhood for them. Don't forget that they are also a generation that has come of age with the ongoing threat of school and mass shootings. They bear a heavy psychic burden that I think it is likely very hard for the adults around them to fully understand. So with this as the backdrop, and I know that was a lot of data and it's heavy, but panelists, do feel free to complicate the picture that I have provided. And provide your insights, because I think that is critical, right? Data points live outside of context and reality, and we have to pull that back down to earth for the audience. So with that, I'm going to introduce our first panelists, and I'm going to introduce them as they give comments. Marisa Perella is a licensed clinical social worker in Washington, D.C. She has spent more than 25 years working on behalf of mental health access for children and families of color. And she has been a leader in delivery of children's mental health services in Washington, D.C., with particular attention to the school setting. Ms. Perella was appointed to the mayor's task force to reimagine school mental health in Washington, D.C., and that is the group responsible for developing the comprehensive plan for school mental health in the city. She most recently founded the Momentum Residency, which provides comprehensive equity-focused professional development and job placement for school mental health practitioners serving K through 12 public schools in the city. LCSW Perella, because I decided you have to have an honorific and social workers are other unseen. Please get us started.
Wow. Thank you so much for being here. It's so nice to be among colleagues in an interdisciplinary setting, because sometimes social workers feel like we're out there alone. And it's probably why I got so interested in swimming upstream of the problems that we see every day. And I've been fortunate that I have opportunities to talk with young people all the time, not only as a practitioner or used to be a practitioner, but now as an advisor to my new program. And so what they've always told me is, when you're going and talking to people, don't forget about us. Like, our voices need to be heard. And so I've often, when I've been asked to come on panels to talk about youth access, I will often refer people to the youth themselves because they have the best, I think, perspectives on what's going on. So I'm going to tell you a story, which I think illustrates a lot of what Thomas talked about. And then I can kind of elaborate on the topics that come out of the story of a young girl, Vanessa, who I treated, it's not her real name, many years ago in the city. She was a 14-year-old girl who had come from El Salvador by herself in a very treacherous journey years prior to that, when she was about 8 or 9. When I first met her in the school, I was a school mental health practitioner, part of this ancillary additional mental health that DC made quite a bold investment on, to be honest, to expand mental health in the schools, expand access. And I met her because I was one of the few people in the school who spoke Spanish. And that, for a young person who doesn't speak the language, it doesn't matter who you are in the school, the cafeteria lady, the front desk person. If you speak Spanish, you're home for them. So I spoke Spanish, and so we got to meet really just in the hallways. And eventually she realized I worked for a place called Mary Center, which is a trusted health center for immigrant families in the city. And she began to seek services from me. And what I learned about her, that for the past several years, she had had some real significant mental health issues that had never been addressed, primarily because she was quiet and pretty complacent and pretty smart and pretty resilient. So school really never picked up on that, right? Schools are very interested in disability and they want to service disability, but they're also overloaded and they can't pay attention to every child. And so she had had some fairly significant suicidal thinking for many, many years and was in a pretty dire situation. So I was able to help her through that. I was able to get her referrals to psychiatry. We were able to work with her family to understand why mental health was important, because culturally that was not seen as important. And she was able to get the care that she needed because of this. But I think the reason I tell this story, I think there's a lot of Vanessas out there, and I think just generally, generally speaking, if you're a quiet girl, you get overlooked. And if your trauma manifests in behaviors, you go to jail. You're in the youth, you're in the jail system in the city. So we have these unfortunate ends of the spectrum where kids who are underserved end up. And we know why they end up there. It's because they're not getting that attention early on. So I want to make the case today as we talk that, mental health on site in schools where children are is an equity issue, because these students are the ones who aren't able to get the care. Say that I'll take my child to therapy on a Tuesday night every week for 6 weeks or 8 weeks because I have the ability to do that, right? A lot of families do not have the ability to do that for many different reasons. And so schools allow for that, to reduce the stigma of what it feels like to seek mental health. It doesn't feel quite as stifled as going to a clinic. You're in school. She got to see me every day, right? I could check in with her. It's a different way of thinking about delivering the service. So there's a stigma reduction, but there's also just an access issue, that she was able to get what she needed in school and move on to graduate, which I got to see her do. So I want you to think about her and children like her throughout the day as we talk about access, particularly in communities who are furthest from opportunity.
Thank you so much, LCSW, Perella. Thank you for helping us to remember that the foundation of this conversation is centered on the children moving through experience. Thank you for helping us to think about language as a barrier, especially in this moment, as well as culture, transportation, but also resilience as a barrier, as a limiting factor for students accessing the care that they need. It certainly complicates the conversation. Our second panelist is Dr. Anna M. Kaskin. Dr. Kaskin is an assistant professor of pediatrics at Georgetown University School of Medicine, and she is also the medical director of school-based health at MedStar Medical Group. She also serves as deputy medical director for the Georgetown University Health Justice Alliance, a medical legal partnership serving children in wards 4, 7, and 8 of Washington, D.C. So right east of the river is often what you hear. These are the folks who are the least resourced. I think Professor Cannon will also be talking to us a little bit more about that. Dr. Kaskin is a native Washingtonian. She received her training as a pediatrics resident at Georgetown University Hospital, and she's lived most of her life here in the city. She looks forward to DC statehood. I had to keep this in from your bio. And finally, getting votes in both houses of the US Congress. And I want to tell you that that is a critically important sentence for our conversation today as we think about home rule and our ability to govern access to care for folks without resources. Dr. Kaskin, I've said enough. Please take it away.
Thank you. And thank you so much to the College of Law, the Washington College of Law, for hosting. And I'll add that the School-Based Health Alliance had a conference here a few years ago. So it feels very comfortable to be here. I'm sort of in between.
Come back. Always come back.
So I'm going to talk a little bit about the work that I do in school-based health centers. And I feel like I should probably describe the model because I'm not sure that, well, I know a lot of doctors that I speak to look at me like I have two heads when I say that I work in a high school. So I wouldn't expect many people in our audience to know exactly what that model looks like. So essentially, I came to be practicing professionally in DC as a resident at Georgetown University. The program had a long history of thinking about things like access and integrating mental health into a primary care program, which at the time in the 1990s was not something that was being very widely done. So that's what first drew me back to DC. And I was fortunate to work with the Kids Mobile Medical Clinic, which was taking a mobile van and going out to underserved neighborhoods as a primary care provider. And one of the key people in the program was the social worker, and she's now the director of community pediatrics at MedStar Georgetown and the director of my program. So mental health is always really baked into these conversations, and it was the first time and probably the only time that I've really had the experience of doing interdisciplinary type rounds in a primary care setting. There were plenty of times when in the hospital setting, in the pediatric ICU, on the HIV/AIDS clinic that we were doing interdisciplinary rounds, but not in a primary care setting. And I will also say that at the time, when you talked about interdisciplinary rounds, most of the physicians involved would suddenly find something they were really busy to do that didn't involve talking about some of the other non-medical issues that our families were facing. In 2010, the district provided funding to put clinics in 3 of the high schools in DC. And we were fortunate to get the grant to start the clinic at Anacostia High School at the time. That was the first 3. There are now 7 school-based health centers. And when we were writing our grant proposal, one of the things that I said was, I have to have a social worker. It has to be part of the grant. Otherwise, we're going to just be spinning our wheels. It's just going to be a rotating door with the same kids going out and coming in with the same problem again. So I was fortunate, as I said, that I was working with a social worker at the time who agreed, and the whole team agreed. So we were able to bake that into our services. So what does it actually look like? So the school-based health centers are full-service primary care clinics run by pediatrics, family practice, adolescent medicine specialists. Any primary care service that anybody would take their child to their pediatrician for essentially is available. So, annual physical exams, sports participation exams, all the vaccines, sick visits. They can come get a strep test, just kind of any of the common things that you would take your child to see their doctor. Now, in the high school setting, we are able to have the parents sign a consent form so that the child can come without the parent. So we're able to remove two pretty big barriers to healthcare. So it's easy for the child to get from school to their appointment, and the parent doesn't have to take time off of work. And we can always pick up the phone and call if we have a question. Actually, the thing that works best is to have the kid call the parent, because then the parent knows the number and they answer, as opposed to when I try to call them, they don't know what the number is. So, you know, we can always communicate with the parent, and we typically do let the parents know what's going on in the visit and so on and so forth. So right there, we've just improved access for those families. And the idea of access, I think, Marissa, you touched on this a bit, which is it's not just physical location. That's a huge piece of it, of course, just being located in schools. But it's also that sense of familiarity and trust and warmth. So when the people in your clinic are people you see every day, you see them coming and going in the parking lot, you see them walking around the halls of the building, it's a different relationship than that doctor that you see. You go in, you sit on that crinkly piece of white paper, they give you a white piece of paper gown to put on, and you sit there like half naked once a year. And sometimes it's a different doctor every time. It's a very different relationship. And in terms of being able to integrate mental health services, it's also crucial to have the warm handoff. So when I have someone who comes in who may be reluctant to say that they, you know, are having some of these issues or having suicidal thoughts, or they're feeling close to tears and they just kind of don't want to go there. And particularly with the young men who come to our clinic, are not always eager to accept the idea of therapy. When I can just walk them across the hall and say, I'm just going to introduce you to our social worker. And the social worker is like this super nice, warm, friendly person. It's a lot easier to establish that relationship and kind of break through some of those barriers that may prevent some people from wanting to access care or accepting the idea of therapy. We also are able to get to know our patients on a really, really in-depth level. So we take the time to screen them for mental health issues. We take the time to screen them for social determinants of health and health harming legal needs, which Yael is going to talk to you about as well more in depth. So we can identify just a wide variety of things that may be impacting this child's ability to improve their health, improve their ability to get to school, to pay attention in class. And ultimately our goal is to have them, you know, be more likely to graduate on time and perhaps pursue their education beyond high school. So it does provide a unique model and a unique setting for working with young people on some of these issues of healthcare, primary care health, reproductive health, and mental health.
Thank you, Dr. Kaskin. You know, very appreciative to think about the ways in which innovative thinking can change systems, but also to recenter us in thinking about mental health as part of a larger whole and not as separate from for young people. Thanks also for helping us to think about this idea that the culture of medicine sometimes is rejecting what the most obvious fix, because we need to have that conversation. All right, moving on. Next up is my friend and colleague, Professor Yael Cannon, although I'm now going to call everyone on the panel my friend. So that's what we're doing. Professor Cannon is an associate professor at the Georgetown Law Center and the director of the Health Justice Alliance Law Clinic, which you've already heard a little bit about. That law clinic is a medical legal partnership training the next generation of leaders in law and medicine and I'll just say that is law students and med students, to remove legal barriers to flourishing health. And I love that word flourishing, and I was thinking about it when you were talking, like what you're looking for students is flourishing. Professor Cannon, sorry, I'm jumping around on y'all. Professor Cannon researches the role of law in promoting health equity and family well-being. And she was named a 2022 Health Law Scholar by the American Society of Law, Medicine, and Ethics. She was a Georgetown University Center for Social Justice faculty research fellow as well. Her research and writing has real span. She has a book coming out, I think, about special education advocacy. She has done work in thinking about AIDS in the law, and a forthcoming book on centering families of color. Apologies. She previously taught at the University of New Mexico School of Law, and here at American University's Washington College of Law. So this is really a welcome back. She practiced at the Children's Law Center located here in Washington that I want you to know about. Many of our panelists are connected to the Children's Law Center. It is connective tissue. So with that, Professor Cannon, please take it away.
Thank you so much, Thomas and Maya and the amazing health law faculty here for having us today and convening this conversation, and to my amazing co-panelists who I'm learning from as we speak. I want to talk to you a little bit more about the context of the social and structural determinants of health that face the population of patients that Dr. Kaskin serves. And I want to start by saying, wow, I am so lucky to be her collaborator and partner in this work. You can already tell probably what an incredible physician she is. And I wish you could meet her whole team because they're equally incredible. And just to give you an example, as COVID hit and the school suddenly closed, and they were very worried about the kids who, were at home without access to care and without access to medications that were in the school. Dr. Kaskin's team was, running around Anacostia, delivering asthma medications and checking in on kids and checking in on families' food insecurity and connecting them to emergency resources. And this is really a healthcare team that goes above and beyond. And when I first came to Georgetown to think about what it would mean to establish a medical legal partnership, which is a model that integrates lawyers into healthcare teams to try to address health harming civil legal needs, which we'll talk a little bit more about in a few minutes. I was really fortunate to arrive at Anacostia High School early in my time at Georgetown to meet Dr. Kaskin and talk about what it would be like to partner. And when I got there, I was totally blown away. Next year, we should have this conference at her health center. I walked in and there was a nurse midwife there who was coming. She comes, and this will be very much of interest to Professor Williams with his research, but who comes a couple times a month to visit with and support the pregnant and parenting teens in the high school. There's a large teen parent population there, and there's also an on-site daycare center. Dr. Kaskin's team was treating both the teen parents and their babies in sort of these multi-generational pediatric visits and with a kind of full family approach. There was a group of LGBTQ youth who had graduated from Anacostia High School who were back visiting at the school health center. And they were laughing with the nurse practitioner and with the social worker and with Dr. Kaskin and reminiscing about their time in high school. And they were talking about how hard high school was, but how the school health center was a refuge for them, including a child who was talking about getting support in their transition during the time that they were in high school, and just how much support around their whole well-being they got at that school health center. So you can imagine when I got there and saw this scene, I was like, wow, this is somebody I can really learn from and partner with as we think about how to really bring the support of not only the med school, but the law school in collaboration to, to this community. And I wanted to show a map of the DC area, and that sort of diamond on the right with this squiggly line going down the middle is the diamond of Washington, DC. And this is a map of life expectancy. So check out Georgetown, where the main campus of our institution is, and the hospital. 94 years is the average life expectancy. That is incredibly high for literally anywhere in the world. And that's right here in DC. But as I tell my students, you can sort of wander over to the closest metro station, which of course is not anywhere near the Georgetown neighborhood, since that neighborhood would prefer not to have people have easy transit access to that neighborhood and its resources. So you wander over, maybe you go to Whitley Park or DuPont, you catch the red line, you have to switch trains, and you go down to, on your way towards the bottom southeast corner of the diamond, to Anacostia High School in the neighborhoods of Ward 8, where Dr. Kaskin works. And just in that metro ride, which depending on delays, maybe you're on the metro for like 45 minutes, life expectancy will have dropped on average, and this changes a little year to year, but on average about 25 years. And this is the context in which Dr. Kaskin's work is so, so, so important, because what youth in the neighborhood around the high school are experiencing that contribute to these incredible disparities is really a powerful illustration of the social and structural determinants of health, which we see in our work that I'm going to talk about in a minute show up also as health harming legal needs. So to set the stage in Ward 8, Dr. Kaskin's school health center and the mental health services that it provides were so important because there are big parts of Ward 8 that have historically been medical deserts. Actually, a new hospital just opened last week.
Well, it opens the 15th.
Yeah, it had a soft opening last week. And a lot of people are watching what the impact is going to be. But for a while now, there has been no place east of the Anacostia River to deliver a baby. And that is, not unrelated to the tremendous maternal and infant health disparities that we see there, and some of the research that Professor Manian does about the sort of national context around all of that, you can really see play out in those neighborhoods. But those neighborhoods are also food deserts. There's very few grocery stores with access to fresh and healthy foods. We know that redlining and restrictive covenants throughout our city have segregated primarily Black families in Ward 7 and 8 into housing that is substandard, with really horrible housing conditions that we see all the time with the kids who are living with mold and mice and rodents, which exacerbate asthma and a range of chronic health conditions, and incredibly high rates of eviction, which we know is really connected to both parent and child mental health and health. And there's research showing that even the threat of eviction can have lifelong health and mental health impact. So this is the setting and the needs that that the kids are facing in the school health center. And I just want to talk about how important it is that Dr. Kaskin has made it possible for kids to get access to justice within this low barrier access to healthcare site. Because when families come in, when kids come into the health center, they don't just get sort of a physical checkup. You heard also about the mental health sort of proactive screenings that they're doing and getting kids across the hall within the health suite to the social worker. But they're also asking about legal needs that they know cause tremendous stressors and impact youth mental health and health more broadly. Just to give you an example before I wrap up, so there was a teenage boy, we'll call him Michael, who Dr. Kaskin's team was seeing regularly. He was hanging out at the high school, like from when it opened until when it closed, and going home at the last possible minute. He didn't seem well. He didn't seem happy, and they were trying to figure out what was going on. Well, after exploring things further and developing trust with this teen, they learned that in the middle of February, when it was freezing cold, that Michael had been living, in his Washington, D.C. home in Anacostia without any utilities. So from October, they had had no heat at all. They had had no water. So nowhere to take a shower, no way to wash hands, no way to cook food, no electricity. So no refrigerator, no way to store food, no lights for doing homework in the evening. And the child had been living in those conditions from October through February, through the whole DC winter. And after exploring further, Michael said, I live with my grandmother, and, I don't know that she'll talk to you and want the help that you're talking about getting me through these lawyers, because she's just really very proud. And Dr. Kaskin got on the phone with this grandmother, got her down to the high school, learned that she has end-stage renal failure, which makes these utilities extremely dangerous for her, as well as her grandson, and talked to her and was able to, build trust with her. And our law and medical students were able to build off that trust, and Dr. Kaskin had established, and to begin representing his grandmother and do advocacy to get the utilities turned back on and to get utility assistance in place. So this is a slide of some of the range of civil legal issues that medical legal partnerships work on across the country. There are just a few that are doing them in school health centers like ours, but that model is really, really important. And those legal issues mirror the social determinants of health that, for now, HHS has really prioritized. And I just want to end by saying that our law students, and you can see one of our former students there, talking to Dr. Kaskin at the high school, and our med students are so lucky to be learning in this model, because they are going to graduate and go off and practice having had this interdisciplinary collaboration.
Thank you. And we will talk more later today about social determinants of health in schools with specificity. So I think hearing from you guys as in the midst of that conversation will be quite helpful. Thank you so much, Yael, for helping folks to understand what these partnerships can look like, but also what the real fruit of it is, right? That this young man is actually able to show up at school ready to learn, as opposed to seeking refuge, and to meet his basic needs. Last but not least, I'm going to get it right this time, is Professor Pearson Brown. I almost messed it up again.
No, you're
Tomar
good.
Pearson Brown. She's an assistant professor of law and the director of the Health Law Certificate Program at the University of Pittsburgh School of Law. I have been watching the pit nonstop as I think about University of Pittsburgh. Her research applies elements of system thinking and design approaches to address challenges in legal education and in health justice. You laugh, but the pit is an excellent way to think about some of these problems, and very well done, I think.
Yeah.
I do like television. Prior to serving as assistant professor, Professor Pearson Brown was an associate clinical professor of law and directed Pitt Law's Health Law Clinic, which is also a medical legal partnership, for 8 years. She earned her JD from Case Western Reserve University School of Law, and she got her LLM just down the street at UDC, the David A. Clark School of Law. Professor, give us your thoughts.
Well, thank you for that fine introduction, Thomas, and thank you, Maya, for this opportunity. Thank you to my panelists for all of the work that you're doing and for giving me the opportunity to speak with all of you today. So my research interest thinks about what happens after our young people with mental health issues become adults? What are we doing to make sure that we're ensuring continuity of care as they make that developmental transition into adulthood? And particularly, I'm interested in the structural, legal, and normative factors that converge to create this heightened period of instability when young people transition away from their pediatric home, away from the supports and benefits of childhood into adulthood. And this period of transition is in part developmental, to be sure, but certainly there are also structural factors that we need to be mindful as we think about how we support adolescents in this transition. And so, you know, like Yael, I did medical legal partnership work for a number of years, and I was representing families at Children's Hospital of Pittsburgh, UPMC, where the families were saying to me, you know, I feel like my kid we fell off a cliff. My son or daughter turned 18, and all of a sudden, everything that we had come to rely on, all of the supports, the things that they were able to access in public school, the things that they were able to access, they all went away. And in the pediatric community, when I'm talking to other physicians, you know, they talk about, we need to build better bridges to transition. We just need to find those ways to make that transition more seamless. And so when we talk about healthcare transition, a lot of providers will say, well, we need to make that warm handoff from the pediatric provider to the adult provider. We need to build capacity in patients to make that transition from their who they're seeing for their pediatric services, right? So it's really individual focused. It's really focused on the patient and building patient capacity. And it's really kind of tunnel vision on just going from provider to provider. And so we're talking about making this bridge, but think about it. If you were going to cross a bridge, you would want two even playing fields, right? Like you bridge because there's something here and maybe there's a space in between, but I want to get to this other level surface. In reality, and especially when we're talking about mental health care for young adults, the playing field looks like this, right? There's nothing to bridge to. The services that are available to children and adolescents, and we can certainly critique them, right? But the services are there, right? We've got innovative programs like in-school help. We have wraparound supports. The way that pediatric care is structured tends to be more holistic than the way that adult medical care is structured and provided. So whatever level it is, we can talk about the height, but whatever level it is, if we look objectively at the amount of services, mental health services that are available for adults, it's less. And so you can't build a bridge between two systems that are unevenly resourced. So what are we creating? What is that structure? What does that support look like? And so I think we need to take a look at the structural transition from adolescence to adulthood from three key perspectives. Number one, I think we just need to look at the bare bones structure of our pediatric and our adult care systems. On the one hand, you could say, well, this is, you know, it's objective that they're two separate systems, right? Like kids are just different from adults, but we can also critique that and think about the ableism that infiltrates how we think about who is deserving of care and what quality of care and what measure of care is available, and the ableism that sort of pervades how we think about, well, what it means to be an adult, right? Why do we choose to separately fund child and adult services? And why do we pick a separate service model instead of thinking about life course care or mental health care that can follow children as they evolve? We know that certain mental health conditions don't emerge until late adolescence, right? The way that trauma can look for a young person changes in how trauma presents in an older adolescent and changes between how it presents in an older adult. There are certain conditions that don't even begin to manifest to really show symptoms into late adulthood, right? So we can think about changing the model and changing our investment in our care model. I think we can also think about law-based distinctions between how we treat children with disabilities and adults with disabilities. And so on this, I've been thinking a lot about two things. Number one, I've been thinking about the different standard for childhood SSI versus adult SSI. So SSI stands for Supplemental Security Income. It's a program that's administered through the Social Security Administration, and it's cash assistance for people with disabilities. And this is significant, right? It makes a difference because you get, your sort of insurance through your Medicaid, but the cash assistance can be like, okay, now I'm helping, I have financial assistance to pay for the transportation to get to the visit, right? It's the stuff that I can buy to support whatever diagnosis I have. The standard for childhood eligibility is based on development. It's based on executive functioning. It's based on how is the child able to do things that an able-bodied child of that same age and capacity would be able to do. When that young person turns 18, all of a sudden the standard is, can they work? Why is work linked to our understanding of what it means to be an adult? And is that an ableist construction of adulthood? And does changing that model from what's developmentally appropriate for a young person to can this young person work? Totally lost my train of thought. I'm worried about the ableism, and I'm worried about changing access to a resource that somebody needs, that somebody has been using as a lifeline for perhaps 17 years, and why they should lose access to that lifeline just because they happen to wake up on the morning of their 18th birthday. A second legal consideration that I've been thinking about is this the shift from entitlement to eligibility for disability-related resources and support. So under the IDEA, if you're a child with a disability, if you meet that legal definition and you need mental health services, you are entitled to get an accommodation through your school. This is how a lot of students get in-school supports on executive functioning, behavior modification, right? They're getting mental health supports in the school because they're entitled to it under the IDEA. When they age out of school or when they graduate, they still have access to, the ADA, and we have laws in place that support, but we don't have that same infrastructure or that same right to get the services. So you can apply for what your state has, but states fund these services differentially. So just because you might be eligible for the service as a person with disability doesn't mean you're actually going to get it. So all of the infrastructure and support that we've so carefully created for adolescents and young people suddenly disappears around adulthood. What does that mean for quality of life? What does that mean for health? What does that mean for thriving? Lastly, I think we need to be really thoughtful about the normative construct of who is somebody that we have empathy for, or when we think about people with mental health, right? The young person who's been traumatized, we have some care for them, but the older adult who is maybe talking to themselves or manifesting certain systems, that person is shunned, that person is rejected, right? We think about the adultification of our young people of color. So even when we're talking about adolescent mental health, if this person is not able to move in the world and be perceived as a child who is experiencing trauma or a child who is experiencing distress, the adultification means that we're going to treat this person like an adult, and we don't have empathy for adults with mental health. This is where we see criminal involvement. This is where we see police excessive use of force and violence, right? So we need to be mindful of these structures that undergird how we think about mental health care and how that changes and creates a precarious situation for our young people as they enter into adulthood.
Thank you so much, Professor Pearson-Brown. It makes me think so much about the child welfare system and the ways in which I am older now, but still need supportive parents and like systems and structures. And even then, it's been difficult for many Americans to find access. So to think about 17 and 18-year-olds suddenly, right, both being assumed to be like functional, right? Like that adult actually means something, but also that we've not even been thinking about a system that prepares for them to take care of themselves in these spaces, or acknowledge that, right, so many of the very serious mental health disorders, to your point, emerge in our early 20s and our late teens. So thank you. I have a few questions that I'm going to pose. I have a question that I have pre-selected to close us out so that there is some hope and some like forward momentum for everybody in the room. But let me start with a question that I think is a helpful baseline. Some of the people in the room will know what EPSDT is. It is this acronym that refers to early and periodic screening, diagnosis, and treatment. And EPSDT has been a longstanding required component of state Medicaid programs. Can y'all talk to me a little bit about whether or not the requirements have been effective in ensuring children have access to the mental health care that they need, and how the interventions that we've heard about already today start to connect dots in a more, I don't want to say efficient, but in a more holistic way when you think about the larger systems? And I kind of leave it open to the panel and everybody jump in as you see fit.
So when I think of EPSCT, I think more in terms of the annual well visits that kids need. Are they getting adequate asthma support and follow-up? And I think that it pushes organizations to try to make sure to maximize the number of kids that are going in to see their physician at least once a year. So with the population that we serve, we have kids who, go 2, 3, however many years without really seeing a physician, especially for a physical. They might go to an urgent care because they sprained their ankle, or they have a fever, or they're coughing a lot, or what have you, but they haven't actually had a comprehensive physical. So the idea that we're really pushing for kids to be seen by their physician once a year, and the schools have been fairly proactive with that in terms of requiring kids to turn in their health certificate. So there is more and more a culture of, yes, we want you to be seen once a year. The Medicaid MCOs as well that's one of their goals, is to make sure their enrollees are maximizing.
And I'll just say MCO is managed care organization, to the extent anybody doesn't know all the letters. Go ahead.
So yeah, so they're always really proactive about getting their enrollees to get in for their physicals as well. So you have a number of different organizations working together to try to bring the kid in to be seen. So to that extent, I do think it's helpful. And from a mental health standpoint, for my practice, since we do all that, we do the mental health when they come for their physical, we do the mental health screenings, and we do the well-being. Well, we call it a well-being screening. Originally it was called the health, harm, and legal needs screening. Then we just changed the name on the top of the page. We call it well-being screening now. But so we are looking for all those things. So those are ways to try to capture those kids who are in need of those services. It doesn't necessarily affect supply in terms of mental health providers. So that's the big challenge. We identify kids who need to see, who would benefit from seeing a therapist, or who might need a psychiatrist, but the wait may be, it's typically months, on the order of months. So that's the downside, is that it can be frustrating for providers and their families.
Especially once you know the need is there.
Exactly.
Right, and cannot do anything to help your child. I mean, Marisa, your work is like right in this lane.
Yes, 100%. And I think, one of the challenges is, and they say this in the schools, once you screen, you need to intervene. And so some schools are nervous to screen because they simply don't have the capacity. And we've certainly entered, and one of the reasons this program in DC, this expanded mental health, came to pass is because of that. Schools were screening. They were finding that one school found that 50% of students had thought about suicide that year. That's a public health crisis. That's not something that we would ever ignore if it was something else. Like 50% of students needed glasses. We would just move them along to the optometrist and get them glasses. 50% of students were thinking about suicide in this particular school. So they had to expand their mental health services fairly quickly to screen and to figure out the different levels of treatment that everyone needed. So to your point, I think screening is really important, but if we're not building the systems, students and families begin to mistrust the system even more than they already have, because they're being asked questions a lot of the time and no one is there to follow through. And some providers might say, well, they, especially Medicaid providers will say, they're just not showing up at their appointments. We have a 50% no-show rate. And so I guess my response is, well, what are we doing? What are we doing wrong that they're not coming to their appointments? And part of what we figured out in DC is we needed to provide services in places that were, especially for mental health, that were more palatable and more comfortable for communities. Because they're not going to travel across town, to your point, on the metro to find the most local, Medicaid provider. That there needed to be a deeper sense of trust. Particularly when, and in screening for mental health, do we all tell our doctors the truth? No. I only have one glass of wine a week, doctor, I swear. Because you cannot ask a child about their mental health one time. They're not always going to tell you right away what's going on. They're going to tell you maybe on the third or fourth time because they see Dr. Caskin's coming back every week. And now they trust her and now they're willing to go there because it's there's still a significant amount of stigma attached to that.
Is there also a piece about, like, if students were even to take the train to Northwest, does that provider understand the world in which they live in the context that they have to navigate?
Precisely. And the reason I started this organization that I've run is to bring providers in to really understand holistically the specific communities that we're working in and the cultural component to that. So you're learning about DC culture and history, you're learning about families, you're learning about redlining. We do tours of the DC History Center as part of our training. We look at evidence-based practices, and then we look at, well, who are these evidence-based practices studied? Who did they study to determine that these were okay? And then probably the biggest piece of what we do in our training is we bring in students and we bring in parents and we bring in teachers and school leaders and we talk to all of them and they become our faculty to say, this is what's kind of worked for us in the community. And if we really believe that we want to serve these kids, we want to close these gaps, we really have to talk to the communities a lot more than we're doing. And it's been effective. There's been more trust built when you have folks understanding the communities that they're serving. Yeah.
Excellent. Professors Cannon, Pearson Brown.
I guess I'll just give two dimensions of kind of the legal context of this. One is that when I first learned about EPSDT, I was blown away when I actually sat and read the law and regulations. It is an incredibly robust and powerful law. It makes, to Professor Pearson Brown's point, it makes children's Medicaid so much more robust than adult Medicaid, right? So states can develop in their state Medicaid plan what services they want to provide to adults. But for children under EPSDT, they have to provide all medically necessary treatment and services. So if a provider, like one of my two co-panelists, says that a treatment is medically necessary, and that includes a mental health, behavioral treatment, then it really is supposed to be provided to a child who has Medicaid. The problem is what we were just talking about, what Maricela just mentioned about the just tremendous gaps in care in terms of, especially I think like more intensive community-based mental health services. And so for a long time in my practice, I was seeing kids get sort of very low-level mental health treatment. And then the next step up was like basically psychiatric hospitalization or psychiatric residential treatment or entry into the juvenile justice system or the school to prison pipeline, which I just want to shout out to Nicole Chuchinda, Amy Saji, and Talia Gonzalez, who write a lot about this sort of intersection of all of these issues. And so the law is only as good as it's being implemented. And so that's the first dimension. The second dimension is just that it's only as good as kids actually have access to Medicaid and are covered by it. And obviously that's a huge—
Can I just add too that would also be CHIP is what people might be familiar with in the language.
Yes, and that broader access that kids might have under CHIP. We know that there's many gaps in care across the country, including for immigrant communities. Here in DC, we're really lucky because we have excellent Medicaid coverage on paper. The problem is that we continue to see kids who actually aren't covered by Medicaid, who are supposed to be because of administrative barriers and burdens. And Dr. Caskin had a patient who we worked with at Roosevelt High School who was a young teen mom. I think she was an immigrant from El Salvador, and she and her baby didn't have Medicaid, and she scraped together a few $100s to pay for her child to get vaccinated as a baby. And that baby missed like all of his medical visits, like the first year and a half of his life before he, found his way to the school health center team. And we just know how important that early intervention is, and getting that support, and add to it families who have been through trauma and need parents who need mental health supports like this teen did, and the sort of growing early childhood and infant mental health arena that wasn't available to them.
Dr. Christian-Brown?
Yeah, I mean, so much has been said. There's very little to add. I mean, I guess I'll just say from my perspective, this again reinforces the idea that this sort of chasm that young people fall into, it's legally created, right? Like we have created a structure in which we're going to hold some and not hold
It's not by accident.
Right. Yeah. So this is the sort of the system working as designed.
Yeah,
Okay.
and that's health injustice.
Yeah. So let me like even push that further. On our call, I told you, and I often tell my students that my mother has worked in child welfare for decades. And so there's a way in which the things that your parents do, even if they're not what you do, are like the water that you swim in, right? Like you just have the language, you have the understanding. She served as an appointee in the Children's Bureau during a long career. She told me to take this sentence out, but you got to give props to the mom. And she focused on child welfare and child welfare interventions, and I really carry those values forward. I know that we're talking about broader interventions, but I was wondering if you have a sense of how we might better serve children that are navigating family services and foster care systems, to ensure that they have appropriate access to mental health, especially given that I am going to put forward the idea that their needs may be even greater than those of children in the general population when we talk about stuff like ACEs, but feel free to correct me. So I just wonder, is there a special perspective maybe that we should bring to foster care, children in systems of family separation?
My quick answer, and then I'm really interested to hear what the panelists have to say, is I'm really thoughtful about the lack of coordination between transition planning requirements. So there's transition planning that needs to happen as young people age out of foster care. There's transition planning that's mandated under the IDEA. And then there's transition planning that I think a lot of healthcare providers are thinking about bridging
Right.
that gap. Are those three modes in communication with one another? And my sense is that there's not, right? So there's duplication of effort. So there's resources aren't being conserved or used expeditiously, but there's a missed opportunity to get the benefit of the synergy of doing those three planning processes in tandem with one another. So I think in an environment where we have differential resources, we need to sort of maximize these providers who are sort of committed to doing transition planning work and making sure that they're transitioning in tandem with one another.
And for folks in the audience who don't know what an IDEA is, can you just explain that briefly?
Yeah, so the IDEA is the Individuals with Disabilities Education Act. It's a federal statute that requires a free and appropriate public education be given to all students who meet the legal definition of child with a disability. It's actually a very broad definition of what makes a child with a disability. So if you're a child with a disability, you get an IEP, you get an individualized education program. And part of that program is there's transition planning that's supposed to take place as a related service. And that transition planning is supposed to include, post-secondary education, work, and life skills. And so there's a really great opportunity in this mandate to think about if this person needs continued mental health support in order to enter into adulthood, what are we doing now while they're still in their K through 12 environment to get them ready for those, continuing to grow upon those skills and implement those skills and access those resources in their life outside of school. If this child is also system involved in child welfare, the transition planning for aging out of foster care should be happening in tandem with that school planning. And if there's a physician who's working on, we've got to make the sort of warm handoff from pediatric mental health care or pediatric care in general to adult care, is that provider read into the conversations that are supposed to be happening in school and the conversations are supposed to be happening in the child welfare system? Again, my sense is that that's not happening, and that's a missed opportunity to provide support.
I'm going to add on to that just because, and it's something that honestly don't know the answer, but one of the big challenges is that healthcare systems and electronic medical records don't speak to each other. So not only are we siloed based on our professions, but when someone is transitioning, how are you going to know what was done for the last 17 or 18 years? Because it's like pulling teeth to get any information from a different healthcare system about what was being done for the patient. And I understand HIPAA and all that good stuff, but it seems like there could
But
be.
HIPAA, it's supposed to talk, right? HIPAA assumed that these systems would talk to each other. And right, like that is, I think, what many people argue is yeah.
I
go
think
ahead.
we build systems that actually build the wrong barriers to supporting kids. And I don't think the systems were intended to do that, but they do. And we haven't yet figured out a way to collaborate as the norm. I mean, I think we do want to collaborate. We're all here together, but the systems aren't working in our favor. And the kids are suffering from that. And we see it all the time. Collaboration is also not a funded entity. So if you're looking, which I am, for grants and funding, and I know you are too, you know, they want you to do one thing, but often they're not funding that incredibly important collaborative effort that if you spend enough time with other people who are doing similar work for that child, you will find the solution and you will find it cheaper.
And faster. I
And
would argue,
faster
right?
and more efficiently. And it's not I don't think it's sexy enough to fund.
Yeah, and I just want to say too that I hope, how do we make it sexy? I think what I also just want to know, you know, we have panels later today that are going to
No
focus
Wiley,
on
we get no Wiley.
the pit. That is how we make it, yes. You think we're joking. But I just want to know, and I want to see if we can take a couple of questions from the audience because we're getting low on time, but I hope you're not thinking about our panel this morning in isolation from the conversations we're going to have later today about reproductive health, about LGBTQ plus health, and access to transgender care, right? That we're building this all together. We are on the boat together. So I just want to see, are there any questions from folks? Maybe in the back, and then Rachel, go ahead.
All for your time and definitely having this conversation. So my question is, how can advocates continue fighting the good fight in faces like this? And where do you see the greatest opportunity for legal or policy strategies to make a difference in confronting like selective service delivery for adults with disabilities? I'm asking this because I am a court-appointed guardian for my sister, and I have seen through certain organizations where they will just be like, we're no longer offering services for her. I've gotten excuses, downsizing, short staffing, but they are offering services to similarly situated individuals who are of another race as well. So I'm just curious if any of you thought about like kind of what to do in those types of.
Yeah, I'll do my best to get started. So it sounds like there was two parts, right? What do we do to stay motivated? And I think there was a second part that I'm not remembering, but I'll talk to the first piece. You know, talking to my colleagues is what helps me to sort of stay motivated and stay in the fight, and also keeps my thinking fresh. Because if I'm so used to looking at a problem one way, I start to miss other opportunities. So I talked to Yael, I talked to Nicole, you know, I talked to my colleagues who are thinking about the same issues from different perspectives. And then that gets me thinking like, oh, I didn't think about that connection, right? I think we have to remember that all of these things are connected. I think that's just going to be a theme. And so our silos sort of defeat us, and being self-reflective about the times that even my own thinking gets siloed because I'm so used to approaching a problem one way. So staying in conversation and forming those connections, I think helps to keep our thinking fresh and our advocacy innovative.
That's the connective tissue, right? And speaks to the point y'all were making that all these providers and folks thinking about transitions need to be in conversation. Anybody else want to chime in, or I think we have till 10:30. Okay. I'm trying to be good. I'm sorry, Rachel, and then I'll come to you.
I just, in the midst of this conversation, at the forefront of my brain is the NJVDC, which is an Olmstead case brought on behalf of kiddos with psychiatric disabilities being unnecessarily institutionalized. And I spend a lot of time thinking about like the structural and legal pieces of that. But I'm wondering, like, as practitioners, I think Professor Kendall, we were speaking of like kids either get low level care or they're institutionalized. But as practitioners, maybe to Dr. Kaskin and to you as a social worker, like, what are you seeing that actually helps keep kids out of institutions when they are receiving supports, and have higher levels of need, things that actually help to keep them in their communities?
I mean, something that I thought worked really well years ago when I first got here was, in-home MST services, which is multi-systemic therapy. So these are also extremely difficult positions to fill. Because providers cannot see a lot of families at once because they're traveling from home to home. But the treatment really was very holistic. It brought in families, it brought in teachers, it brought in friends and peers to figure out how to help the child. So it really was treating the child in their community and not in isolation, which we know from many psychiatric illnesses. I mean, community is what brings about a lot of the healing. So that was really effective. I know that it's sort of these kinds of programs have come and gone through the past 25 years that I've seen. And from what I can tell now, these in-home, more intensive programs have really petered out since COVID.
You wonder if like online or telehealth might be a way to.
That's an interesting point. I think the jury's out on that. I think we talk a lot about having increasing access through telehealth. And I think sort of once again, that's been really supportive for people who already have privilege.
What they need, yeah.
Right? So you see a lot more
Digital divide comes back up when you
digital
raise that.
divide, and also just the trust. I think the trust and the norming of that people aren't necessarily set up for that. People aren't they're in jobs and professions that they're cleaning buildings. They're direct service workers. They're not able to be online necessarily, doing that. So I do think that getting back to some of that community work. I mean, I've talked to some incredible school leaders who, when their children aren't coming to school, they send their staff to the parents' door and they knock and they say, we need to bring your child to school today. Is there anything you need
to make that happen?
To make that happen. And that is kind of what it takes right now, in order to get to.
I'm going to take your question and then just add something to close out, and then we will wrap this guy up.
Thank you so much for sharing your expertise this morning. I'm a physician, an adolescent medicine specialist, which means I specialize in the care of teenagers and young adults, and I have a strong interest. So I thank you for your passion in transition of youth with complex and chronic health and other needs. I've also been a school executive strategist, health leader. So just the idea of collaboration, there are so many barriers. But what I wanted to ask about specifically are two things. One is information sharing. So there's between different healthcare systems and records, there's also FERPA and HIPAA. So it's really difficult without a, at least combined limited policy that allows us to share information for the benefit of what kids need now. There's just not a lot of understanding of FERPA, even within the educational space. And so it's very defensive in terms of what I can't share.
And you've got just about like a minute. So if you can give me there was a second piece though.
But the second piece was just the mandates, in resource restricted environments, like education can't screen for health because they're using all their resources. And, in the health environment, we have this that we need to do. So those things that are collaborative, that are not even paid for, become less and less possible as you're.
Okay, I'm gonna stop you only because I'm gonna eat into your break and I apologize. So with that in mind, we talked about a lot of the challenges. I think everyone on this panel and everyone in the audience knows Medicaid has a target on its back right now. My question to you, and I encourage you to be bold. What can each of us in this room, right, facing systems that penalize and shame poor folks, which is, I believe, very clear. What are our next steps leaving this room, thinking about creating systems that better reflect the need for access to mental health and ensure students have access to it? What do we do? What are the little things? Be bold, tell us to fundamentally change things, but we only have a couple minutes. So first thing, I know.
I'm just gonna say mental health is health. Stop separating the two.
Amen.
Keep it together.
I'm gonna say funding, reimbursement. As everybody said, this work is not built into a physician's day, a social worker. We're told you need to see X number of patients, otherwise you're not getting any bonus this year and you're going home with your base salary. So why would you take time away to do something that you're not even going to get reimbursed for? So
incentivize the right things.
Open the codes.
Two things. One is, I think, finding ways to elevate the voices of young people and parents and those with lived experience in these systems. And then also to think about access to youth care, including youth mental health care, as preventive. And so when we were talking about the foster care system, I was thinking of Shanta Trivedi's work, who's going to speak this afternoon, and how that system has kind of been thought of as a family policing or family regulation system that causes a lot of harm. And so how can we kind of reimagine the conversation we're having today as a way to keep kids and families out of that system, out of the school to prison pipeline as well, out of the juvenile justice system? We know those systems are harmful and also very expensive, but policymaking often doesn't think about the long game in that way. So I think we have to continue to surface the preventive role.
The
of these
long-term
interventions.
gains, yeah. Professor Pearson Brown, last word.
Yeah, I would just say foment a clear vision of the world that you want. Know what you're fighting for, not just what you're fighting against.
Amen. All right. Thank you so much, panelists. This has been wonderful. And thank you for your attention and time.
Thank you all so much. This was such a fabulous way to set the stage for our conversations for the day. I've been filling out my map like crazy. I see all these threads, child welfare, you know, pregnant and parenting teens, reproductive healthcare, a refuge for LGBTQ plus healthcare, place, like place is being important for equity. So that will be our next panel, which will start at 10:45. So we'll get a nice break. There's coffee and snacks outside for those of you who are here. For those of you on Zoom, we will be back at 10:45 to talk about the US educational system and social determinants of health for youth. Thank you all so much.
Everybody else back.
I think it's free.
It is so fantastic to have such wonderful energy here in the room. And I know we have a wonderful national audience as well. Welcome and thank you so much for being here today. What a fantastic first panel to start the morning. If you're just joining us, don't worry, it's being recorded, so you can catch that recording later. We're going to send that out to everybody who's registered. But luckily you are here for this next wonderful panel, which is our second panel of the day. Oh, and I should say I'm Asha Shelzo, and again, I'm the director of the Health Law program, and it's again my honor to be part of this program with you today. So we are introducing our second panel, which is the US educational system and social determinants of health for youth, a really vital topic that is part of that intersection we've been talking about all morning. I'm so pleased to introduce our moderator. Thank you so much, Professor Angie Porter, for being as our moderator and just doing so much to help plan this and have this thoughtful discussion this morning. Professor Porter joined the American University Washington College of Law in 2022. She serves as an assistant professor of law, teaching torts, higher education law, and Africana legal studies. Angie's groundbreaking research explores continental and diasporic African ways of knowing governance and examines how these ways of knowing persisted despite the imposition of Western law on African people, which was achieved through enslavement, colonialism, imperialism, and other forms of oppression. Now, Professor Porter, I know you're going to be introducing our delightful panel, so I just want to extend my thanks to each of the panelists in advance and turn it over to you. Thank you.
Thank you so much, Asha, and it is a pleasure to be here with this second panel. I'm going to take my time and introduce them because I do hope at the end of our session, I'm going to reserve about 15 minutes for audience questions. And if there's anything you can connect with right now in their illustrious bios, I would take note of that so you can prepare some questions. So to my immediate right, we have James Hughes, who is an associate professor at the University of Pittsburgh School of Social Work and is the chair of the Race and Youth Development Research Group at the Center on Race and Social Problems. Dr. Hughes also serves as the principal investigator for both the Just Discipline Project, an initiative aiming to reduce punitive discipline in schools, and for Parenting While Black, a program supporting Black caregivers. Dr. Hughes has recently received the Larry E. Davis Award for Excellence in Community Engaged Scholarship, the Distinguished Research Award for the American Educational Research Association, and the Excellence in Research Award from the Society for Social Work and Research. A great researcher.
Nicely.
All right. Next, we have Nicole Pryor-Tuchinda, who is an assistant professor and director of the Health Law program at the College of Law of Loyola University, New Orleans. She teaches health law, disability in the law, children in the law, and torts. Her scholarship, which has been published by journals including New York University Law Review, focuses on preventing and healing childhood trauma, social determinants of health, education, disability, and health justice. She directed the Juvenile and Special Education Law Clinic at the University of the District of Columbia and was a founding co-fellow of the Health Justice Alliance, a medical legal partnership clinic at Georgetown University Law Center. She was an associate at Ropes and Gray, an associate chief counsel for enforcement at the U.S. Food and Drug Administration, has an LLM from Georgetown, MD from Johns Hopkins, JD from GW, BA from Yale. All right. Next, we have Rachel Pereira, who has a PhD in policy analysis from the Party Rand Graduate School, an MPA from the Robert F. Wagner School of Public Service at New York University, and a BA in History and Political Science from Hofstra University. While at Party Rand Graduate School, Dr. Pereira was a National Academy of Education and Spencer Dissertation Fellow, and previously spent 5 years with Teach for America. She's currently a fellow at the Brown Center on Education Policy and holds the Robert and Virginia Hartley Chair in Governance Studies at Brookings. Dr. Pereira is focused on civil rights, education, school discipline, and COVID-19 recovery. And last is Talia Gonzalez, who is a professor of law, Hillary and Lillian Hastings Research Chair, and faculty co-director of the Center for Racial and Economic Justice at UC Law SF, formerly UC Hastings. She's a senior scholar in the UCSF, UC Law SF Consortium on Law, Science, and Health Policy. And since 2017, a senior scholar in the Center on Gender Justice and Opportunity at Georgetown Law. Professor Gonzalez teaches and writes extensively in the fields of education law, health justice, civil rights, restorative justice, and critical race theory. Her work has been supported by grants from various granting organizations, and she is vice president of the board of directors for Public Health Advocates. Let's welcome these panelists again. As Asha mentioned, I teach higher education law. I am not an expert in K-12 or youth health, so I'm really excited to learn from this group. I also anecdotally grew up in Rochester, Minnesota, in the shadow of Mayo Clinic, and both of my parents worked at Mayo Clinic. So I heard we had a physician in the room. I'm sure we have some other health professionals in the room, but that's about the extent. Like I know about Mayo Clinic a lot from my parents. I went to school. How do we put these things together? So that's
You were a young person.
Yeah.
You were a young person to me.
I was a youth. So I'm the representative of the sort of, kind of understand these issues, but I'm largely ignorant to your expertise. So in that spirit, you can talk to me and I'm sure others would appreciate what you say. So my first question is very broad for all of you. And maybe we just take this order in which I introduced you for this initial question. How should we conceptualize the relationship between education and health equity for youth?
Yeah. Well, first of all, thank you thank you to the organizers for putting this together, and thank you to the first panel for a really awesome panel that has a lot of overlap with what we're talking about today. In my own work, it's funny, my bio is very researchy, but my work is very on the ground. Like our team is doing implementation. We have programming in 15 schools, serving 5,000 kids, close to 800 teachers, trying to do restorative work. And then our parenting work is all intervention based. And so I think when we think about the school setting and when we think about health, there's multiple layers. And some of the things that came up early in the first panel around access, to reemphasize the fact that the national recommendation for mental health workers and social workers in schools is around 1 for every 250 kids. But estimates suggest that only 10% of schools are actually meeting that threshold. And schools are the place where kids can get services they need. So there is a missing opportunity there for many of the reasons that were already described. And so that's one set of factors where we're not getting to young people that need help when we could be. But then there's like sins of commission. We are in schools harming children in many cases. We have children that are coming in with needs related to trauma, related to things they're experiencing in life, which, by the way, are not absence of justice issues. Poverty, health disparities, these are issues of justice, racial injustice that have historical roots that are not in a vacuum. And so these are things we need to address. Schools are a place we could potentially support them, but kids are coming to school and they're being, in some cases, re-traumatized. Schools can be very hostile environments, and there are places where kids are being harmed. We have a trauma responsive program. We run this in our schools with restorative programming and some schools without restorative programming beyond this trauma piece. And it's night and day what happens. In some cases, kids see our trauma program as the only safe space they have, versus a school where that's just the tip of a multi-tiered intervention period. And so that becomes a problem that we need to address in the practice and policy levels. We also know that we're punishing kids for health problems. We're punishing kids for mental health challenges. We have a system that is overtaxed, overstretched. Vast majority of teachers we talk to, they want support, they want resources, they want to be able to address things that are related to mental health. They want to reduce their own biases, but they don't have the resources to do it. So we've had success bringing in full-time practitioners in 15 schools to help organize that work, to build relationships, because one of the main predictors of health and mental health is positive, strong relationships for kids, positive relationships with adults. Our team's been able to put people in buildings to help to do that work, specially trained. That wasn't until the federal government changed a little bit. And so our federal funding, it looks like, is on the chopping block. So we may go from 15 sites to 1 site next year. So these are just sort of the political realities that we're dealing with, and some of the, I think, double-sided issues in schools. We're missing opportunities to support. So there's like an omission, and then we are doing harm, which is a commission, and both need some reconciliation.
Thank you for this great question. I think Professor Gonzalez and I would agree that educational inequities lead to health inequities. Educational injustice is health injustice. And what we know from the data is that higher quality education and greater educational attainment, including like graduation from high school and college, means that people have better health behaviors, longer lifespans, and are experiencing poverty less. They're experiencing employment more. And just as we saw in the pandemic, schools are important sources of connection, support, and community, and also places where children receive limited healthcare and other supports. So they are vital to the holistic well-being of children. And unfortunately, schools are also sites of racism, ableism, and other forms of discrimination. And so whether we're talking about the school to prison pipeline or school brutality, which includes police brutality and other excessive, unwarranted forms of state agents applying force upon our children's bodies, schools can be a place of trauma and health harming other actions by the government upon children. So, and unfortunately, children who are living in low income households, children who are minoritized due to their race, immigration status, their gender identity, or sexual orientation. Those children are more vulnerable and more targeted in schools and therefore are experiencing educational inequities that are health harming. And so these questions are really important. And drawing from the last panel, nonetheless, schools are supposed to be places where health harms are prevented. And so the ways in which our education, law, and policy evolve over time will directly affect health over the long run, and also incarceration rates over the long run, because at some point, as mentioned earlier, health problems become criminalized. So we need to do a better job with the way we treat children in schools.
Yeah, thank you for having me. And I'd echo so much of what my co-panelists have said. You know, education doesn't happen in a vacuum, and yet oftentimes policymakers and even at times education leaders think about it as such, right? And so you have instances where children are being punished for mental health and behavioral health problems. We've seen so much of that since the pandemic. We know there's a youth mental health crisis, and yet many states and school districts are responding by promoting punitive practices, making it easier to suspend and expel kids rather than get them the supports. And so, you know, schools can be sites, can be important sites where children and families get more access to health services through wraparound services, through community schools, but they can also be very sort of harmful sites that can, you know, lead to declines in institutional trust, declines in trust with public institutions like schools and hospitals and social workers. And so, you know, schools are provide this sort of avenue for you know, important touch points with children and families. It's one of the only institutions that families in the U.S. are required to engage with, right? We have compulsory school laws here in the U.S. And so, you know, unless you're homeschooling, you have to engage with the school institution. And so they're sites of opportunity, but too often they're not resourced, they're not supported enough to be able to sort of realize the positive impact that schooling can have on health. And so I think especially right now, we're at like a crisis point where schools have not recovered from the harms of the pandemic. Students and educators certainly haven't. And federal supports and extra resources are going away. And you have sort of declining enrollments in some places. So schools are really in need, students are in need, and we're responding with these outdated practices like, you know, punitive discipline that are only going to make the problems worse. And so, you know, I think this is where we're at a critical point for, you know, educators and in the education system in the US. And it's going to be really important that we sort of keep in mind how interconnected these systems are.
So I love being on a panel where I'm not the most cynical. And that suggests that I'm not remarkably cynical, or that I haven't been thinking about this work for multiple decades now in these ways. But I think, you know, you're called, so I double tap many of the things that I just heard all of my colleagues say, right? And I say that because I actually know James, Nicole, and Rachel. And in these different ways, we've either been on Zoom together or in person together. So it's actually really fun to like sit here. And I say that because that's actually also thinking about my response to your query, right? Which at your core, you said, how do I conceptualize, or how do we conceptualize the relationship between health, equity, and education? And I wrote down a couple words, and we've already heard some of these words. One is I think about that as a health affirming, right? So we have this site, we have this opportunity, right? Our young people are in buildings and classrooms, potentially at as early as 3 or 4, right? And maybe going up until 18, 19, maybe into their 20s, depending on sort of when they're matriculating out and moving out of those traditional education spaces. So it's that possibility. So it's structural, right? So one way that I answer that question is it's health affirming because there's a structural component to it. The other way I answer it though, and you just heard 2 very poignant ways of thinking about it that I absolutely agree with and spent a lot of time working towards to do, right, and think about the exposure of harm that young people have, is that it's health harming structurally, right? The ways in which not just schools as sites, right, are set up, but then the people that are constituting them. So that's my other joinder to this, is to say it's structural and it's relational, because you can't walk into a classroom, a building, or even be thinking at a district level and without constituting that with people. Right. And so when we talk about conceptualizing health equity and we talk about education, yes, we can encapsulate it in this health harming and health affirming language, but we also have to contemplate it in these horizontal and vertical ways in which people are moving in the messiness. And maybe they're moving in that messiness, right, around health and education because they are really pushing towards a health harming framework. Or maybe they're working in that messiness because, and we heard this in our first panel, they're moving towards the health affirming framework. And so I would say that it's interlocking and it's compounding. And how we then think about constituting our change, right? How we're moving forward to advance a word like equity, which I will say as many times as I can, since it's often stricken now from conversations. I'll also sneak in that word critical race theory, which I had hoped maybe would also be in my introduction, so I could say it as many times as possible, so that we can talk about compounding interlocking structures of power and oppression, because again, none of this is operating in isolation. So, I really offer that as the opportunity then for everyone to look at the title of this session, which is to say the U.S. educational system and social determinants of health, and also be reminded that education is a social determinant of health. So even within, right, the titling of this, we're compounding and we're interlocking. So I think that's how I'd kind of help us maybe start to encapsulate some of now the more granular, like James was really helping us think about in that classroom moment, right, in that building moment, and these ways in which different programs are available. Rachel was really bringing us to this place and thinking about school discipline, and even Nicole pointing us towards where the possibilities are there, but also a lot of the challenges. And I know because she works and lives in 2 different states that are both not places that are particularly health affirming for young people, especially when their identities are those that sit at the margins and constantly feel that pressure of power and oppression. So.
And wait, Talia, can you remind us of those states?
Well, I'm not going to out Nicole, but I mean, I will say it does indicate that she's in New Orleans. So Louisiana, right, is one state where we're not necessarily feeling as confident and comfortable about the ways, right, in which schools are promoting and supporting our young people and their identities. And then Texas is another place where perhaps we're not feeling, right, that same sort of wrapping our arms around who our young people are and who our adults are, quite frankly, to not continue to create that ableist bifurcation. I think Tamar's really inviting us to think about as well. So
thank you. Thank you so much for that overview. And I think I'm a little cynical with my questions, so we're just going to be cynical together. But I've learned so much. I'm over here feverishly taking notes, and I really am fascinated by everything that was said, particularly that schools are doing harm, health affirming and health harming dynamics. People are being punished, I heard, for their health conditions, and it's in a site that they are required to be in. It's compulsory. School brutality too is a term I hadn't heard yet, alongside police brutality. So let's sit in some of the themes that came up, particularly the intersections, which I know you are all deeply passionate about. So these intersections between these issues and students or youth identities, like their racial identity, their gender identity and sexual orientation, disability, socioeconomic status came up. I'm sure you're in circles. Well, maybe not, but I'm sure you have encountered conversations where those themes are not at the center and your work is different. And I really want to tease that out and help folks who are listening understand why the difference in your work is so important and how we shouldn't make the mistake of thinking these dynamics don't matter. So let's live there for a little bit longer and talk about how these identities intersect in ways that create barriers to equitable health for youth in schools. So let's do reverse order this time.
Sure. So, well, I'll pick up on where Rachel left us off in thinking about school discipline, right? So this is where you are going to get cynical, Talia, or just really pragmatic and realistic, Talia. Is that, you know, when we contemplate school discipline, we have to contemplate it as a health issue, right? We can use the term health crisis, right? We can think about it as a public health crisis at both an individual and community level, but as a practice, right, it is producing exposure to things that are profoundly health harming. And it's been in the last 5 years that we've really seen evidence, the empirical record showcase this in the ways that those like myself who moved through schools and were removed from classrooms, right, were isolated in hallways, were excited when we got to go to the library, for example, instead of being in a classroom, or had a permanent seat in the principal's office, that we knew that this was not okay and our parents would advocate for that. But, you know, depending in my instance of which of my parent came to school and with the color of the skin that they carry with them in the world and the ways in which people make assumptions about that, then the responses were different. And so, you know, it's important to recognize that what we know now about school discipline is that it produces not just traumatic symptomologies and toxic stress in the short term for young people. And when I'm talking about exclusionary school discipline, I'm talking about practices such as suspensions, expulsions, restraints, use of force. And then we can even start to talk about more punitive forms of discipline in terms of policing. But I will just cabin myself to exclusion. And so I will say something else before I tell you about some of the health harms to it, is that use of exclusion is a state sanctioned form of segregation. And so to your query, right, to your pointing us to identity, is that whether you look at the record right now about who are the students who are being expelled, or you start at the very early historical record, or you even intervene right post Board versus Brown decision, that school discipline and in particular suspensions and expulsions are used in deeply profound racialized ways. And so how we think about race and white supremacy then creating barriers that are not just also racialized, but are intersectional, whether that be in the context of gender, sexual orientation, right, socioeconomic status, all of those multiple marginalizations, those are the young people that we're talking about. So what happens when you are excluded from your classroom for a short or a long period of time because law and policy allows for both? You can experience depression. You can experience suicidal ideation, which we heard a number of panelists this morning talking about. You can experience feelings of hopelessness, right? All of these things. Then that compounds because it might not be that it's your first exposure. It's your second, it's your third. It leads to school push out, right? Which then to Nicole's point earlier is that we see a decrease in life expectancy. So when Yael put that quadrant up there, I would have to imagine that when we think about Georgetown in 94 years of age, those are also people who have graduated from high school. Because you have a diminished life expectancy by not graduating high school, which some of the newest data actually shows can be up to 15 years less, which is even greater than it was before. And so there's this whole host of ways that at the moment in the acute exposure, right, you're feeling this mental health and well-being, but then in the long term, and this is where the work of like Michael Nino, and others at Arkansas have really looked at what is this, how does this show up then in young adulthood, but then more importantly, actually in later life, and showing symptomologies of stress, showing symptomologies of depression as well, and then higher rates of mortality and morbidity. So all of that then creates this continuum that says, this is where, when it's landing against the bodies of our young people that are not normative, and I use the word normative to signal not white, right, and not privileged in our schools, that we've operationalized something that allows us to migrate them and move them out and really produce a set of health harms that should not be produced. So the centrality, right, of my work is to say, how do we, one, I would say abolish exposure, right? But that becomes much more provocative, especially in these days. But how do we mitigate exposure, right? And how do we diminish exposure? And the challenge to that is that in the last legislative cycle, so 24-25, we've seen 25 states advance 33 new bills to increase the use of exclusionary school discipline. That is a marked shift from what our legislative trends were previously since 2010, right? And it's actually been since January that 25 of those bills have been proposed to enhance the use of school discipline. So it is no surprise to me, right, that there's a sense of being emboldened at the state level because of federal activities and the ways that education is now facing pressures both federally and at the state level that our young people are getting caught in the middle. And that health harming aspect is really compounding and really interlocking. And it leads to then what James was talking about also is where we think about school-based restorative practices, social emotional learning are being pressurized, right? And being diminished. But I really want to leave space for others to talk about that. So I don't know if I even responded to your question.
You did.
But I'm talking about the things that mean something very deeply to me. And again, this comes back to saying that I think for those of us that do this work, it can come from many places and spaces, but it often comes from a space of lived experience. And I say that for myself. I say that for my brother, and I say that intergenerationally in my family. And so to the extent that the young people and the parents and the caregivers that I'm constantly sitting with and working with, and the educators too, because let us not demonize educators, let us not fall into that same rhetorical trap as well, right? That they are thinking about this because they're also coming from a lot of those same spaces. And so then that creates opportunities, I think, for change and reform in the really more positivist ways that maybe you'll ask us to talk about.
Thank you. There's so much I'd just echo and underscore and what Professor Gonzalez said. You know, I think it's important to understand and consider the US school system as sort of structurally segregated, sort of structurally unequal. And you also, again, to Professor Gonzalez's point, have a lot of within school structural forms of inequality. And so, you know, students from racially minoritized backgrounds, students with disabilities, students who are part of the LGBTQ community, you compound those identities and, you know, the likelihood of you not facing some form of discrimination or unequal opportunity declines, right? Black boys with disabilities have some of the highest suspension rates among any student group. And those are issues that are, again, compounding within and across school systems. But, you know, it's important to also keep in mind in this moment, especially as school privatization is on the rise across states, that public schools are the only institutions that are legally required to serve all students. They do have legal requirements, even if the federal government is trying to weaponize civil rights laws to unjust aims. The law is what the law says. Like, you are required to, serve students with disabilities. You are prevented from disciplining students with disabilities for behaviors related to their disability. And so, that I think presents an opportunity when you're thinking about equity-focused policy and practice. But there again, we see that people aren't considering these intersections. They aren't considering actually the causes of inequality, right? So in lots of states, prior to this boom of efforts to promote punitive practices, there were efforts to promote restorative practices. And those were very much motivated by a large body of work highlighting the negative short-term and long-term effects of suspensions and expulsions. And that work also underscores that, those practices aren't effective in any like short-term outcome that you would hope to see, right? If you think about suspensions as like intended to prevent misbehavior, they don't do that either. And so you have this large body of research, you have policymakers who are finally taking that seriously, but then they're not thinking about like what the cause of discrimination is, what the cause of these inequalities are. And so many of these equity focused reforms, or at least ostensibly equity focused, right, don't have actually like any equity dimension to them. There's this rhetoric around like, we're going to use this reform to reduce racial disparities, but like there's no theory of change in how this sort of policy is outlined that encompasses why we even think like these racial disparities emerge in the first place. And so now we're at this moment where many of these equity focused reforms that I would argue were poorly designed on the front end and not resourced adequately to be effective in their implementation are being now sort of weaponized, or the lack of effectiveness is being then weaponized to say like, okay, that doesn't work, we need to go back to suspending kids. And so, I think these like problems compound both in like structurally in what the system looks like, in how inadequate policy designs and inadequate responses to these problems. And if I'm trying not to like, if I'm trying to like wear a happier or like more hopeful hat, I think that this presents an opportunity because we really haven't tried most of the things that we would think can effectively reduce disparities and improve educational opportunities and access for all students. And so, that is something to keep in mind as we sort of hear this rhetoric, and we try to, again, sort of have this vision to our prior panelist point, this vision of like what we want in the future. And if what we want in the future is a more sort of equitable school system that promotes more equitable health access and outcomes, there are many interventions and policy ideas that have been left on the table, and that suggest have lots of reasons to be hopeful, would lead to promising outcomes.
I would like to just highlight that a lot of the structural reasons why certain kids are targeted more than others stem from structures of funding for our schools. The children who are in low-income households and neighborhoods are getting educated at schools that are where their funding is based on local property taxes. And that's an extremely powerful structural factor that we're often not talking about. And if people want equity for people of all colors, that we need to address this, the problem with poverty and wealth distribution in the United States. But further, there are studies that show that structural problems arise from teacher bias as well as and we can see the legacy of slavery in that. We see how also ableism arises from a lack of understanding of trauma's effects, as well as a lack of understanding and teacher training regarding how disability shows up and how it can impact students. There's an overemphasis on punishment in our schools, in our society in general. Meanwhile, punishment doesn't do much good, especially when compared to ways in which we know how to support children and address their disability needs and actually address the wide variety of learning approaches. So what students need is more support, less punishment, and more empathy and understanding regarding trauma, but also so I think if we actually try to reform education systems to be more supportive rather than punitive and exclusionary, we could actually change so much of how our schools fail children who are the most marginalized.
Yeah, want to echo probably all of what my esteemed colleagues have said, and grounded in some of the things we see in the local context in Pittsburgh. And Tulia mentioned the fact that there's these rising trends in embracing punitive discipline now after many years of progress and moving away from them. And we're definitely seeing that. We're seeing, our work before the pandemic was very much about reducing these rates, and you could see dramatic change. And now in some of our cases, we're just trying to hold the line because the rates across the county are up, the rates across the state are up. And we still have great results versus control groups, but we don't see the same return because schools since the pandemic have, as has been said, responded to mental health crises in particular in punitive ways, which are harmful. They're harmful to health, they're harmful to justice outcomes, all kinds of interconnected youth outcomes. When we look at this with a racial lens locally, one of the interesting things that we've seen is that in Pittsburgh and probably nationally, the city districts, your major districts in your metropolitan areas get a lot of attention around race and justice issues. Pittsburgh Public Schools, the Black suspension rate, we did a study a few years ago, 3-to-1 versus other students. But when you zoom out and look at the county, and Pittsburgh, Allegheny County is one of the whitest major metropolitan counties in the country. When you zoom out, the racial disparity is 8-to-1 at the county level, right? So now you're a Black parent trying to make a housing decision, trying to make a school decision. The city is a little bit safer from the disciplinary standpoint. So these are issues across locales that we need to be thinking about. Another interesting piece of this is that it's been alluded to. Students that have experienced trauma are also highly likely to be disciplined. And we know that, ACEs was mentioned in the first study, in the first panel, 60% of African-American youth nationwide have at least one ACE, adverse childhood experience. So they are in these interlocking circles of harm. And these traumas or different things that our kids are experiencing, poverty, again, those are structurally racist issues that are rooted in segregation, rooted in housing discrimination. In Pittsburgh, you had very serious labor market exclusions for the Black population that migrated there in the 30s and 40s, residential segregation. So these are manufactured inequalities that now pour into the schools. And we talk, there's all this anti-DEI movement nationally. When we talk to school teachers, what we find compelling to them is to say, you're being asked to solve these issues. They don't want us to talk about these issues, but you're being asked to solve these issues. So get behind this movement to talk about and work towards resolution for these issues. And we get traction, but we're also coming in with resources, right? So there's an embracing of those facts when you're also coming in with support, and that does get to the school funding policy issue itself. So building on these strands of hope, I do think in the teaching force, there is an appetite to do things differently. I don't think they think that these punitive approaches are effective. There's a momentary respite, but there's not a long-term solution there. So we can build on that, but we also need to do that with resources, and that's an important piece of that entry point.
Thank you so much. Great segue to what I think is going to be my last question. So dear listeners, please prepare your own questions because you're going to take us home. We kind of left off on hope, and I think this next question is not so hopeful. So, do what you want with that. But I wanted to ask it because in this moment, I think what most people who care about these issues are thinking about is the current moment. The current issues that we are facing day to day, current measures and actions by the federal government that impact all areas of life, including health, including young people and their identities, including the education system. I mean, just to list a few, we have immigration policies, we have executive action and discourse related to gender identity, transgender identity in particular, related to gender as a concept and gender theory. We have various measures affecting access to education, whether that's K-12 or higher education. And of affirmative action, for example, one thing I'm thinking of. Changes to the student debt apparatus. I know that's higher education, but we have measures related to pulling research funding, related to DEIA, and targeting discourse around race. Some of those themes just came up, around history, around social justice. You know, as you said, James, how do you help address a thing if you can't talk about the thing? So these are the many issues happening currently that are on people's minds, and I just want to give you all the opportunity to speak on it through your expertise and help us understand how these issues affect your particular area. And I think the order we can go in this time, no particular order, but I'm just going to say, let's start with Nicole.
So I think part of the solution ought to be enforcement of some existing laws, including the Individuals with Disabilities Education Act, which can help change a punitive approach by a school to one of inclusion and addressing the needs of the child support. And so, and ideally evidence-based support. And that's also why we need continued funding of the research studies that show what teaching practices are most effective. But I think when I think about what else needs to get done, honestly, I think reform of the ways in which schools are paid, are basically funded is really important. And I would like to think that even though there has been talk about being against DEI, that there is still concern about certain, well, if you looked at the recent Dear Colleague letter from the Department of Ed, that there is still concern about certain groups being discriminated against. And there was talk about white and Asian students being discriminated against historically. So if we want to address equity generally, we need to actually think about what's going into our systems and how schools that are struggling really need more resources to actually do all the things that teachers are being asked to do. And so I also think that we need to draw upon interdisciplinary ways of getting children what they need. If every school could have what Dr. Kaskin provides, and school-based resource center, a health center, the meeting of the needs of children with disabilities would not be just siloed to educational approaches. We would be able to take advantage of the full expertise of the medical field. And we need partnerships between educators and healthcare providers to do that. We can do so much more than what we're doing now. And punitive approaches should be the very last resort. And we know better than to be beating kids up by adults in public schools, and we need to stop doing that. And talking about the challenges that cause bias amongst teachers and the legacies of slavery, and trying to actually sincerely meet the health needs of transgender and other LGBTQ youth is absolutely needed. And it's about actually centering their voices and what they want, and not trying to impose or deprive them of supports that they really need. And schools should not be weaponized or be the battleground for where kids can be deemed safe or unsafe. Every child should be safe in school, regardless of their background and intersectional identity. So I think conversations like this help to create the conversation we need to address these many issues. And I really think it's part of the solution.
Yeah, again, underscore so much of what Nicole has said. You know, I think what came to mind when this question was asked is, like real serious concerns about the destruction of the federal education infrastructure at like every dimension, right? Education research, education funding, federal civil rights laws are being weaponized towards unjust aims. They're trying to enforce Title IX. They're reframing Title IX, which is supposed to protect against sex-based discrimination as a weapon to attack trans kids and trans athletes. That's the only Title IX work happening right now at the Department of Ed. And the federal, if we think about the history and like the purpose and why the federal role has emerged and developed in the ways that it has, it was very, most of these functions were designed, they were created to address failures of states to educate all students, right? Before IDEA, students with disabilities did not have access to public schools. That's it, period. Before Title VI of the 1964 Civil Rights there was very little progress in integrating public schools by race, right? You had more than 10 years of sort of stagnation post-Brown, where there was sort of massive resistance, and it wasn't until the Office for Civil Rights was starting to, until the Civil Rights Act and different federal actions were really pushing on states to integrate, that you saw really meaningful integration. Again, funding was intended to address like very serious inequalities. There are still huge funding inequalities, but they're much better now than they were, 50, 60 years ago. We've made huge strides in reducing funding inequalities. And so much of that work is on the chopping block. So I think we all really need to be paying attention to that if we care about education systems. But on the flip side, I think it's really important to keep in mind that at least in the K-12 dimension, most education policy is state and local policy, right? The federal role is very minor, despite all of the talk about the federal government and dismantling the Department of Education and sending all education back to the states. Like, education lives with the states. Like, it's nonsense, the idea that like there's sort of overbearing federal bureaucrats dictating what's happening in schools. That's happening now, but it wasn't happening before. And so, keeping that in mind, I think is really important as working towards educational equity and health equity, because your local school board has a lot of power. Your state legislators have a lot of power, and those political dynamics are very different than the national stage. And so I know it's very easy, myself who works on federal policy, to feel very despondent right now about the opportunities for change here at the federal level. There are plenty of opportunities at the local and state level, and it's really important to keep that in mind and understand those as sites of meaningful change on all of these sort of school policy and practice areas that we've been touching on.
Mm-hmm.
We can Rochambeau for it.
Okay. Well, yeah, I building on what Nicole and Rachel have said, the Dear Colleague letter that came out from the Department of Education was in bad faith and certainly logically indefensible, right? And I'm no lawyer. I'm glad I'm in a room full of them. But from what I understand, pretty legally shaky at best. And I think what I'd like to see, we really have to go on the offensive. We're so busy responding to all the madness that comes out of federal offices now, that I've had the chance to do some work with Legal Defense Fund, and I think it's time to go on the offensive. It's time to go and say, look, let's target these injustices, whether you want to talk about race or not. These things happen to actual families. Actual families were held out of jobs, were held out of housing, were segregated into high poverty areas, and are now subject to inhospitable environmental and institutional conditions. What can we do to say that these things have been wrong? They've had real consequences. Let's talk about them and let's see where our reparative pathways might be. And so I think there's an opportunity for the legal community and the educational community, youth development, youth health, focus people to think about this strategically. What can we do to start fighting back and let them, try to defend the historical record? Because the historical record is unequivocal, which is maybe part of the reason why they don't want to talk about it, right? So let's expose it. Let's do what we can to make it plain, to make it plainer to the public than it is. So we have a firmer ground to stand on in the face of powerful but really misguided and intended forces.
So Angie, I can't take the list of everything in the current moment that you asked us to reflect on. But I think there's a couple of places where I want to highlight, right? Because as I heard your question, it was to say, you know, maybe what are we all paying attention to right now that might be getting to this place of thinking about how within the US educational system, we're going to see an increased diminution of either access to healthcare, right, at a very basic level, or we're going to see forces, right, that actually increase the disparities around on health. And so you named immigration policy. So I just want to have folks think about the fact that, you know, since January and over the last 100+ days of this administration, you've seen student attendance drop dramatically among communities that self-identify as immigrant communities. And that's because of the fear and chilling effect, and because ICE on a daily basis is walking into schools with or without permission, right, and removing young people and separating them from their families. And so some of the early data is showing that anywhere between 5% and 20% of students are no longer attending schools, depending on where they live, because of fear around either mixed status or their own status within their family. And so while then the flip side to that, of course, is that there's been significant action for know your rights trainings, right? To have lawyers and advocates available on call and with regularity. And that includes even places like San Francisco, where I live, right? Where one would assume as a sanctuary city that that is not a concern, but SF Unified in the fall, right? Before the new school year began, was already holding community know your rights trainings to really help educate, but that didn't diminish the chilling effect. And so many of the targeted actions that you're talking about, whether they're legally cognizable or not, and the courts are continuing to weigh in on a daily basis with so many activities, for those of you that do follow that on a legal framework, isn't changing the fact that there's either anticipatory obedience or just chill. Right. So if I'm in a mixed status family and I'm concerned that if I go to school and my parent or caregiver picks me up after school and they will then be removed from me by ICE, I am much less likely to attend school. So then what does that mean for my health? Well, one, obviously, right, that's creating a level of toxic stress and precarity that is going to create weathering on my body. But more importantly, that I'm not getting access to health services that might be available at my school from a mental health standpoint or beyond. So immigration policy and the ways it's being enforced at the local level, I think is really important. And I appreciate you bringing that to bear. The other is thinking about DEIA. So it's not just that we've seen 3 executive orders that have an effect relative to diversity, equity, inclusion, and access, is that we then have the follow-up February 14th Dear Colleague letter, and then most recently, right, the required compliance that all superintendents in each state are supposed to certify that they are complying with federal civil rights laws. And if they don't, right, then the states will lose their federal funding. So each one of those executive orders have economic sanctions provision in them that include, right, things as broad as curriculum, as training, right, and a whole host of activities that we know they shouldn't have control over, and they don't have control over. But again, it's creating a chilling effect, right? It's creating anticipatory obedience, or, right, there's already activities in which funds have been removed. And so we've seen evidence of that already, that at an individualized school district level, the districts are losing funds that are considered under DEI. And so in that moment, right, we have to be thinking about them. Well, then what's the state role, to come back to Rachel's point? So if states truly do have ownership over, and they do, right, around education, whether it be from a First Amendment standpoint in terms of curriculum, but then ultimately just in terms of the whole sets of enforcements, then where do they push back? And so this is where I'm going to point out, because I can think both hopefully and not, is that there has been some litigation. So we've seen litigation In Maryland, we've seen litigation so far in New Hampshire, where the National Education Association and the American Federation of Teachers, and then the local chapters, the state level chapters of AFT, are actually fighting these executive orders. And then now, this past week, actually, is the compliance. So it signals to other states that there's a possibility. New York came out this week and said that they will not be requiring the certifications. The New York Department of Education will not require superintendent certification. California, as it was reported in the LA Times, has stood strong in saying, not as far as say that they're not going to require certification, but I think that's what we all anticipate, right? Vermont has also done that. So again, the question then becomes, in light of the fact that all of this is happening, then what are you doing to stand up? And I think there's a space and place for all of us in this work if what matters to us is health equity and not formal equality, right? As whether that's being framed from a legal standpoint or non-legal standpoint, because that's the weaponization. And so, maybe you're someone who the opportunity is to work at a local level on Know Your Rights, right? And to really be out in the community because those are the capacities. Maybe you now have the ability to be signing on to amicus briefs, right? Maybe you're really thinking in a cross-collaborative way and working with pediatricians, as I do, that we are going out and providing technical assistance pretty regularly for the last few weeks that focuses on the exposure to school discipline is health harming. And that's why actually it should be used as a last resort, to use Nicole's language. So that's my invitation, right? And this kind of picks up where Tamara left us, which I think was a more positive note, which is to say, we all have North Stars in the work that we do, and we're sitting in this room or we're sitting in whatever, maybe our more comfortable pajamas with a cup of tea, which is kind of like where I'd like to be right now in some ways, right? I got my tea. But we're all choosing affirmatively to be in this moment. And so then how can we take the energies that we might have from that and move that forward in all of these ways so that the collective wave is the wave that matters, right? Because it might feel at just a personal level, you're like, I can't yoga my way out of this, which is how I feel on a daily basis. You should be doing your yoga or whatever you need somatically, right? To ground yourself in self-care. But we have to do that relationally and collectively. And so I think that's also my invitation in that, if you're also working with a researcher who can't present anymore, come and present their work for them, right? Bring that forward. And that's certainly true. And I know that opened our conversation, and I work with folks who they have now been put under gag orders, even though they still work for the government and can't present anymore. So I will happily, right, show up and spend that time and voice to bring it in. So I think there's a lot of ways we can all engage.
Thank you so much. So many good things and all of your answers. We have about 10 minutes. We're done at 11:55. And so that means audience questions can happen. Probably time for a couple questions. So I see Professor Williams, and hopefully there's maybe another question. I have a backup one just in case. All right.
Sorry to be chomping at the bit. You mentioned weathering. I'm not sure if I may have been out of the room for a moment, and there was a more fulsome discussion of weathering, but I would love to hear y'all maybe give folks a general definition if they're unfamiliar, but also to talk about weathering in the very specific context of school. It's obviously like a well-known theory in terms of thinking about maternal mortality and morbidity amongst Black women, and the thesis that long-term stress due to race and racism in society is a cause. But can you talk about that and place it in schools? Because that's very important and new for me to think about.
Sure. Nicole, you and I both think about this, so who wants to go first?
Why don't you?
So I think what we're seeing is exactly what you're suggesting, right? Is that both research and lived experience is bringing forward the fact that people's lives are shifting and changing both at a very genetic level and beyond because of exposure to school discipline, and that is intergenerational, especially when we think about families, but because of the toxic stress and the cortisol reaction. And this is where I'm gonna lean on my pediatrician friends in my brain. And if I had the diagram that Danielle McBride, who's at UCSF and a pediatrician there, often uses, is that with that repeated heightened cortisol activity, then it's actually creating a level of toxic stress that is starting to weather the body in the same ways that we think about this in other areas. So it's really an application, right, of a framework and thesis around health and health equity and long-term effects of exposure rates in terms of school discipline. Because at the end of the day, most kids don't get exposed once to discipline, right? And I'm using the term discipline to be encompassing of both the formal and the informal, and that's part of it. So we can track numbers, right? And talk about diminutions or rises in the number of expulsions or suspensions in school or out of school that are happening at a given time. But it's actually the accumulation over time, starting as early as pre-K. So when we look at the data actually relative to Black preschoolers, it is higher rates of exposure, meaning there's more Black preschoolers that are removed from the preschool classrooms than compared to their peers. And then when you break that down, thinking about preschoolers that with their racial identity being one that is Black and, right, being disabled and being a girl or a boy, then the numbers shake out even more significantly and rise, just like James was talking about. So I think people are just really trying to think differently. It's the same way too that when we look at the expanded ACEs research, and there was a recent systematic review that is now actually capturing removal from the classroom as a adverse childhood experience, because you're getting the same types of long-term effects in adulthood from that exposure as well. So really moving us from those traditional ACE categories into the community and urban level, as we think about like the Urban ACE study that was done in Philadelphia, but now into the expanded ACE categories. And so all of that I think is playing together. And that's really been the last about 7 years of research. So it's exciting. It's exciting that we know more about the bad things that these do. But I think it matters because it means that different partners can be at the table. So in California, when willful defiance was up at the state level to finally be removed from state statute over a period of time, it wasn't an instantaneous removal. County mental health departments were significant partners and players. And so that's a really different way of thinking about who are your education stakeholders and why are they caring. And it's the very reason that this title is the way it is. So, but I'm happy to chat too.
And I would add that Harvard's Center for Developing Child, it has done great work regarding the allostatic load that racial discrimination puts upon Black Americans, and how over time it really promotes chronic illness, disability, and early death. And just like the research on trauma, and Dr. Casket, I'm sure, can talk even more about this. It shows that adversity and the law definitely traumatizes by depriving children of adult supports and separating them from their primary attachments and overwhelming them with adversity. But the effects on the body is multi-system inflammation, restructuring of the architecture of the brain to increase connections that promote anxiety and impulsivity, and decrease the connections in like the prefrontal cortex that promote memory and executive function and measured judgment. So thank you for that question.
And just elevating it right within the conversation and space, because, right now there's probably about 15 people in the country, Nicole, I would say, that are really working deeply on this as even just part of like a national working group, this deep intersection between health and school discipline. And it would be amazing if that was doubled and tripled, and quadrupled.
Yeah,
right?
There's so much work that needs done on that.
Okay. Oh, we have another question. Yes.
Hi, thank you all so much for being here. This has been so informative. I one day hope to work in the field of restorative justice, so I really resonate with points about the harm and the ineffectiveness of really punitive measures. So I'd love to hear how you all navigate conversations with people who feel, kids who act out, they deserve to be punished, and like restorative trauma-informed approaches are too lenient and let kids get away with bad behavior. What are your responses to points like that?
How long do we have? I've been doing RJ work since 2001, so I have many thoughts on that. But James, I wonder if you want to jump in because of the work you do in Pitt.
Couple of things with that. I think, you know, when you walk into a building, it's unlikely you're going to get everybody on board, right? So the best way to respond to that is to show them. And you get the people, what we've been able to do, I'll say, is it's a cultural shift, but it's very hard without administrative support to get a foothold, we have found. But we have the people that are willing to do the work and try something different, and they start to see impact. And the students are also early adopters because they see how effective it is to, first of all, build positive cultural attributes in the school, and then have resources when there are conflicts. And when people see it, over time, they start to buy in. So it's harder to make the philosophical argument, although there's very good arguments around why punitive approaches don't work in schools or in criminal justice. But when people get a chance to be exposed to it, get a chance to be a part of the positive energy, a part of the cultural shift, they realize I actually don't like disciplining kids. If I can do something different and have some support in it, then people do embrace it. But there's always folks that are not going to, for a number of different reasons. So having realistic expectations, I think, is also important.
And unfortunately, I do have to cut in. We have 60 seconds though. So I see Nicole do you think?
Yeah, I would say, please tell them to become trauma informed, learn about the impact of trauma upon the brain, so that you can realize that children are far more innocent than you might think at first glance. And they're actually really trying to survive in these difficult, often unsafe environments at school, for instance, and that it's not lenient to not punish them. It's actually going to help them behave better in the long run than excluding them and stigmatizing them. It's not going to help them do better.
Oh, good. Thank you. I feel like that's a great place to end. And fortunately, our panelists are here and we have lunch coming up. I know Asha's going to come down and make an announcement as she's doing that. I just want to thank you all, Talia, Rachel, Nicole, and James. This has been so illuminating, enriching, and we really appreciate you. So thank you so much.
Thank you.
Fantastic. Thank you, Professor Porter, for moderating this panel, putting together such a thoughtful and insightful discussion, and for our fantastic panelists. I just want to put it out there that if we decide to have a t-shirt company that says we can't yoga our way out of this, all property rights on Talia. Okay, for the national audience, it's, you get the property rights.
You know where I'm gonna put them. I'm gonna put them into Justice Works.
Nonprofits. Well, listen, thank you all again, and for the great questions as well. So I just want to mention we have a great crowd on Zoom. So please come back at 12:30, which is when we're going to resume on time with our fantastic keynote. In the meantime, for those who are here, we have a really wonderful lunch set up back in the hallway where you saw the breakfast. If you had asked for any special dietary constraints, please check out the meals we set aside for you with Tamina. So please look for that. Also want to mention that for those who want to take a few minutes, the maps are still in the room. If you're just kind of processing what you learned, feel free to use them to take some notes and get your thoughts together. And online, we're also sharing the map again with you over the chat. So yeah, and if you want to come have your lunch back in this room, of course you can do that. We also have an entire room reserved right across from where the lunch is. It's room 401. So that way you can spread out and have a chance to engage and connect with each other. So we'll see you all back at 12:30, and thank you all again.
Thank you.
Good afternoon, everyone. Welcome back, and welcome to those of us who are joining now. I'm thrilled to welcome both our Dean and our keynote speaker, Representative and Dr. Arvind Venkat. I will first introduce Dean Hughes, and thank you so much for being here with us today. Dean Hughes has been at WCL since 2007 as a professor of law, director of the SJD program, and Senior Associate Dean for Faculty and Academic Affairs. She is a graduate of the college at the University of Chicago. She received her law degree from Harvard Law School, where she was an editor of the Civil Rights, Civil Liberties Law Review. We were classmates and probably never knew each other because that's how big the school was. We're friends now. Dean Hughes is a business law teacher and scholar with a 20-year record of distinguished scholarly publications, focusing on commercial law, markets, and society. She now serves as interim dean of WCL, and I'm so grateful for her support of the Health Law and Policy program, and so pleased to turn it over to her to welcome our keynote speaker.
Thank you so much, Maya, for that kind introduction. Good afternoon. On behalf of American University Washington College of Law, it's my honor to welcome you to the keynote session of Health Law and Advancing Equitable Access to Care for Youth, hosted by our illustrious Health Law program. We're delighted today to bring together experts from law, public health, medicine, sociology, and more to dive into some of the most pressing issues affecting young people's access to healthcare. These include youth mental health and expanding access to essential care, the influence of social determinants and education on health outcomes, challenges and solutions for serving LGBTQ+ youth, navigating adolescent reproductive health care post-Dobbs. That is just some, of the issues affecting youth healthcare. And a symposium like this is so invaluable to help us to think together and to hear from informed and impactful voices working in this field. We're profoundly grateful to our symposium partner, American University Center on Health, Risk, and Society, including Center Director and Professor Tracy Weitz and Program Director Wendy Anderson. And finally, I want to personally acknowledge and thank the Health Law and Policy Program team, including Faculty Director Maya Manian and Program Director Asha Shalo, along with Program Coordinator Tamina Asa. Now I have the distinct privilege of introducing our keynote speaker, someone whose career embodies the spirit of service at the highest level and is truly making an impact in this area of great concern. Representative Arvind Venkat. Representative Venkat is a public servant, physician, and advocate. In 2022, he was elected to represent Pennsylvania's 30th legislative district. He was elected to represent the district, making history as the first Indian American elected to the Pennsylvania House of Representatives, and the first physician to serve in the State General Assembly in nearly 6 decades. To be the only physician in that house, you must have to do a lot of explaining. People must turn it. Before entering elected office, Dr. Venkat spent more than 20 years on the front lines of emergency medicine, treating thousands of patients in crisis, many of whom were navigating the consequences of long-standing health disparities, substance abuse, gun violence, mental health crises, and systemic neglect. These experiences shaped his compassion and shapes his approach to policymaking and legislation. Representative Venkat fights for accessible and affordable healthcare, investing in our first responders, protecting reproductive rights, curbing gun violence, and expanding access to the ballot box for all voters, getting more people back into the workforce as well. Beyond his bedside and legislative duties, Representative Venkat has been deeply involved at the community level. He previously served on the board of the McCandless Franklin Park Ambulance Authority, ensuring vital EMS services for the community. Additionally, he's a former president of the State Emergency Physicians Organization, underscoring his commitment to the medical profession and public health. He brings a unique perspective grounded in both lived experience and professional expertise. At a time when our nation faces profound questions about who gets care, who makes decisions, and whose voices are heard, Representative Venkat offers a vision rooted in compassion, data, and justice, values that align powerfully with our mission here at the Washington College of Law. A distinguished scholar and dedicated practitioner, Representative Venkat completed his undergraduate and graduate education at Harvard University, his medical education at Yale University, and his emergency medicine residency at the University of Cincinnati University Hospital. Please join me in warmly welcoming this amazing keynote speaker.
So thank you for that very kind introduction. Thank you to the Center for Health Law and Policy. Thank you to Professor Manian, who's been my dear friend since childhood. And so it's wonderful to reconnect here. So I'm going to tell a little bit of a story about my background and how it relates to the moment we're in today. And I want to emphasize that what we heard this morning really is setting the stage for what I hope will leave you with an understanding of how we can take the educational and theoretical background that we're seeing now into the real world of politics and policy, which I can tell you is a very messy place. So I'm an emergency physician. I do still practice. For those of you who are fans of The Pit, and I heard it was referenced a couple times this morning, it's actually based on the hospital where I worked for 15 years before I was elected, Allegheny General Hospital. I joke that Noah Wiley's career as an emergency physician parallels mine. I was a medical student when he was John Carter on ER, and now I'm a grizzled emergency physician in Pittsburgh, just like he is on the show. And I went into emergency medicine because it's the only part of our healthcare system where we can see anyone and care for anyone, no questions asked. And you get to be the voice for the voiceless as an emergency physician. I trained at a time before the Affordable Care Act when nearly 20% of my patients had no insurance and no access to care. I've seen patients who died as a result of that. I have practiced during the height of the fentanyl epidemic when patients would come in recurrently during the same clinical shift. We would see them, we would treat them, we would release them, and before the shift was over, they were coming back because of a fentanyl overdose or an opioid overdose. I have practiced during the height of the COVID pandemic, and that's really what motivated me to run for office, because as the president of the State Emergency Physicians Organization at that time, what I saw was the divisions in my community and really across the state of Pennsylvania and across the country and really throughout the world, a misunderstanding of what science and health can do and the need to bridge those divides in the political arena. I get asked often, and the first people who asked me this question were my parents, when I said I was going to run for office, and I learned a lot of new swear words in my native language of Bummer at that time. But what I said then, and I say now, is we get the elected officials we deserve in a democracy. It ultimately comes down to who's willing to step forward and run for office. Before I was elected, in addition to being a practicing emergency physician, I was a professor of emergency medicine and a clinical researcher focused on the economics of the delivery of emergency care. And I have seen the role that academics plays, that academic discussion plays to inform our decision-making. But what I also know is that in this very challenging time, we need to be willing to get outside of our comfort zone and go into what is a messy and often contradictory arena, which is politics, in order to both stop terrible things from happening and hopefully enact good public policies. What I am seeing now as someone who is in the political arena and as a practicing emergency physician is that I have never seen a moment in my lifetime, and certainly in my career as a physician now spanning back to when I started medical school in 1996, that there was a greater threat to the delivery of healthcare to all populations and especially children, which is the focus of your conference today. When we see the attacks on research and scientific expertise that is coming out of the federal government and what that means in terms of understanding the challenges we have, and developing new interventions and treatments, we are seeing a step backwards that, frankly, putting aside the scientific, moral, and educational piece, our economy has been completely dependent on innovation that has come out of the partnership between the federal government and universities. So in a purely self-interested economic way, this attack, these reductions are a step backwards that, frankly, I'm not sure that we can easily recover from. I'm an immigrant, my wife's an immigrant. The attack on immigration that we're seeing, again, is something that is an unfortunate thread in American history. For those of you who studied here, you may have learned of the Know Nothing Party during the 1800s. We're seeing a reestablishment of Know Nothingism in our government today. In my area in Western Pennsylvania, and I represent the North Hills suburbs of Pittsburgh, the only population growth that has existed has been because of the immigrant population. And during my campaign in this past election, and I represent, as I was talking to some of your colleagues today, I represent a purple district. I'm the first Democrat to represent my district ever in the state legislature. And it is really a circumstance of talking to people who will say, in my opinion, very challenging things to say, you know, send everybody back. We don't want anybody who may have come here in an undocumented way. And my answer to them is, well, we're shooting ourselves in the foot. You know, when we are seeing that this population has disproportionately been involved in caring industries, whether it's childcare or healthcare, in the agricultural industry, in the construction industry, in the hospitality industry, you name it, we are really challenging ourselves. The United States is on a trajectory to start having a decrease in population in 2033, except for immigration. In my state of Pennsylvania, that decrease would be happening now, except for immigration. And so, again, purely self-interested, this policy is a danger, and it is coupled with the attack on science and expertise that I mentioned earlier, because immigrant populations are disproportionately involved in scientific research, in medical advancement, in industrial advancement, and this is something that we are seeing a dangerous outcome as a result. The next area that is of great concern to me is the skepticism of vaccines and science and medical evidence in general. I spoke out very vehemently about the nomination of RFK Jr. as the Secretary of Health and Human Services. Right now in Texas and New Mexico, we're seeing the largest measles outbreak in the United States and over at least the last decade. And we're on a trajectory for it to get worse before it gets better. And we are seeing children who have died because of lack of vaccination. And we're seeing attempts to put forward treatments that are harmful. My wife, excuse me, my wife is a pediatric liver specialist. When RFK Jr. started putting forward that everybody should take cod oil, vitamin A, she said to me, we're going to start seeing kids who have liver issues and liver failure. And she was right. Within a week, that's what happened. This skepticism of established medical evidence is endangering children. There's no other way to say it. And we are, as a result, putting ourselves in a position that a disease that was eliminated in the United States as of 15 years ago is roaring back. And finally, and perhaps most egregiously, the attempt to say that cutting $880 billion out of Medicaid would be somehow all related to waste, fraud, and abuse is a moral outrage. It is a policy outrage, and it is one that will have spillover effects to the entire American public. Having practiced as an emergency physician before the Affordable Care Act and before the expansion of Medicaid, and studied this issue in detail, what we know is that Medicaid has been life-saving to enormous parts of the American public. 72 million people in the United States depend on Medicaid, 3 million people in my state of Pennsylvania. And there is no way that an $880 billion cut is related to waste, fraud, and abuse. It will directly affect children. It will definitely directly affect senior citizens. It will directly affect the disabled. It'll directly affect the working poor. That's just the truth. And in our interrelated healthcare system, where I work in a location where I see everyone, and the necessary economics of that is that patients who have high-end insurance subsidize the care of those who have Medicaid or who are uninsured. To take a huge chunk of the population out and say you no longer have access to any type of health insurance is a recipe for everyone to see increased costs and decreased access to health. And that is particularly true in rural parts of this country, predominantly represented by my Republican colleagues, whose hospitals are struggling, whose access to care is less than what we would experience either here in Washington, D.C. or where I live in Pittsburgh. And the result of that will be a continuous cycle, vicious cycle of loss of healthcare access and spiraling costs. And so we are at a moment, all of this together, that is, to go to the topic of your conference, is directly jeopardizing health for youth in all forms. And finally, and this has become apparent over the last week, you know, the tariff policies from the Trump administration combined with a budget proposal to lower taxes for billionaires and beyond is as great a shift in American history of taxation and costs and burden from the most well-off to the least well-off. It is Robin Hood in reverse, as has been termed in many press reports, that I can imagine. And as a result, the combination of higher costs, decreased health access, loss of scientific expertise, rapid spread of previously eliminated infectious diseases, and a loss of demographic progress that comes with immigration is a very dangerous moment for our country and for what you were talking about today. So what can we do about this? So I'll go back to the moment when I decided to run for office in 2021. I started having discussions about this, and I mentioned my family was somewhat skeptical of it. About 6 months later, they started asking me where my polling was, but that's a different story. And in my area, it had changed quite a bit. It had been a traditionally Republican area. Democrats were really nowhere to be found. That had changed in the Trump era, but it was still a very kind of purple, you know, unclear area. And running as a person of color, as a minority, there were questions from friends and family to say, how are you going to overcome some of the non-verbalized barriers that exist to being able to move into a position of representation for your community? And my answer to that is, there's no doubt that racism exists. There is no doubt that it didn't just exist in the past, it exists to this day. We're dealing with the consequences of it to this day. But I believe strongly that we can overcome those barriers by meeting people where they are and showing that we care about their concerns. There's a saying that all of us in medicine learn, probably on the first day of medical school, that no one cares about what you know until they know you care. That empathy is a critical part of how we build bridges. And so my entire campaign was based on door knocking. I've personally knocked on 35,000 doors in my district. There's probably not a house in my district that I haven't knocked on their door more than once. And that lesson of meeting people where they are and trying to show our empathy, I think, is a critical part of where we are today. one of the things that I saw in the academic discussions this morning is that there is a great deal of understanding and scholarship and being able to see where the problem is. But if we are going to overcome these readily identified concerns, we are going to have to get outside of our comfort zone. So what does that mean as a practical matter? And I'll put on my hat as a state legislator now. I serve in a body, I serve in the state house in Pennsylvania, where there are 102 Democrats and 101 Republicans. It is as closely divided as you can imagine. We have a Republican state Senate, we have a Democratic governor. So to get anything done, you have to find an ability to work across the aisle. Otherwise, you can't get anything done. On the flip side, because we flipped control of the state house when I and a number of others were elected in 2022, we were able to stop a lot of bad things from happening. Attempts to prevent abortion from being recognized as constitutional under our state constitution. We were able to stop efforts to discriminate against the LGBTQ plus community. These are bills that oftentimes come over from our state Senate and don't get a vote in our state house. And it fundamentally came about because individuals like myself and others stepped forward, and the public ultimately decided that we wanted to see a different Pennsylvania. So I'm going to give you 4 things that I would ask all of you to do coming out of this conference that have nothing to do with what is correctly identified as the problems here, but as a practical kind of guide to take that knowledge and bring it into the political arena, which is messy and difficult and compromised and does not always result in everything that we'd like to see in public policy on a regular basis. The first is you need to build relationships with your local elected officials. Too often we see a concentration on what's happening in here in DC, and I understand that. What you see in the news is, what is President Trump doing? What is Congress doing? What is whatever outrage is coming out of, some elected official's mouth in DC. But 90% of the governing that happens in our federal system happens at the state and local level. But 90% of people don't know who their state and local elected officials are. It is critically important that every person in this room, and frankly, the public as a whole, build a relationship with their local and state elected officials, because both political parties are pushing issues down to the state and local level. Whether we like it or not, whether we think there should be federal solutions, it is going to be pushed down to the state and local levels. So how are you going to build relationships with your state and local elected officials? Honestly, it is a matter of deciding that it's a priority for you, and every 6 months picking up the phone to say, I want to meet with my state representative or my state senator or both. And don't go there the first time and ask for something. Don't make the first time that you're meeting your state elected official be that you're asking for something. Make sure that it is that you are saying, I'm a lawyer, I'm a physician, I'm a social worker, whatever the case may be. These are the issues that I'm seeing in our community, and I want to be a resource to you, and I want to learn what you're working on. That, to me, is the most impactful thing that a constituent of mine can do. And I represent about 63,000 people in the state house. There's probably a couple thousand who regularly will contact me in some way, shape, or form. And you can imagine that they're the ones who stick in my head when I'm thinking about how do I best represent that community. The easiest thing for me as a state elected official is if the public says nothing to me about an issue, because then I am free to do whatever is politically expedient or whatever the case may be. But when the public is engaged on an issue or in a relationship, that's when the all politics is local saying comes forward. And so having that relationship with your state legislators, with your local elected officials is really important. The second thing that I would strongly advise all of you is, as much as data is important and as much as data should inform decisions, and I'm a nerd, I'm a professor of emergency medicine, I like reading papers, I like research, but stories are what persuade, not data. showing up at a meeting with 5 academic papers. Trust me when I say, even I, as an academician, will not be able to process that. But I will remember the story of a constituent who lost access to healthcare because Medicaid was ripped away, or an LGBTQ youth in my community who wasn't able to participate in a school activity because of discriminatory practices, or a pregnant woman whose life was jeopardized because they didn't have access to reproductive health care. And that is where stories are very, very important. And we've talked about the pit a couple times. I'll just draw the parallel here. The RAND Corporation here in DC just produced an amazing report on the jeopardy of emergency care, both for children and for the American population as a whole. It's a wonderful report, has all types of amazing statistics. I guarantee that every member of Congress is thinking about what they saw on the pit than whether that RAND report was there. And what they've done in that portrayal is show the same problems, but in a way that we can understand from a humanistic perspective. And so bring your stories to these meetings and your engagement, and recognize that that is how you are going to persuade. That is how you're going to make real the issues that you're talking about today. The third area that is very important is that we need to recognize that we're not going to get perfection out of our elected officials. The idea that our elected officials are going to come up with wonderful policy solutions that will address these issues is frankly a fantasy. The best ideas come from all of you. It comes from the activities that you're doing in your community every day. It's not from what I do in Harrisburg, that's for sure. It is the best ideas come when a constituent comes to me with a practical problem, a practical solution, understands that it is difficult to push things through the political process, and then to go from there. And I'll give you a real world example. I have a constituent. Her name is Kathy Bryden. She has given me the permission to tell her story. She came to my office about 1.5 years ago related to her son who had serious food allergies and died as a result of cross-contamination in a restaurant. An example, tragically, of a story that has stuck in my head since that time. And she said, look, there's pieces of legislation in other states that have addressed this issue. Are you willing to pick up that flag and move forward with that? And the answer to that is yes. And being able to bring Republican colleagues along, we've been able to pass that legislation and hopefully get it enacted to law shortly. That is directly as a result of the public, in this example, the Bryden family, coming forward and saying, this is a real world issue. This is our lived experience and what we need to go from there. And when she told her story, she didn't talk about her story in terms of an unrelatable way. As much as I would love that my colleagues would understand intersectionality or would understand critical race theory or a number of different issues, we need to put our language at a level and in a relationship that fits with the lived experience of the people who are representing us. Like when I meet with medical folks, I love to lapse into medical jargon, but I guarantee my colleagues don't and have no idea what the difference is between an ophthalmologist and a rheumatologist or whatever the case may be. And we need our ability to tell stories to be couched in a language that still fits within a tradition that is going to be beneficial and is going to get our point across without automatically alienating because of political divergence. Because we want to try and build bridges. We don't want to just simply say, I agree or disagree because I used a term that they may not understand or understand the background of. And so that's hard. That's really, really hard. That's not a simple thing at all. And I've experienced it firsthand, as someone of Hindu background, when I've brought up some issues of religious freedom and have had some of my Christian colleagues try to analogize in a way that I found personally offensive. But kind of slowly bringing them along in a way that used common terms was much more effective than saying, you know, I'm not going to talk with you because I think your heart is in the wrong place because of how you framed this or not. And that's not easy, and it's not simple. And then the last thing is that don't expect that the political world is going to save us, because the political world is messy, gray, and difficult. As I mentioned, sit in a legislative body with 102 Democrats and 101 Republicans. I think most of my colleagues would say that I'm in the centrist part of the spectrum of our caucus. I have a colleague who represents a part of central Pennsylvania that went for Trump by 30 points, and he wins as a Democrat by anywhere from 3 to 10 points. He is indistinguishable from my Republican friends on issues like abortion rights, gun safety, but he's with the Democrats on economic populism and supporting the social safety net and supporting organizing in unions. And as a result of his election, as much as mine, we are able to prevent a rollback of reproductive rights. We're able to prevent a rollback of LGBTQ plus rights in Pennsylvania. We're able to advocate for Medicaid expansion. We're able to expand the child care tax credit. And that's messy. That's not helpful. In the last election, he used political rhetoric, which I found very, very challenging, but was necessary for him to win. And that kept Democrats in control in the state house, and it allowed us to drive an agenda forward that I'd be willing to bet many of us here would find beneficial. But the political world isn't going to save us because of how messy that is. Please continue to do the grassroots activism that is needed to raise your voice. In this very challenging moment, one of the things that has really struck me is the lack of moral courage that we're seeing, whether it's from law firms or universities or from other entities that we would assume would band together to raise their voice. And it is a necessary part of advocacy to understand that we are going to have very public positions, and we should have public positions, and we should petition our elected officials, and we should protest. But because the political process is so messy, we have to sometimes be willing to accept that we're going to get half a loaf and not a full loaf, and not call that a defeat, but call that an initial victory that we can then expand upon. So those four things, I honestly think, are the practical ways that we can translate the knowledge that we're acquiring here and the challenges we're facing in the delivery of health to youth into actual real accomplishment that exists. So I'll close with a story about where kind of the intersection of advocacy and health really has struck me. So last legislative session, there was a resolution, and resolutions, at least in Pennsylvania, are not particularly, significant. We do resolutions on amusement parks. We do resolutions on, somebody, did something extraordinary 30 years ago, which no one really remembers, but we want to remember because it happens to be that day and we need to do something on the floor. One of my colleagues from Philadelphia put forward a resolution to recognize a group called Vote ER. They register voters in emergency departments. It's a nonpartisan activity. They just do it because they recognize the social determinants of health. And one of the key ones is whether you are engaged and empowered within the political process. And he did a resolution to recognize that. Should have been completely non-controversial. And one of my colleagues on the Republican side, actually the then Republican leader, stood up and said, I think physicians should be focused on clinical care. I don't think they should be doing anything else beyond that. And that got my blood pressure up. So I stood up and I told the story of a very famous physician, at least to physicians in Western history, named Rudolf Virchow. Rudolf Virchow is known in medicine. He had a great understanding of physiology. He identified patterns that made a big difference even to this day in terms of how we diagnose certain conditions. But in the late 1800s, he was asked by his community to investigate the causes of a typhus outbreak. Typhus is a disease that we do not see in the United States, but typhus is a disease that is transmitted by fleas. It's directly related to sanitation and related to poverty, and you see outbreaks of typhus in impoverished communities. And he wrote a report, and in that report, he said that medicine is a social science and that politics is medicine on a larger scale. And that is a saying and a story that when he was reporting about typhus that I brought to my colleagues in the Pennsylvania House to say that whatever walk of life you're in, medicine, law, social science, social work, you name it, that to take yourself out of your comfort zone and recognize that there are additional factors that come into play in terms of how we deliver health, how we have healthy and well communities, comes directly from, frankly, the political process. And that is an important part of what we face. And so that political engagement, as uncomfortable as it is really important in this time when we're facing challenges that, frankly, I didn't think we would ever see. So with that, I'm very grateful for the opportunity to be here, and I'm happy to answer your questions.
Have until 1:30 for questions. That was very sobering and very inspiring. I'm sure we'll have a lot of questions. Do you want to just take hands?
Sure, yeah, absolutely. Asha.
Cool. I'll start. Thank
Yeah.
you. And thank you so much for your
Yeah,
wonderful
yeah.
comments, for being here. What about the role of misinformation and disinformation when you are meeting with your constituents, other stakeholders? How are you hearing this? How are you handling it?
Yeah, so I hear it a lot, related to vaccines, related to COVID, related to, trans youth, you name it. I think there's two parts to how we need to address misinformation. The first is we frankly need research on how effective communication happens. When we're talking about NIH priorities, and I'm not talking under the crazy administration we have today. When we look at the pandemic, when we look at the COVID pandemic, from a scientific perspective, it was an extraordinarily amazing outcome to develop an effective vaccine to prevent or largely limit serious illness within 10 to 12 months. It's never happened in scientific history, and we should be grateful for that. But we never studied how to communicate that effectively with people. My personal experience, anecdotal, not scientific, but I think we do need scientific research on how to communicate effectively, is when you have met people repeatedly and show that you care about what their concerns are, that when misinformation happens, you are able to address it very rapidly. I have a colleague in the legislature who came to me and said, my wife and I are really concerned about vaccines. We've read all this stuff that it's going to cause our child to have autism and the like. So, but we had built a relationship. He came and talked with me about it, and I walked him through, this is the facts about vaccines, including my personal experience and my wife's personal experience. We have 3 children. They're all vaccinated. They're all fine. The vast majority of people have the same experience. And so I feel comfortable saying that that would be beneficial to your child. And he ended up having his children vaccinated. But that came because we had that type of relationship that I wasn't just talking with him for the first time in that circumstance. And so I think, honestly, to borrow a football analogy, it's about blocking and tackling. It's about meeting people where they are, having relationships across what can be uncomfortable divides, so that when those moments come, you can disabuse people of the misinformation that exists. I also think we need to flood the zone with good information. I was never a social media person until I was a candidate. Now I post 2 or 3 times a day. And part of that is to drive a narrative of what I think is important before other people fill that vacuum. Other questions? Yes.
I sometimes do legislative advocacy too, and I was struck by your point. Of course, we have to sort of think about how to compromise, or not much is going to get done.
Mhm.
But how do you balance that with preserving your values?
Mhm.
You know, I'm thinking like immediately after the election, people were like, we should have toned down the trans stuff,
Mhm.
which to me would be a compromising of my values. To say, let's throw this marginalized population under the bus
Mhm.
so we can win this election, but of course, losing the election had significant consequences that,
Yeah.
I haven't seen what we've dealt with in the last 5 minutes. But there's a constant, and how do we strike that balance?
Yeah, so I don't think we should ever compromise on our values. I think what we can compromise on is the outcomes that sometimes come about from the advocacy from our values. And I think the issue of trans rights is a really important example of this. I'm amazed as a Democratic elected official that we've allowed this issue to be defined by whether a trans girl participates in a swim meet. What I have said to my constituents is, and you may not like this answer, but this is the honest answer that I've given, is that I'm a physician. I know there are biological differences between men and women. I don't think it's discriminatory for recognizing that there are certain single sex areas of activity, but that the real issue that we're talking about is whether we treat everyone equally and with dignity before the law. And that when we're talking about employment, housing, public accommodations, education, healthcare, we have said that our American tradition is that people are not discriminated against under those circumstances. So that's what I'm fighting for. And I'm not going to go down the rabbit hole of an issue that affects a tiny group of conspicuous people who are trying to distract us with a shiny object over here from what the vast problem is over here. And so that's how I do it. It may not be the perfect answer. It's an answer that has allowed me to continue to look myself in the mirror and still be able to fight for what I think is the real issue when we're legislating and we're talking about constitutional policy and we're talking about, in my city of Pittsburgh, where right now trans adults are not able to get gender affirming care because of the issues that we're facing. And so I don't think I've compromised on my values in that regard, but I think I've been able to put it in a framework that can bring more than 50% of the people that I represent along to be able to fight on this and every other issue. So that's how I would approach it. Yeah, yes.
We kind of touched upon this earlier at the conference, and disinformation around particular diseases we thought we pretty much eradicated and everything else in these cuts. But from what I've seen, essentially collectively, we seem to be kind of on the precipice of the greatest loss of life expectancy in the history of the Western world, at least in the last century. I don't know how, I guess my question is, how do you deal with that or acknowledge that reality without just coming across as a doomer?
Sure. So first of all, I acknowledge the reality. I mean, I think that, I portrayed it, I think, in my speech, but if I didn't emphasize it enough, I think this is as dangerous a moment when it comes to health in our country as I've seen. And I think, students of history would say probably that we've ever seen. And so I think it's okay to acknowledge the doom that is there. The question is, what do we do about it? I think the 3 things that people need to do and need to do very quickly is raise their voices in an organized way, peacefully but loudly, in every opportunity with our federal elected officials. I think that don't assume that your power is diminished because you're one individual, but recognize that if there are 10 individuals, that is very powerful. If there's 1,000 individuals, it's extraordinarily powerful. So whatever the issue is, people need to get in the game of not being violent. I'm not advocating for that. I'm saying loudly but peacefully to protest and to make their voice heard. As a state legislator, if I get 5 phone calls in my office about an issue in a day, that is like a 5-alarm fire going off in my head, because 5 people don't call my office every day on one issue. But too often we assume that our elected officials don't pay attention to popular will. That's not true. But the easiest thing to do, like I said, is to reinforce apathy. The second thing is we all have to vote in every election. There are critical local and state elections this year. In my state of Pennsylvania, there are 3 Supreme Court seats which are on the ballot. There are county court seats, there are school board seats, there are local municipality seats. As an elected official, I pay attention to what's going on at the local and state elected level. If my community starts drifting away from where I am, I have to think long and hard about how to do that. So voting is critically important. And then the last piece is, and this is the most uncomfortable piece, but it's true, is we need people to step up and run for office, and we need to support them, those who do, in every way that we need to do so. And that involves time and it involves treasure. I believe that we should have root and branch campaign finance reform, but until we do, unless we, the people, are willing to participate in the political process, both with time and treasure, we simply will not get the outcomes that we want. So those are the 3 things that people need to do. They need to organize and raise their voice. They need to vote. And they need to run for office, and they need to make sure that they're supporting those who do. Yes.
So obviously we're Washington, DC, so I think maybe there's a little bit more of a belief in subject matter expertise.
Yeah.
I feel like in higher levels across the country, I was an engineer in Texas.
Sure.
And the people who I were working with were advanced degrees in chemical engineering, had experience in vaccine development, and they were still skeptical about those things. What do you think about that trend? And is there a reason? Is there a basis, or is it pushed by rhetoric?
So I'm very concerned about this war on expertise. And it's always ironic to me in the legislature when some of my colleagues who are very vocal about their skepticism of expertise when the cameras are off, will come to me and say, hey, can you tell me what you think about this medical issue or that medical issue or the one? It's an opportunity to build relationships, but I got to bite my tongue sometimes when I'm doing that. I think functionally, this is where there is a gap between science and expertise in scientific areas and how we communicate that to the public in a way that is culturally competent. And so I strongly believe that one of the terrible tragedies out of the pandemic was that as much as the scientific expertise was brought to bear, it was not simultaneously having people who were expert in communication in a culturally appropriate way for all segments of society to meet that moment. And we're still bearing the consequences of that. I also think that this administration has explicitly decided that expertise is something they want to undermine. And I think every proto-authoritarian regime tries to do that as a way to concentrate sources of authority under the strong man, as opposed to being more diffuse across a variety of different domains. And so that's why having communication and engagement is so very, very important. Yes.
In your previous answers to the question, you talked about the importance of being in, like, having a voice in locality and trying to connect with your local representatives and having movement. You say non-violently, but being in a certain situation where you have a lot of people moving together on a certain topic. And then you talk about how the importance, and going back to the point about talking about the trans community and having the insert, like that small minority and not focusing on there. What upsets me when you hear these certain things and you kind of bring that up and talk about that's the steps that we need to take as a people. A lot of people have taken those steps. For example, I want to point our attention to Palestine. And in this election, it was the #1. And you look at the statistics and you have surveys, and on that statistic, it was the #1 issue that Democratic voters were focused on. Democratic voters, but then also to people who don't identify as Democrats, whether independents or not. But they said, like, the uncommitted movement in itself said, I will vote for Kamala Harris. And then if you have an arms embargo, right? And there are thousands and thousands of people. I went to a protest this past weekend. Thousands of people were outside protesting. And it didn't start with Donald Trump. It didn't start with the Republicans. But instead it started with the Democrats. And when the Democrats were in power, they were still funding.
Look, I grew up in the Detroit area, and Dearborn, very close to where I grew up, is the largest Arab population in the United States. And so from folks back home, I saw very clearly the direction that issue was going. Here's where the messy part comes in. And I'm not saying this is a right answer. I'm just going to give you an answer which I think reflects the reality we're in today. We aren't in a country where there's anything but a two-party system. And I wish that we could talk about, you have gradations, but ultimately on most elections, we have an identified Democrat and an identified Republican. And I don't like lesser of two evil choices. I think that's a wrong way to put it. But I think we end up choosing in a very complex way among two choices. And sometimes we are moving the ball slowly. I think if we had a Democratic administration now rather than a Republican administration now on this particular issue related to Israel and Palestine, we'd have a far different policy that may have been reflected during the Biden administration because of the pressure that's being exerted by the public. I think those who made the choice, personally, my opinion, to vote for Trump or to stay home because of their alienation from what was articulated on this position by the Democratic Party, by many within the Democratic Party, I shouldn't say the Democratic Party as a whole, I think resulted to some extent, I'm not putting the blame, but I think this was a factor in an administration that is doing far worse things in this area than would have been seen under a Harris administration. And so that's hard. And that's where this issue of values versus politics and outcomes comes to bear. And I'm not going to pretend that this is an easy answer. I just think that that's the situation that we're in today.
If I were to finish my question as well about this topic.
Sure.
When we talk about 40,000+ people who have been killed since October 23rd. And then even before that, right? This when you're talking about they're doing much worse. Like the worst has already been done. Genocide was a red line, should be a red line. So not to, make it about my perspective or things of that sort. And we can have conversations later on.
Sure.
We always have conversations, but when it comes to the voice of the people, right? When we have money in politics, when we have the individual voter in itself, of feeling that they have a voice, and they're saying, I'm calling for you all to take this certain stance, and they go to these local representatives, and I'm telling you to please talk to your higher ups, and then hopefully at the top, right? If we have enough pressure from the people without this, when will it be a time where, like when we start having a conversation about a different system, a different two-party system, because it's always the same lesser of two evils.
Sure.
W.E.B. Du Bois talked about it as well back in 1928 something. Malcolm X said the exact same thing in 1968. When is it more of a conversation?
There's a lot of factors that reinforce a two-party system in the United States compared to others. Part of it is that we have a three-branch president and a presidential-based system as opposed to a parliamentary system that rewards proportionality compared to having a dichotomous majority. So I'm happy to take the conversation offline. I'll just leave it at the fact that Democrats lost this last election, I think is causing a great deal of rethinking on this issue. And when people lose elections, it tends to crystallize the mind. And we're going to see it in Pennsylvania, where one of my senators, John Fetterman, has a very different perspective than the one you've articulated. And I'm not saying I agree with this, but that he's likely to face a primary challenge in 2028 directly related to this issue. Yes.
I'm in a master public health program, and I just wanted to know, what are your recommendations for being able to collaborate effectively among the different sectors of education, healthcare, law? We've been talking about this all morning as well. So what do you?
In terms of bringing the sectors together, in a systematic way, or interacting with people who may have different perspectives based on their backgrounds, or both?
I would say both, yeah.
Yeah. Nothing hard about that. I think I'd have to give it some thought to kind of give you a really educated answer. My experience has been that it ultimately comes down to human relationships. There's politics in every single sector of life. And politics is simply how we channel the complexities of human interaction and, coming to decisions. And so if I had to give you a simple answer, which isn't a complete answer, be willing to step out of your comfort zone for whatever your knowledge domain is, or even what your political or cultural viewpoint is, and be willing to engage with people with a different viewpoint, who then will at least you build a relationship there. If you look at the legislation that I have, if you look up the PA House website and you look up my legislation for this session, you'll see that every single one has a Republican co-prime sponsor on that. And I do that for 3 reasons. One is it's, frankly conforms with the views of my community that is often looking for bipartisan support. Second, it's a way to get something actually done, because I need to get stuff through the Republican Senate and to get to the governor's desk. The last reason is that you can sometimes co-opt their rhetoric for your outcomes and values by bringing people of opposing views along. And so I have a big focus on medical debt and on the issue of costs of care. I had legislation that passed unanimously earlier this week in committee to force transparency from hospitals about their hospital-based financial assistance programs. It all started from having 3 Democrats and 3 Republicans other than me on the original bill.
I think we have time for one more question.
Sure.
Oh.
Yeah.
So under this new administration, but even before that, we're seeing sweeping executive decisions and legislations and measures that are having huge effects on healthcare, education, amongst other issues. As a law student, though, it seems like a lot of these battles are being fought in the courts. And sometimes it's easy to feel a little powerless in those situations because judges are not, elected, right? So my question is, how do we engage, or is it even possible to engage with the judiciary, and have you been able to engage with?
Sure.
So
So as a physician, I try to stay away from the judiciary as I can, and thankfully I've largely have. I think it's a fallacy when you look at American history that courts don't pay attention to public opinion. I think when you look at the civil rights movement, when you look at gay rights movement, when you look at any number of issues, I think public opinion preceded judicial decision-making, or at least judicial decision-making was very contemporaneous with that. Obviously, our system of government isn't set up for direct advocacy with the judiciary, but I think the judiciary is serving as an important check on the Trump administration at this point. And the only way to really get around that and to do more is, frankly, I'll throw it back to you. I don't understand how these law firms are kissing the ring in the Oval Office when it is so, I'm not a lawyer, but it sure seems blatantly unconstitutional to say because you represented a client that somehow you aren't deserving of access to the judicial process. And that's essentially what's being said. So I think that we have to, it's incumbent upon us, and frankly, you as a law student, I was reading an article today that there are law students who are saying, I don't want to work for those law firms that are kissing the ring. I think that's a very powerful message, and I hope more people will do that. And I think if we were in a moment where the institutions in society said enough through we the people, there's a lot less damage that could be done by this administration than what we're seeing now. So, thank you so much. I'll be around for the rest of the afternoon.
I feel like we could keep Representative Venkat here all afternoon. Questions. I wish I could, but I am so incredibly grateful for him taking the time out of his busy schedule to share his vast expertise across science and politics, which is very rare and unique and very necessary. So I'm really, really grateful. We are going to transition to our afternoon panels, which will dive into much more depth in some of the issues that Dr. Venkat talked about, LGBTQ plus access to healthcare and reproductive access to healthcare. And for those of you who are just joining us, you'll see these systems maps created by Professor Tamar Pearson Brown before you, also available online, and link in the Zoom chat for those of us who are online. And so again, the idea is to use these to draw connection so that we see that these are not four separate siloed topics, but deeply interconnected. I've got notes all over mine. And so I think it will really draw the whole day together nicely for all of us. So for those of you who are just joining or who just came, that's what you see before you. So we will meet again at 1:45 p.m. So for those on Zoom and those in the room, we'll have a break. And we will start with our next panel, which is on advancing access to care for LGBTQ plus youth. Thank you all so much. Thank you, Dr. Venkat. All right, welcome back. I know everyone's just getting settled back in from the break. We're ready to start with panel 3. That is going to be advancing access to care for LGBTQ plus youth. So we're really delighted to have our moderator today, Professor Andy Wodzinski, who's an associate professor of law and the director of our Elliott Milstein Civil Advocacy Clinic here at American University Washington College of Law. So Andy's teaching, scholarship, and advocacy seek to promote access to justice for litigants who would otherwise lack counsel. In our Civil Advocacy Clinic, Andy supervises students in civil cases involving survivors of intimate partner violence and members of the LGBTQ plus, QIA plus community. He empowers students to grow as lawyers and advocates through zealous representation of clinic clients. We're so thrilled, Andy, that you're going to be moderating the panel today. Thank you for being here. And if you'll go ahead and introduce the rest of our panel, that would be wonderful. Thank you.
Absolutely. Hi, everyone. Welcome back from the post-lunch slump. I'm really excited for the conversation we're about to have with the experts sitting to my right. Before I ask each of you all to just introduce yourselves and sort of where you're coming from for the conversation, I just want to say that I personally and professionally value that there is this space to have a conversation about what it means for there to be access to care for queer youth. This is, of course, as has been mentioned various times today, we have a political and social landscape where attacks on queer people are more and more prevalent, are more and more direct, are more and more harmful, particularly on genderqueer, trans and non-binary folks, and particularly on trans women explicitly in a lot of executive actions, and then in other ways that are impacting the queer community negatively through the defunding of research and science that explores health and the queer experience, and that defunds healthcare, which we know will have a negative impact on queer folks. So I feel privileged to be part of this conversation and to hear more from everyone on the panel today, their information, their perspective, and ultimately, I hope, a sense of solidarity. So I think if we could just go down the row and have each of you introduce yourselves, and then if you could just say a little bit about what fields and spaces you're joining the conversation from. We can start with you. Sure, Carlos.
Well, thank you for the invitation. My name is Carlos Rodriguez Diaz. I'm a professor and department chair in community health sciences at the Boston University School of Public Health. I am originally from Puerto Rico, and I do part of my research portfolio is in Puerto Rico. So as a scientist, I work with communities. My training was in health education and public health. And my inspiration came from working with people that were forced to be part of public health initiatives that were not built for them. As a Puerto Rican in Puerto Rico, experiencing the colonial relationship that we have with the United States, often we receive funding that we contribute to the federal government, but to implement initiatives and public health programs that were not designed for people like the communities that I was working with. So nowadays, my work is with communities, most of the time with LGBTQI populations, and in the intersection of different identities, including my Latino, Latina, Latina community. And we develop interventions together. And the interventions are to improve their health in general, but most of the outcomes that we measure are in access to preventive services, HIV prevention, gender affirming care. And I should also add that coming from an academic environment in health, we're also experiencing the impact of all this good stuff that we have been discussing on health and the termination of grants that are the fuel for us to innovate in the field and to secure a better future, a healthier future for LGBTQ youth.
Harry. Hi, everyone. My name is Harry Barbie. I'm an assistant professor in the School of Public Health at Johns Hopkins. I'm trained as a sociologist. I received my PhD in 2020, but I do very interdisciplinary work now, so generally in the social sciences. Broadly speaking, I'm interested in issues of LGBTQ+ health and aging, health over the life course for LGBTQ+ people, how their distinct life experiences and conditions influence their health over the life course. And historically, I've been really focused on actually midlife and later life, including the transition from midlife to later life. But particularly over the last 5 years, given the profound rise in especially state level policies targeting transgender youth and their access to affirming healthcare, I've begun to transition my work a lot more to focus on that area, better understanding those barriers to care, facilitators, and the myriad positive consequences of having access when you desire access to that to gender affirming healthcare. I should also say I'm a queer person, very proud, and I'm from North Carolina. I grew up in the rural South, which had a huge impact on me as a queer person in terms of the unique types of stigma that I experienced there and lack of mentors and social support systems. And so I put that on the floor just to sort of contextualize myself and where I'm coming from.
Hi, I'm Alejandra Caraballo. I'm a clinical instructor at the Cyber Law Clinic at Harvard Law School. Prior to this, I worked at the Transgender Legal Defense and Education Fund, where I primarily litigated trans healthcare cases. And the work that I do now at the clinic, I advise quite a wide set of nonprofits with the help of students, specifically on issues of digital privacy and healthcare, particularly with regards to stigmatized healthcare, such as abortion and gender affirming care. And some of the things that I've been looking into over the past year or so is particularly telemedicine laws and how they relate to SHIELD laws, as well as investigating the use of prescription drug monitoring programs such as PDMPs and how they are being weaponized against the trans community, particularly such as the case filed by Ken Paxton against providers of trans youth in Texas. It was very clear that they utilized the PDMP program to be able to figure out which providers were still providing care for trans minors. And just kind of the broader dystopian panopticon that is currently being built up to surveil US citizens, especially around health issues. And despite, I think, a lot of misconceptions about HIPAA, there is not a lot of protections out there, and the ones that exist are being steamrolled. And so a lot of concern specifically around that issue of digital privacy.
Hey y'all, my name is Alan Morris. My pronouns are he, him. I am the Director of Policy for the National LGBTQ Task Force. We are the nation's oldest LGBTQ advocacy organization. We are, again, advocacy based. We're working in various states, but Texas, Florida, and North Carolina. And I think one of the biggest goals right now is, figuring out how do we shift the narrative, how do we get the target off of trans folks' backs, right? How do we get our opposition more so in line while also making sure the Democrats stay in line, right? And figuring out what are those one issue voter, problems that we need to speak to in these various state houses and senates and also just Congress in general. So yeah, I'm happy to be here. And yeah.
Hi, everyone. Thanks for having me here. It's such an honor. I've been inspired by everyone's perspectives today. My name is Aura Obando. I use she, her, ella. I'm a physician at internal medicine, pediatrics, and addiction medicine. I work at a small community health center as well as a larger hospital system in the Boston area. My views today are my own. I offer primary care services to socially marginalized populations. So I take care of a lot of people experiencing housing insecurity and homelessness, childhood poverty in general, immigrants. I provide gender affirming care. I provide addiction treatment. And so this is a topic that is really close to my day-to-day clinical work. I see a lot of folks in my clinical spaces fleeing other states where they're not able to access care. We call them gender refugees to Massachusetts. I have derived a lot of comfort from finding guidance from our Attorney General recently, reinforcing our dedication to gender affirming care and guidelines around how to address executive orders. So yeah, it's great to be here.
Thank you all so much. So to start the conversation, there is, sort of picking up on the discussion that we were having in the keynote, there's a lot of misinformation about what it is we're talking about when we say care for LGBTQ plus youth. And so Aura, I'd actually love to start with you from the practitioner's perspective of how would you start to define that phrase?
Yeah, I think there was an earlier comment made about sort of envisioning the ideal world. So what I will talk about right now is sort of an ideal setting, acknowledging that most healthcare spaces aren't built to handle all of this in a routine visit, but ideally it would be. And I think it's important to envision that ideal because that's what we can work towards. But I think there's some guidelines that apply literally to every patient that walks through the door. And so I'll kind of give you a sense of how I approach this in my clinical space. So the first thing I want to make sure is I set the stage in creating a safe and welcoming space. I do that with visuals. So welcoming signage in multiple languages. We have LGBTQ flags everywhere. I make everything gender neutral. I introduce myself with my pronouns. I emphasize confidentiality as well. So I open my visit with saying what my role is. I'm often in like shelter spaces or program spaces. So I make sure to talk about our boundaries between those two organizations and the scope of HIPAA, as well as what I am a mandated reporter for. And so I think that kind of also makes people feel a little bit safer to have that right at the onset to know what it will be maintained private in our encounter. I also really try to use non-judgmental language. I normalize a lot of behaviors that are traditional, like typical for adolescents. And so I contextualize all my questions and like, it is common for many people your age to do this, this, and this. And that helps kind of people loosen up knowing that this is a normal expected behavior and it allows people to ask questions without fear of judgment. I also use trauma-informed care, which means that I acknowledge that a lot of my patients have incurred a lot of trauma in their lifetimes. And a lot of their behaviors and actions and the way they perceive the world is informed by that, and that I do not want to re-traumatize as part of my encounter as well. And I also try to employ cultural humility, which acknowledges that I do not know all the cultural context of my patients, but I'm open and eager to learn. And that I acknowledge that there's an inherent power dynamic in the provider-patient relationship that I try to make less paternalistic or patriarchal in my encounter. And so those are all the strategies I use in that space to build trust. Often it takes a few visits to get to that place where we can have open, honest conversations. I think it's really important to gather data on all patients too. So across the board, we'll capture information around sexual orientation, gender identity, just the way we do with race, ethnicity, and language. And this allows us to really look at our quality metrics to make sure we're offering equitable care across the board. And then it also may elicit patterns of like intersectional needs that may come out as well. And then we screen pretty aggressively for social drivers of health for all our patients. So housing security, food insecurity, transportation needs, material needs like clothing and strollers or whatever the need may be. We screen pretty aggressively for all these things because they definitely impact people's health and well-being. And then I take a complete history, and that really focuses on both risks as well as strengths. I really want to make sure that we build resilience and reinforce resiliency factors. So we know that stigma and societal rejection and discrimination can lead to health inequities in LGBTQ youth. So we see higher rates of mental health needs like depression and suicidality, higher risk of substance use, and then higher risk and disparities of health when health outcomes is related to STIs and pregnancies. And again, I just want to reinforce that this is not something intrinsic to the child or youth in front of me, but rather the structural issues that drive these disparities. But we also know that youth in supportive and affirming families and communities and environments and schools have great potential to lead happy, healthy lives. And so we really want to identify those positive protective factors as well and reinforce them. And if they're absent, to try to create some, even if it's members of our own clinic being that healthy role model for a young person. And the last piece I'll just say is we try to really create our clinic as a one-stop shop so that we're not referring out to the community and forcing people to kind of build that relationship with each and every encounter. So as much as we can offer out of our medical home, we do. So in our primary care visit, we can address needs around contraception, gender affirming care, addiction treatment, housing needs. As I mentioned, our case managers work really hard to address some of the needs around like people needing to replace lost or stolen IDs, which is a great barrier to a lot of needs, whether with housing or even picking up prescriptions sometimes. And so we really try to kind of center the medical home as a one-stop shop as much as possible, as well as mental health needs. So we have a robust behavioral health department that we refer to as well as needed. And then we really try to know our outside resources as well for those we can't offer in our clinic. So for instance, legal needs, housing needs, things like that. And then the last piece I'll say is that I emphasize that sexual and gender diversity is not pathology, even though the medical system is set up to sort of pathologize people's identities. And so I try really hard to avoid that where I can. Sometimes to get something covered by insurance, I have to put a pathology in the chart, and I always am really transparent about why I'm doing that. I want to celebrate trans joy when it's there, and it really bothers me that I still have to put gender dysphoria, even if there isn't anything, if there isn't dysphoria, to get something billed. And so I'm just really transparent about that, why I'm doing that.
So I'd love to hear next from Carlos and then Harry from your vantage point and from the public health perspective, how you all would start to sort of fill in the term care for LGBTQ youth.
I always like to ask the participants of our research, the communities that we work with, what is that you need? And to me, that's a starting point of what is the care that we need to provide. And in healthcare, nowadays, we are doing more and more research that is comprehensive of the social circumstances, or what we've been calling the social determinants of health. So care for LGBTQ youth includes addressing housing, their relationship with their peers, family, studying stigma and how we can reduce the negative impact and stigma has on their health and well-being. With kids, we also talk about politics. Kids understand the politics that we're living. And nowadays, part of doing our work to promote their health is to, on one hand, protect them from what is happening in the world, but also recognizing their agency and how much they can work with us in having a better future, which is, it would be their present when adult. And following to what the colleague mentioned, from the research perspective, I do community-based participatory research. And with that approach, we ask, again, what is that is needed so we can provide better services? And on one hand, I can see sometimes where a clinic with many LGBT or pride flags might attract some people. I have worked with populations that are looking exactly for the opposite because they are afraid of the stigma or the discrimination that they may feel if in their communities they're seen getting to a clinic that is self-identified with the LGBT community. We also address the intersection of our cultures, and language tends to be a significant barrier. There is very little research that we conduct with youth that is consistent with their language. We traditionally do research in English and then translate. Like the translation is a cultural adaptation. So we advocate for more research that is developed with really the cultural needs of the population. Most recently, we developed a project that the youth work with us in developing an e-health intervention and app. And rather than working in English and then translating it into Spanish, we work simultaneously with kids that were monolingual Spanish speakers and those that were English speaker. And we learn together. We believe that that made the intervention even better. We finished the trial and now we can say that the intervention actually worked. And lastly, in research, another important element in looking for the care of LGBTQ people is consent. I'm not going to talk about the law in a law school where in an area that I'm not trained, but commonly we have to ask for parental consent to have kids participating in research. But when the research we're doing may increase their vulnerability by asking the parents to allow them to participate in a study that is for queer people or related to HIV or some sexual behaviors. We have fortunately identified through research that parents most of the time don't care about their kids consenting to participate in a study if the study is for their well-being. We conducted a trial and we got questions from parents. Fortunately, NIH, this was funded 10 years ago. We were able to do the research without parental consent because we demonstrated that parents wanted that kind of intervention, that the kids knew what they were getting into. And of course, we provided information for parents if for whatever reason they found that their kids were involved in research. All this to say that care should be centered in the experience of the kids. We can build with them. And even when we develop research for them, their participation is fundamental. They have the expertise and we should be facilitators of that expertise and work with as partners. And as scientists also recognizing that we can be very, we can threaten the process. We are not easy to work with. I would say, I think I'm easy to work with, right? But historically, we have imposed our knowledge. And if we were to develop things that can be owned by the community, by the kids, and we have to let them lead.
And Harry, what would you add here?
Yeah, I mean, those were both really great comprehensive answers. So maybe I can add on by saying a little bit more about why all those things matter a bit. So for instance, we heard a lot about things, what affirming care or LGBTQ plus care looks like in a clinical encounter. Things like using correct names, pronouns, having administrative and identity documents that reflect the experiences of patients, using symbols like flags, having appropriate medical literature, health literature. Why do those things matter? Well, there's research that shows that even when LGBTQ plus people perceive, setting any sort of objective markers aside, just when they perceive their providers to be affirming of their identities, they have far better health outcomes and particularly preventative health behaviors. So some research that I've done, for instance, folks are more likely to have an annual checkup. They're more likely to get HIV, STI testing. If they have mental health conditions, they're more likely to stay on top of those health conditions. So there's a variety of benefits just if a patient perceives their provider to be affirming. Of course, social determinants of health matter enormously, in part because they disproportionately affect LGBTQ plus people, whether it's issues of homelessness or estrangement from families. These are issues where we see vast inequities and inequalities for LGBTQ plus youth. And another thing I'll say about what is LGBTQ plus care, I think one answer is to sort of look at how it's currently framed in popular culture. And there's a lot of rhetoric right now that sort of frames LGBTQ plus care as only like gender affirming surgeries. And that's a dominant narrative right now that creates a lot of barriers, I think. Now, if we just take gender affirming surgery on its own, the research is very clear that for those who desire those kinds of services and have access to them, the health benefits are profound. But that's not all that LGBTQ plus care is. And in fact, I think we're seeing a political effort right now to pigeonhole LGBTQ plus care as just gender affirming surgery. Some of you may be aware that recently the Trump administration directed the NIH, obviously they're defunding trans healthcare or trans health research rather, but they recently directed NIH to focus funding on studying regret and detransition among trans youth. Now, from my perspective, as someone who studies trans healthcare, trans health outcomes, I think it's valuable to study the full spectrum of trans health outcomes, whether they're positive, negative, complex, but framing them in such a way that ignores the profound benefits, well-documented benefits of access to gender affirming care, and including gender affirming surgeries in particular, is very dangerous. And so I think it's also important to consider sort of how that is framed within the current political rhetoric.
It's really helpful to start to fill out what we mean when we talk about access to care for queer youth, and particularly to avoid essentializing in the ways that you were just talking about, Harry. I guess I want to turn now, because we all know and have recognized that in the current legal and political landscape, there are a lot of emerging barriers and threats, or the resumption of acting upon those barriers and threats. So Alejandra, I wonder if I could turn to you to start to talk about the legal landscape with the acknowledgement that can be a tough thing to talk about.
Yeah. So one of the biggest things on the horizon right now is the Supreme Court case Scrimetti, or US v. Scrimetti, which arose out of Tennessee's ban on gender affirming care. The central question in that case is effectively, what is the standard of which claims of discrimination against trans individuals are brought under the Equal Protection Clause, whether or not they're brought under a heightened scrutiny standard or just rational basis, which means the level of scrutiny that the court applies. Essentially, if the Supreme Court sides with the state of Tennessee in that case and basically says that trans people, either under the basis of sex discrimination or under transgender status, are subject to rational basis review, it would greenlight pretty much all of the discriminatory policies that this administration is pushing forward without much of a constitutional check. So by June, we'll know where we stand on that aspect, and effectively, if it's a loss on that end for the plaintiffs, it's going to meaningfully impact all trans individuals, and beyond that, any person who is gender nonconforming, any queer individual. It's going to be used very broadly on that end. So I'm very much dreading that potential decision. But I think we also have to take a step back and see like what the administration is doing. And I think there's been a lack of focus or understanding of how these executive orders have been utilized, especially with the rapidity and the number of them. But specifically on the first day, on Inauguration Day, Trump signed an executive order called Defending Women from Gender Ideology Extremism's ridiculous title. And basically the way that they define the nebulous term gender ideology is essentially acknowledging that trans people exist, even acknowledging their existence at all. They basically define it as a existential threat to women to acknowledge that trans people even exist. And one of the sections in there specifically says that federal funding cannot be provided to any agency or any entity that promotes gender ideology. So what do they mean in practice? And in practice, it means, do you acknowledge that trans people exist and do you work with trans people? And what effectively they're going to do, and what we're starting to already see, is that they're going to defund from getting any federal funding, any entity or organization that works with trans people, and even acknowledges their existence. And so this would include Medicaid and Medicare funding. And we've already seen on NIH, they've basically canceled anything that has the word gender in it. CDC funding, basically all of that on the healthcare side, and then on the education side, student loan funding, educational grants, Title I funding under education for low-income schools. We're seeing all of that threatened. I mean, Maine is having agriculture funds defund, like over trans sports at the state level there. But this is going to be wide-ranging, and we're going to start to see this on basically any NGO that receives any sort of federal funding. We saw the National Center for Missing and Exploited Children was forced to remove all references to LGBTQ youth in any of their external facing materials and internal facing materials, or they would face a complete ban on federal funding, which over 85% of their funding came from the Justice Department. They would basically be insolvent. They did it on a Friday evening, and by the Monday, they scrubbed everything. Same thing with RAIN, which is the rape, abuse, incest network. They similarly were forced to scrub, and we've seen a lot of organizations essentially scrub all references to LGBTQ people. And so at the end of the day, what does this mean? It means the wholesale eradication of the acknowledgement that trans people exist from society. And the next step, I believe, beyond that is going to be the revocation of 501c3 status for any organization that works with or defends trans people. And we've already seen essentially law firms who have made a corrupt bargain with this administration, a very cowardly one, and is one that I have very strong feelings for the firms that do this. Some of the firms like Wilkie Farr Gallagher, which I previously had co-counseled with when I was at TILDEF, they worked on some of these trans cases and co-counseled with the ACLU, TILDEF, and some of these others have co-counseled previously with the ACLU and these other nonprofit orgs. Effectively, what it's doing is going to cut off all of these nonprofits and others from being able to challenge these policies in court. They will not, if they pass these bans, none of these organizations are going to be able to challenge it because they're not going to be able to get lawyers to actually help co-counsel and represent them. Additionally, they're agreeing to these pro bono services, so they may actually be in court defending the administration's policies. And then, so it's depriving the community of even the basic necessity of legal counsel to fight these policies. And so, they can't get NGOs like the ACLU and others defunded because they don't accept federal funding. So the next step is to revoke 501c3 status. And I fully expect that that's going to happen at some point. The preview of that was the public service loan forgiveness, which they said they were going to not allow public service loan forgiveness for any organization that advocates for trans youth. They can't do that under current student loan requirements by Congress. It basically says it has to be any 501c3 is inherently qualified for public service loan forgiveness. That's in the text of the statute. So how do you get around that? You revoke 501c3 status. It's exactly what they're going to go through next. And so I think people need to understand that the moment we're in, this is a wholesale effort to eradicate trans people from society. And they view queerness as inherently deviant and something to be pushed out of society. And if you can't convert through conversion therapy into what they view as heteronormative, then they are not only like willfully through neglect pushing these kinds of social determinants of health, they're going to amp them up to 11. They're full-scale defunding all of the HIV prevention programs. They're defunding all studies into LGBTQ health so that basically when all of these negative aspects start happening, we won't know about it. We'll be flying blind, not knowing exactly what is going on in these communities. And that is by design, because You can't litigate these, you can't fight back if you don't have the data, and if they're not collecting the data, then it doesn't exist. And so part of that is, and I don't use this word lightly, a lot of the people in this administration are eugenicists. They really do want these kinds of social determinants of health, if they are amped up to 11, to essentially destroy these communities. If it's HIV, if it's poverty, if it's all these things, and we're going to see a confluence of these kinds of factors come to a head as the economy begins to collapse over the next few months. Sorry, I'm like not the most cheerful ball of joy right now, but I think people need to be realistic about the moment that we're in. The kinds of things that we thought were possible a few years ago are no longer possible in terms of the kinds of studies and progress, and everything for the next at least 4 years is going to be scraping and clawing to just keep the meaningful little bits of progress that we were able to get over the past few decades. And I think that's the kind of fight that we have to prepare ourselves for, because the kinds of things that we thought we could fight with, either through the courts, either through research and better data and all of these things, they're basically already at war with those things. And we're going to have all of those tools slowly removed to fight back with.
And Alan, when it comes to access to care for queer youth, what are you seeing in the sort of political and advocacy spaces that you're working in?
Congress is fun. Congress is really fun. I mean, even just listening, to my sibling talk about some of these things, it's in our name. Everything that they want to defy with the National LGBTQ Task Force, right? They want to make it illegal to be trans, right? Something that we're seeing, or my job is especially hard right now because, and the bill that she's, speaking of is HR 9495. You're on your computers, Google it, HR 9495, right? I have to now figure out, how do I go to Congress and have a conversation on both sides of the aisle? One, holding Democrats in line to make sure that they do what they are the party of. And then B, not piss off a Republican and have them put us on the list. Because if we're on the list, we're going to be the first ones up to get that 501c3 taken, right? And then we also have to look at, how do we leverage our C4? Because our C4, we have a little bit more flexibility to say some more things, to be a little bit more direct. But more than anything, y'all, we have to approach a lot of these conversations from a place of principled struggle. And I'm not sure if you've heard of that, but it essentially means we may not agree on the tactic. We may not agree on the community that should be seen as number one, but we're not your enemy. Right. And I think that's part of the larger issue, even just with the movement. And I'm pretty sure my sibling can tell you, like, having these conversations with various organizations for us to figure out, how can we come to the table to come up with something to fix it in these, various moments when they do try to offer us something, when they do put that, wait, can I cuss? Yes. Sorry, y'all. I'm from Houston, so I feel different, okay? So even when they throw this, raggedy Equality Act in our face for the 15th time, right? That's not solving our problems, right? But on the opposite end, we still have to see that folks want to approach things from a bipartisan place. I have to show respect and reverence. And I have to understand that I am existing in a world as a Black gay man from the South, but a Black trans woman from the South is seeing this world totally different, right? And I have to be able to hold the both and some of those, things. And it also, turns into a situation where what is going to be the resolve for us in this moment? It's not even 100 days and look at all this shit, right? Like, I am constantly on edge trying to figure out what we say, what we do, and how we respond in this moment, simply because, yes, you lovely lawyers, y'all are gonna go out there, you're gonna sue, it's gonna be an injunction, but what the hell do we do when we have a president that says, I'm not going to get the person who I just deported, and SCOTUS said, bring them back. I'm not gonna do it. How do we push back against that, right? How do we push back lawmakers who are literally kissing the ring? They do not care. But you know what? We've been successful because you know what works? Those faith leaders get up in there and start talking. We start pushing back and having those letters written, right? We have some sit-ins and we have some intentional conversations to let these lawmakers know that their decisions have to humanize people at so many different angles. But to be completely transparent, even sometimes that doesn't work. And some days, you know, like today, after I leave here, I'm gonna go home and roll my eyes because Monday, I don't know what I'm going to say about what just happened where the president, who is supposed to be the leader and is supposed to follow the rule of law, is clearly saying, I'm not going to do it. And he's packed out SCOTUS, so no one's necessarily going to push him.
So I want to take us to try to think about some bridges and collaborations as we're hearing more about the struggle, right, in these various ways. I guess before we talk about that, I'm wondering if anyone can just speak to when we have these laws, these efforts, these political narratives that are anti-trans, anti-queer, right, disaffirming, erasing. What is the impact of that on queer youth who otherwise would be trying to seek care? Is anyone able to speak to that?
I would say first, we need to lean into our trans leadership. I mean, and that's something that a lot of folks, they say it, but a lot of national orgs have to do better with making sure that trans people are able to lead the movement and say what we're doing, because that's going to benefit the next generation, right? I also think that there's a multi-generational issue happening where younger folks want to burn all this shit down and older folks are like, we've already been here, we've already gotten through it, and we've lived through worse, right? And they're not connecting. So figuring out how we connect with the youth in certain ways. Do any of you all know Miss Major? Google, get on those computers and start Googling. Miss Major was present for the Stonewall riots, right? When you hear someone say the civil rights movement, they cannot talk about the civil rights movement without the Stonewall movement, right? And Miss, I had the pleasure of going to her home a few weeks ago, or going to the Oasis. It's a place that people can go to seek respite, but I could not rest because we have an asshole in office, sorry. And I asked her, what was it like during those moments? And something that she kept telling me, she was like, I wish I had more younger people standing next to me, right? So how can we welcome more younger folks into the movement to listen to what they want? And how can we embrace something that feels a little bit uncomfortable for us, something that makes us swivel in our seat, similar to when we start talking about racism, some of the white folks, they still get a little offended, right? When we talk about trans people leading, some folks still get a little bit offended and they swivel, right? But if that's not who you are on the inside, it shouldn't cause you to swivel not one point, right? But that's my take.
So Aura, I wonder if I can turn to you on this. You know, what do you, as you're hearing these kinds of policies that would essentially cut off the ability to do the kind of affirming care you described at the outset of the conversation, what would the impact of that be on the ground, do you think?
I'm already hearing a lot of distress as people are hearing in the news what could come down the pike. There are a lot of youth that are terrified about what will their access be to medications or surgeries down the road. There are different, strategies being used right now to try to plan for that or prepare. People are trying to, stockpile meds just in case, which is not necessarily a safe thing to do, but I understand where it's coming from. People are asking for referrals for surgeries that they were hoping to have down the road, but are worried their access may be limited. And so trying to kind of get it while they still can. There's a lot of fear, and I do see increased rates of anxiety and depression, higher scoring on our screeners as related to the political environment. It's definitely led to a ton of referrals to our behavioral health department, and as you know, in the community, the wait lists are quite high. This is care that's really hard to access, and it's becoming even more so as the need is escalating right now. People are afraid about their access to be able to change their documents. These are already causing issues as we take care of our patients. So people aren't immune or deaf to what's happening on the outside, and it's already causing a great deal of distress. And so, when I hear what's at the higher political level, I feel that fear too. I don't know if you all had that while Alejandra was talking, just the crushing feeling. And it can be really paralyzing. And so I think for when I feel that, I try to really refocus on the care of the person in front of me and become their advocate, because that's really tangible to me. And so I always center back with the youth and you are safe in this space. We will do what we can. There are organizations that are putting aside grants and donations to have a source for hormones if needed, if Medicaid is cut off. So I'm telling the youth what is already being put in place on a safe way, so to try to kind of reassure and create safety. But I feel where it's coming from.
So turning to Harry and then Carlos, I wonder if we could start to think about some of the bridges or interdisciplinary collaborations to, as best we can, start to meet some of what we're talking about here. Harry, do you mind starting us off there?
Yeah, I mean, so right now I'm as the representative referred to earlier, I'm really just trying to think locally now. I think before I had a much stronger focus on affecting change federally. I don't see myself having those opportunities now. So a couple things I'm currently doing. So I live here in Washington, D.C. There are a lot of community organizations led by LGBTQ plus people who want to partner with folks like me, with researchers, investigators, and I'm looking to build those partnerships. But also local policymakers too. I've had a lot of policymakers in DC interested in learning about what they can do to better serve LGBTQ plus youth, including trans youth. And then practitioners as well. There's a lot of research that shows that generally speaking, practitioners, healthcare providers really want to do right by their patients, including trans patients. But so often they don't feel like they're knowledgeable enough or have the resources to do so, have the skill set to do so. And so I've been engaging a lot more with practitioners, holding workshops for them, helping them better understand that they too can practice affirming care, even though they're not, providing gender affirming surgeries or, hormone therapy. But that affirming care is very expansive across the health spectrum. I'm trained as a sociologist, and I'm just saying how, when I was receiving my training, I was sort of taught that it's sort of, best to publish single author publications and, just work with other sociologists. And that's been a mindset that I've really started breaking out of since I've entered public health. I work a lot with, as I said, medical providers, psychologists, social workers, to just ask better questions and generate better answers.
Carlos, what are your thoughts?
Well, I would like to start by acknowledging that if we have a privilege, we should use it. Not everybody can be on the front line all the time. And some of us might have the opportunity to be in that place because of who we are, where we are, what we know. So we should dismantle the structure of privilege, but in the meantime, let's use it for something better. I also want to mention, following what Aura was mentioning, the fact that we are seeing people migrating within our LGBT communities. People are either leaving the country, planning to leave the country, or we are seeing internal migration. People moving to states and cities where they feel that they are going to be better. So with that, we will require collaborations across the board. Lawyers and public health authorities have to work closer than ever to secure that we can provide the services that people need while we comply with the law, or if the law is not consistent with the best clinical or public health practices, to see how is that we're going to challenge that process, because health should be the main goal. Another mechanism that was mentioned earlier today is medical legal partnerships. We are currently testing a model with Latino communities in 3 different cities. And what we are seeing is that the traditional way that MLPs have been implemented have focused on an individual, their healthcare needs, their harm health legal needs. But now we're seeing families. And the issue is affecting more than one individual. So how do we screen the family? Not only the individual that is the client or the patient. Technology is going to be fundamental as we build coalition in our response. But at the same time, there is a lot of legal aspects behind technology and how we can use it. And the issues of trust are going to be affecting how we can integrate technology in our initiatives. And for others here or in the audience that are researchers, we don't have to be only academic scholars or researchers. We're more than that. I often describe myself as a research or as an academic activist, because I grew up being an activist and ended up being in academia. And research is a tool that provides us the information to advocate, to make changes. We don't need to be afraid of engaging in activism. And lastly, and I was pleased to hear somebody in politics talking about working with their own community, knocking at doors. I think it's important that as part of building bridges, we talk with people that disagree with us. We need to facilitate conversations that are going to be complicated, uncomfortable perhaps, but if we want to see a close in the gap and the polarization that we're seeing in our country, we need to have those conversations.
So Alan and then Alejandra, I'd love to turn to you both to hear, this is a dark time for queer people. And Alan, you talked about principled struggle, but I wonder if you could speak a little bit more of what you think of or what it means to you to engage right now. And I'm just going to end the question there, actually.
Do you want to go first?
You can go.
You can go.
Yeah, I mean, I feel like I've spent the last few months, especially after the election, reading just about every book there is on authoritarianism and like trying to understand this moment and like how that places us in the broader context. And I think the thing that I keep coming back to is like the United States in particular, I think we've been so isolated in some ways from the broader LGBTQ struggle worldwide and globally. And I think one of the things that we have to learn from one of the things that we have to really learn is that these struggles are not just isolated to the United States, and we have to learn from other folks in Russia, Hungary, Poland, Turkey, India, Brazil, all these other places that have faced similar hybrid authoritarian regimes, and how to kind of combat this illiberalism that particularly tends to focus and attack LGBTQ people and how to survive and thrive within those circumstances. And, I think kind of going up to the broader point, I think we also need to expand like what that means and the scope of what the movement needs to focus on and do. And for me, I think in the immediate aftermath of the election, I did an interview, and one of the things I said is like the primary thing we have to do is survive. Like they don't want us to exist. And every day that we do is just a giant middle finger to them. And so I keep saying to people, your job for the next 4 years is to survive by any means necessary. And I think that also like, as you were saying, like earlier, the people are fleeing. I know families that have already fled the United States because they have trans youth and they were worried that effectively that care will no longer be available. I know several trans people, high profile trans people that are making plans to leave the United States or are in the process of currently leaving the United States. And I know others that have already left. And that's kind of the unspoken reality that is really happening right now that's not really talked about, but there is a full effort of essentially of people leaving the United States. And I think part of that is, I think there's a lot of complicated conversations about privilege and being able to leave the United States, especially people with disabilities, because the way that immigration law works, it pretty much discounts the ability for the movement of people with disabilities. But at the same time, we have to understand that, these kind of classic ways that we apply these academic frameworks of privilege and other things, sometimes we haven't applied them in the context of, we need our community to survive, right? And like, we need people to build these bridges. And so I think some of it is like understanding we may need to like help fund and build these pipelines to get people out of the United States. And I think that's a conversation that a lot of people aren't prepared for, because I don't think they've ever thought of that framing of like the United States as a place that we may have to flee from. But that's the kind of reality that we're facing. And I think, if you have those connections, you have folks in other international places in the EU or Canada or otherwise, like maybe the best thing you can do is help facilitate those kinds of exits out of the United States. But, and I think at the same time, still fight for the people that are here, because not everyone's going to be able to leave. And so I think really the focus that I continue to kind of turn back to over the struggle for the next 4 years is survival. And I think it's a place where our community has been before, obviously in the 80s and 90s during the AIDS crisis. Really, like, survival was like the most important paramount thing, while like the treatments were being researched. And I think for here, it's like, it's not necessarily a virus of like biological origins. It's one of human origins in terms of like this virus of hate that is like spreading, and the elimination of empathy within our society, and this elevation of cruelty as the cultural currency. And so I think really the thing that we need to focus on, again, and I'm going to hammer it again, is survival. You need to survive.
I think, so I just got back from Texas this week. We were working with a trans-led organization that's pushing back on some of the anti-trans legislation in the Texas House. And it was refreshing to see the level of people or the number of people that were there and the level of synergy to remain in conversation and principled struggle with what was going on, even if they didn't necessarily understand it. And I think for me and the organization, I'm gonna try to keep this very C3 friendly because this is being streamed. We have to figure out, how do we keep people engaged to be able to show up at the ballot box for the midterms and for the next election? Because so many people have clocked out, right? So many people are tired. And just like she said, like, people are fleeing. They're leaving. So what is it we can do to keep people more engaged and ready for civil service, and not just at the federal level? How can we change things at the local and state level so we can see the reality of universal health care that is based on the county, and we don't even have to worry about something happening at the federal level, other than people probably having to sue them because they're trying to infringe on it. But that's a whole nother conversation. But figuring out ways that folks can have what they need, and they don't need to rely on the federal government to come in and say what's right and wrong. And that is really going to start with folks being more engaged at the local and state level. And then I think the last thing is giving people grace. If people don't want to do it, hey, they just won't show up, right? Something that I told someone the other day was, I'm hoping that as people are checking out, that they're passing on the legacy to someone that they trust, right? So, so that way that spot isn't missing and someone is there for them. And I think that's really important, especially for the next generation, right? Because they're coming and we have to get in line because they want to burn all this shit down. I was having a conversation with my grandmother, and my grandmother was just like, you know, I just don't understand this new generation. And I said, well, grandmother, the same way you didn't, you don't understand me, I don't understand half the things that I'm hearing either. And I'm 33 years old. But I'm like, one thing I do know is there is a strong commitment for people that we would often see as different or we didn't like understand them, for them to have the limelight and to be seen just as much as anyone else, and for folks to humanize these issues as much as possible.
So I want to leave a bit of time for questions for the panel, but just to sort of, before we move there, we started by sort of talking about what it means to think about care for LGBTQ youth. And it's hard when the threats we're discussing are so existential not to talk about everyone that they impact. But I wonder if either Ara or Harry or Carlos, if one of you might just talk a little bit about what it means to engage with queer youth in the healthcare space right now to you. Ara, would you mind speaking to that?
Sure. Yeah, no, I mean, I think I mentioned I'm caring for a lot of populations that are under attack right now. So this is, affecting day-to-day work at this point. I really put a lot of effort into building trusting relationships and affirming safety, at least within my clinical space. I collaborate a lot with my colleagues in the legal sector, in the policy sector, to really try to advocate on behalf of patients, either individually or on a larger scale, at the state level. And I'm very vocal about my politics in my clinic space, which is sort of taboo, right? Like, I think we're not supposed to do that, but I think it's really imperative that my patients see me as an ally and know that that I'm working on their behalf. And I think that helps me in my own coping also, to be like an advocate at all those levels, at the individual level, in the institutional level. We didn't really talk about that too much, but you'll Google your clinic and health center and hospital. I bet they've taken down their gender care pages or immigrant health pages. They're all coming down. There's so much fear and paralysis. And the end result of that is this capitulation, and then kind of collusion in these erasures that are happening. And so there's a lot of advocacy to be done at the institutional level and at the state and federal level. And it can be overwhelming. So I also do a lot of self-care, but I do want to make sure it always goes back to the person in front of me. That's my commitment, is to the patient. And I want them to know that.
Carlos, did you want to add to that?
Well, on a different note, I will just say, let's protect joy. Joy is a way of persistence, and we deserve it, and the young people deserve it. But let's work with joy.
Thank you all so much for that conversation. I'd like to we have a few minutes. We have about 5 minutes for questions for the panel.
So I read Erin Reed, and she's been spotlighting what's been happening in Montana, actually some good things out of a very red state. And so I just want to hear some of your thoughts on that. I think, Alan, in particular, since you do policy work, is that unique? Is that something that could be replicated and built elsewhere? What do you think about, that actually, there's representation in the state legislature, and then there's as Dr. Venkat talked about, bridges being built, and the personal stories and the personal relationships seem to be making a difference there.
I mean, shout out to Erin and Zoe. They're doing such great work. And this is not new, right? We've been winning in so many different ways in so many different states. It's just that the negative things are more advertised on the news. So my concern, and something, is probably why a lot of people don't want to invite me on their shows, is because I'm going to push back on the media for their lack of advertising and discussing the wins, to give our people joy, to give our people some hope, and to know that it's not all these negative things that we're seeing, right? Or something that I love that Erin is doing is whenever Mr. 34 Counts signs a executive order, like it's very clear, just because they sign a EO, it is not law, right? And it gives people a little bit something more to look forward to. I mean, but then also, I mean, to me, I consider that the Bible Belt. So what I've been wondering, and we're hoping to have some conversations with Aaron, is how are they engaging with legislators in the middle of principled struggle, right? Because it's a lot of religious communities that have very hardcore views, but also they don't want to see people being mistreated, right? So you may try to throw some, oh, well, this is what the Bible says, this is what I should be doing. But then when you're contradicting it with treating people, any kind of way, there are some really good people in this world that are like, no, I'm not gonna let you use that as a tool to spew hate. So that's what I'm saying.
I'm good friends with both, and I've been able to have like an inside window into some of this. And, I think part of it is just Zoe is just phenomenal. And like, I would keep an eye on her for like in the future in terms of politics, because I think she is like a rock star on that end. But I think part of it is like what you're seeing is kind of a real life effect of like the polls that show that, when somebody knows a trans person, they're more likely to support policies that protect trans people and not support kind of these anti-trans policies. And I think part of it is like Zoe is friends with a lot of these legislators and has gotten to know them personally, has gone to dinner with them, and has been very personable. And it's much, much harder when these kinds of bills have a tangible impact on your colleague in that way. And I think a lot of it, as well as it speaks to Montana, it's a state that has been very astroturf lately. A lot of people moving in that don't have roots. I mean, the new senator there, Senator Sheehy, like didn't even live in the state like a decade ago. Like he's a carpetbagger. But these people have come in and like are demanding the like radical changes in Montana. And Montana is like almost a radical libertarian state. They're like, we just don't want the government telling us what we can and can't do. And so that's been part of it. I think there's been kind of a reaction to that. And like all of these bills are coming, like all of the people testifying in favor of these anti-trans bills are from out of state. Most of the time they're being flown in or they're testifying via Zoom because they're nowhere near the state. And I think that that's a dynamic that used to work really well up until about 2 or 3 years ago, because it was still the same dynamic. It just that these policies got so nationalized that no amount of personalization or anything else has been able to be effective. But I think Zoe has just been able to be way more effective. And I really hope that Congresswoman Sarah McBride takes notes and follows Zoe's example, because I think her, like McBride's attempts have not like been as fruitful in that sense, because I think she's been trying to follow the more classical, like West Wing style politics. And I think that kind of politics is dead.
But we are proud of her for
Yes.
that. We are proud of her for that.
Yes, in the back.
I just wanted to commend all of you for your incredible work in keeping as somebody who was like coming out during the first Trump era, and that was terrifying. And imagine people trying to come out now or trying to be themselves. I just also wanted to ask about like, what are some potential opportunities that you think about engaging like parents, about educating them or learning how to protect their youth in general in this climate and local, state, and community?
No, let's just take that one.
I mean, I'm a big proponent of PFLAG is like my go-to resource. I think they do incredible work. We rely a lot on our local PFLAG, and that is definitely my like recommendation for supporting communities, building communities for parents and providing support.
And I will only add that as we continue to do demonstrations and organize, we should remember that we're working with families as well and create spaces for family to have a sense of belonging in the different activities that we have.
I just want to add something. Whenever I hear someone talk about parents and LGBTQ youth, I think about myself, because I wasn't raised by my mother or father. I was raised by my grandmother in a highly Christian home. But something I realized is my grandmother was only what was poured into her. So once we change that thought process and approach it from a sense of how can I have a conversation that can give her a little bit of empathy, but not let the homophobia or the transphobia thrive, because I don't want to harm myself, and start the conversation.
Can I just say real quick, and to that point, like some people, parents, guardians literally do not know how. And so I think like raising up stories of parents and guardians who show support and affirm and love their children openly and proudly, I think highlighting and putting those stories in the spotlight is so important right now. Yeah.
Can you see some comments on sort of the flipping of like the weaponization of child abuse laws where parents' rights are being denigrated to call getting medical care, gender affirming care for trans kids, child abuse, and then when it's convenient for the dominant political narrative, but meanwhile, like in every other scenario, it's like parents have the rights to dictate everything.
Yeah. I could quickly add to that. Montana actually just helped kill a bill that would have made it basically like felony child abuse to take a child out of state to get gender affirming care. And we're seeing increasingly it's a copy of some of these other bills like trafficking minors for the purpose of seeking an abortion. So similar, like that's where they're starting. They really start these broader limitations on patient autonomy, particularly with minors, and then they start like broadening them out. But Florida already passed a law that basically creates a negative inference for providing gender affirming care for if a parent is supportive in child custody proceedings. There's one in Texas, like one of the worrying ones is like they're trying to modify the there's basically a uniform family law act that basically all of the states have adopted. I think it's like 47 something states, and they basically established like the child custody settings and like who has jurisdiction. And what they're trying to flip essentially now is that they're allowing for like emergency jurisdiction in certain states like Texas or others that are trying to push that so that if like you're visiting or you're even driving through the state, like another parent could immediately emergency petition to remove child custody from a parent who's affirming of a trans youth. And we're starting to see the opposite. And of course, like this is like accusations in a mirror, because the ones where they're trying to say you like the bills that are passing that are providing protections that says you can't draw a negative inference from providing or affirming, not even saying like tipping the scales towards a positive inference, just saying you can't take it as a negative one. They're saying that these are kidnapping bills in like California and Colorado and whatnot. But what they're actually doing in these states is actually tipping the scales. And yeah, that's something that I am like deeply worried about. And it's one of the things that I would keep an eye on from the federal government, because they provide a lot of the funding for these agencies. And it could be very easy for them to pass an executive order, especially there was a proclamation around not the Child Abuse Awareness Month or whatnot, that basically half the proclamation was about considering gender affirming care for trans youth child abuse. And I fully expect that an executive order will come down, leveraging federal funding to direct state agencies to investigate the families of trans youth.
All right, well, let's join me in thanking our panel again for this.
Thank you so much, Andy, and thank you all for your courage in speaking out today and for an absolutely fabulous discussion. We have a very short break now. We are going to start our last, but definitely not least panel on adolescent access to reproductive health care post-Dobbs at 3:05. So we will see you all then. Thank you. Thank you all for staying with us. It has been a very my head is spinning and my map has all kinds of arrows on it, and I'm so glad to wrap up with our final panel. But before I do, I just want to give a special shout out to Asha Shelzo and Tamina Asif, who have really made this day happen. So a special thing. Asha's going to wrap us up at the end of the day, but I want to give them a big thank you. Our final panel will be on adolescent access to reproductive health care post-Dobbs. And I am so grateful and thrilled to introduce Professor Jamie Abrams, who will be the moderator for this panel. Professor Abrams directs the Legal Rhetoric program that introduces first-year law students to legal research, writing, analysis, advocacy, and citation. She teaches courses in legal research and writing, torts, family law, legislation, and gender in the law. Her scholarly research focuses on reproductive and birthing decision-making, gendered violence, and legal education pedagogy. She has published numerous books, chapters, and articles in these subject areas. And most recently, she is the author of the fabulous book, Inclusive Socratic Teaching, Why Law Schools Need It and How to Achieve It. Jamie has also been recognized for her innovations and excellence in teaching and pedagogy. Thank you so much for considering.
Thank you all for being here. I want to give one extra shout out to the students. It's a Friday at 3 o'clock in April. It's exam season. So extra love to you all for being here. You are the reason why we do this work, and knowing that you all will be out there practicing in your respective fields is what keeps us all going. So thank you all for being here and for being thought leaders. We are in the home stretch, and we're very excited to put on this final panel about youth and access to reproductive health. It's a great panel to keep all of these threads going. I was saying during the coffee break, I will never approach a conference again without a mind map, because that's always what conference organizers are trying to do, but making it happen is so much harder. And so I just think that's such a powerful visual reminder for us to sit back down after every break and realize we're going to talk about access to reproductive health for youth. And that's going to bring us back to talking about LGBTQ youth. It's going to bring us back to talking about mental health. It's going to bring us back to educational systems and oppression. And so we are so glad you're all here. And it's also going to bring us to a topic that I've not heard come up yet today either, of how we even define youth and where we situate them in the sometimes like neither this nor that kind of space when we think about youth and reproduction. So we have an incredible panel of speakers here today. So I'm going to do some edited, excerpted bios. Their full bios are in the program. I invite you to check it out because they're all stellar. The first person I'm going in alphabetical order is Professor Fields Alsbrook. Jamil teaches at the St. Louis University School of Law, and before that, she spent decades here in Washington, D.C. doing work in federal policy. I'm horrified to say, Jamil, that I just introduced you like a month ago, and I used present tense in describing your work implementing $400 million of grants at the Office of Population Affairs for Health and Human Services. And even as I was getting ready to introduce you for a second time at a program, I realized that I'm not even sure the present tense still fits that introduction. That she had an amazing role at the Office of Population Affairs, Health and Human Services, implementing $400 million of grant funds to Title X family planning clinics. She's also worked as the director of women's health and rights at the Center for American Progress, where she managed policy development. She's also worked at Planned Parenthood Federation of America and at the National Health Program, where she was their If, When, How Reproductive Justice Fellow. So welcome. Next, I'm going in alphabetical order. We have Naomi Kahn, who is the Anthony M. Kennedy Distinguished Professor of Law and co-director of the Family Law Center at the University of Virginia School of Law. Naomi is a co-author of numerous books and articles, including most recently, Hot Flash, How the Law Ignores Menopause and What We Can Do About It, with co-authors, and The Fair Shake, Women in Fight for a Just Economy with other co-authors. Naomi teaches reproductive justice, family law, poverty law, and trusts and estates. She was an advisor to the ALI's restatement of the law on children in the law in 2024, an incredibly distinguished position. And she received the Harry Krause Lifetime Achievement in Family Law Award from the University of Illinois College of Law. So welcome, Naomi. Next, we have Joanna Grossman. She is the Ellen K. Solinder Endowed Chair in Women in Law and a Professor of Law at the SMU Dedman School of Law. She currently serves as the Herman Flager
visiting professor of law at Stanford Law School, and her research focuses on gender equality, reproductive rights, and she's been active in reproductive rights advocacy in Texas, and we'll hear about that experience. She's also the author of many books, including 9 to 5, How Gender, Sex, and Sexuality Continue to Define the American Workplace, and Walled Garden, Law and Privacy in Modern Society. Next, we have Dr. Julie Maslowski. She is a developmental psychologist and a population health scientist who studies adolescent health with a focus on sexual and reproductive health, including contraception and abortion. She's at the University of Michigan, currently doing this work. Her research integrates adolescent developmental science with population and reproductive health to inform developmentally appropriate policies and practices on adolescent sexual and reproductive health. She's the lead author of a recent report, Adolescents, Post-Dobbs, a policy-driven research agenda for minor adolescents and abortion. And then finally, we have Shanta Trivedi with us. She is an assistant professor of law and the faculty director of the Syra and Neil Meyerhoff Center for Families, Children, and Courts at our neighbor University of Baltimore School of Law. She teaches courses on family law and child welfare, family policing. Before entering teaching, Shanta was a staff attorney at the Brooklyn Defenders Family Defense Practice, where she represented parents who were embroiled in the child welfare system. So she has abundant experience at working with families facing challenges as low-income, minority, and otherwise disadvantaged families. So we have an incredible crew of folks to speak with today. So to kick us off, I think the best place for us all to start would be to move from all those bios, credentials, and publications to pull us straight into what you're doing actively right now in the space of adolescence and reproductive health. And why don't we start by going straight down the line?
Okay, hello everyone. I wanted to acknowledge all of the previous panels. As a population health scientist who every day tries to communicate complex social determinants of health and how they're impacting these issues, you all amazed me. And I want to thank the last panel, especially. You really teed us up. Unfortunately, there's a lot of parallels and connections between what is happening in the LGBTQ population and what's happening on reproductive health. So I lead a group of researchers and clinicians who are particularly concerned about adolescents' access to contraception and abortion, and that part of that, much of that is driven by the fact that we don't have a lot of research evidence on minors in particular. And so we are working to bring evidence into this space. And this is really important. So we have recent studies that show, for example, that 2/3 of minor adolescents in this country are living in a state that restricts their abortion access, yet only 1% of participants in studies on abortion are minor adolescents. And this is used by opposition to reproductive rights to justify restrictions on adolescents' reproductive rights. So I'll give you one example. Many of you may know that there is currently a lawsuit pending to try to revoke FDA approval of mifepristone, which is one of the medications that's used in medication abortion. There are a few points that are being made in that lawsuit, but one is that they are claiming essentially that the FDA was wrong in not considering evidence on pediatric populations, and that there is insufficient evidence on pediatric populations for this to be used. I think it was said in the previous panel, they start with minors, right? They start with revoking access for minors, and that we know that that's just the beginning of setting new precedents to restrict access. There are a number of issues in clinical care. So clinical care on reproductive health is designed for adults, but needs to be developmentally appropriate. So many of our group works on developmentally appropriate contraceptive and abortion care. So I'm sure I'll share more as we go on, but that's a flavor of what we do.
Hi, everybody. As was mentioned, I'm Jamil. It wasn't until I knew you were going to ask this question and made me realize a lot of my writing lately has been about vision building, and a lot of my advocacy work has been defensive, and maybe that's something psychological that I didn't realize I was doing. But I've been working on and writing a couple pieces, 2 law reviews, one on I've titled Regulating Birth Justice. And, I don't have to tell, I'm sure many in this room, that, Black and Indigenous women are around 3 times more likely to die from pregnancy-related complications. And so this piece I started looks at what has been the federal government, or generally the government's role in creating those disparities. Others have done a similar work, and it sort of builds on that. The not surprising that the same people who have the worst health outcomes and worst disparities have been those who the government have treated as unworthy to mother. So the piece offers what are the roadmap and opportunities there to address, and in this moment in particular, looking at sort of the missed opportunities if we allow our federal government to be gutted. And then related to that is the piece around defining what birth justice is. You know, as was mentioned, I came from advocacy before joining the academy, and we use birth justice all the time just as a term, and it's a term that doulas and midwives in particular have used and coined. And so I thought there was a definition out there, and theirs was a lot, you know, sort of a unified vision, and turned out there's not. And so what I've started doing, and it's very much a work in progress, is thinking about what does it mean to have birth justice. I think part of the reason we have those inequities is that we haven't all settled on, and this is those who are interested in improving health outcomes, haven't all settled on what it means to have birth justice. Yes, it means not avoiding preventable deaths, but that's should be a given, right? And as it relates to the topic of today, in particular, thinking about what does it mean for young and parenting young people. I know we're going to talk some about reproductive justice, but similarly, I think birth justice also involves centering whoever is deciding to mother and meeting their unique needs and thinking about that. And then the last piece is less of an academic piece. I'm also a fellow with the National Partnership for Women and Families, and we've been working on a piece about a vision for women's health. Quite frankly, started working on this before the election, and then, you know, we had some thoughts about, do we keep it going? Is this the right moment? And I voted for a yes, because I think it was mentioned earlier, you know, we've never had a healthcare system that works for women adequately. And so, yeah, we want to think about defending what we have, but I think part of the reason, my personal opinion, we've ended up in the results we have is because we haven't offered people something that is visionary and goes beyond like protecting the status quo. It's never been good for women. It's never been good for LGBTQ folks. It's never been good for people of color and many others. And then there's that's the happy work. And then on the unhappy work is, you know, all the defense things, Medicaid in particular, as I know we'll talk about, Title 10 near and dear to my heart, and other things.
Hi, I'm Shanta Trivedi. I hesitate to go after Jamil, who is working on multiple things. And when I say that, it usually means I'm working on one thing and there's like an idea written on a piece of paper somewhere.
That's where they were at.
I want to say thank you to all the prior panelists. My head is really spinning, and I'm grateful for all the connections that you've drawn amongst our work. And I suspect more will arise on this panel. And thanks to the organizers for having me. So I'm currently writing about the relationship between pregnancy and violence, and how limiting the access to abortion after Dobbs will lead to an increase in both private and state violence. And by private violence, I mean intimate partner violence, violence between people in a romantic relationship. And by state violence, I mean the intervention of the child welfare or family policing system. And that's because the family policing system often intervenes in cases of intimate partner violence, ostensibly to protect the child, but then accuses the person who is surviving violence of failing to protect their child from the very violence that they are experiencing, and then threatening them with many interventions, not the least of which is the possibility or actually removing their child. Young people, of course, experience both violence in their relationships and pregnancy. So as part of my paper, I'm exploring the unique impacts on youth, primarily, you know, teenagers and adolescents. And the reality is that more than 7 million adolescents live in states right now with abortion bans, and the restrictions that they face on their reproductive health care is further exacerbated by their youth. So in the ways that an adult may be able to travel or seek telehealth, youth may not have that option. So the concern is that when youth are denied access to abortion, the birth rate will rise, and we will see a corresponding increase in teen violence and then state intervention through family policing.
Hi, I'm Naomi Khan. Thank you. This has been an amazing multidisciplinary conference. So thanks so much to those of you who put in all the work of getting us all here. I do feel somewhat, in some ways, I also feel somewhat multidisciplinary because it's a combination, it's a bringing together of health law and family law, just even within the law, as well as lots of people from outside of the law. Shout out to the Children and the Law AALS section. Nicole's on the executive committee. For anybody who's interested in exploring these issues in that format. So my work has been looking at issues involving children's rights, and shout out now to Catherine Smith, who was at Denver and is now at WNL and is doing a lot of great work on the importance of recording those rights to children. Most recently, I've worked on a couple of articles with Mary Ziegler and Max Eichner on our first article just follows really nicely from the previous panel, because we talk about how efforts to limit minors' access, say, to reproductive rights, to contraception, to abortion, to gender affirming care, to learning about various subjects in schools, how all of that is being justified under the rubric of parental rights. And so what we've done is tried to establish a way, a test for determining when laws allegedly passed to promote parents' interests really are in fact efforts to sneak in other culturally difficult issues, culturally controversial issues. And so we call this retrenchment by diversion. It's a tactic of you divert from what you're really doing, which is limiting access to abortion or contraception, by saying, oh, we're doing this all in the interest of parental rights. We've seen this with the abortion trafficking, which we'll talk more about later, as well as now with the care trafficking efforts. And we're also talking about when this triad of parents, children, state, I'm talking about how it really is a dyad, and it's really kind of the state and parents, and when issues like parental consent should be looked at with a great deal of skepticism. I'm also, and I view this as related because I've been doing some work on minors and social media, and of course, being able to access social media for information for minors is important. And I'll stop there.
Great. So in addition to teaching a class on reproductive justice and doing the law professory things. I live in Texas, and before Dobbs, I did judicial bypass. I represented minors in judicial bypass proceedings, which is the proceeding to get court ordered to allow an abortion without parental consent. Prior to the ruling in Dobbs, any state that had a parental involvement law was constitutionally required to have a judicial bypass procedure. So I represented minors in that and did all the appeals for the state of Texas for about 2 years prior to Dobbs. And so through that work, I got very interested in the ways in sort of two things. One is the differences in minors' lives compared with many adult women that directly affect their ability to access abortion. And that is even more so now, obviously, in the wake of abortion bans. So things like lack of freedom of movement, surveillance, truancy laws, no credit cards, right? All of the things that make minors minors, in fact, make it much more difficult to access abortion. And given the new environment in which In Texas, for example, 34,000 women left the state of Texas in 2023 to seek abortions out of state. That's a big number. A lot of people figured out how to get out of state. For minors to get out of state without being detected, without parental involvement, is obviously a much bigger deal. So I'm interested in the ways that minors have practical limitations, some legal, some economic, that were already a problem because we've situated reproductive rights in this autonomy framework, assuming that autonomy is what we're protecting, but then applying that to a group of people who have really restricted autonomy. And then the second thing that the practical experience of working with actual minors really got me interested in is the intersection of all of the different rules and rights around sexual and reproductive health. So if you just take a typical minor in Texas, we're an abstinence-only state where sex education is optional in public schools. It's almost better if it's not given, because if it is given, it's so bad. We do not allow access to contraception without parental consent in Texas, one of only 4 states. And the Title X clinics now, because of a court order, are not permitted to serve minors in Texas, even though generally there's a non-discrimination by age provision in Title X. So there's effectively no access to contraception without parental consent in Texas anymore, other than O-pill, which is new, and we don't really know how much, how much of the gap that's gonna fill. So the combination of lack of sex ed, lack of access to preventative, to contraception, very limited access to abortion, if any. And then we have a very high population in foster care and in immigration detention who have zero access by law to any of these things because nobody is authorized to consent to abortion or contraception for people in foster care or whatever. So if you put all those things together, we basically are situating minors in a landscape in which they don't have anything resembling reproductive justice because they are not protected if they give birth. They're not protected if they don't give birth. They don't have control over whether they give birth. So those are some of the things that I think about.
Thank you, everyone, for all of that. And in that we can hear the things we might have expected in a reproductive health panel about birthing, about abortion, about contraception and sex ed. But there's so much more on the agenda and even so many things that haven't been named in that vision board. And so we heard the criminal legal system, foster care, detention facilities, gaps in research, education law, truancy law. And that really, really frames for us just how deficient a health-only lens is, just how deficient a rights-only lens is, and just how important a reproductive justice lens is. And so, Jamil, you mentioned your birth justice work. Maybe you could start us off by giving us a little bit of a definitional introduction to what reproductive justice is, how what we just heard is reproductive justice, and why it's so essential to get youth into the conversation through this approach.
Sure, I'll do my best and everyone should chime in because I think, reproductive justice is a big tent and we all might have different views about what it is. At a basic level, reproductive justice is about defining, being able to decide if, when, and how to become a parent, how to parent, and raise the children you might already have. I always tell the joke when I'm asked to do the definition of reproductive justice that, as was mentioned in my bio, the if, when, how reproductive justice fellow. And when I did it originally because I wanted a job getting out of law school and I did not know what reproductive justice was. And I remember looking it up. Well, first of all, I remember being asked in the interview, what is it? And who knows what I said? I know it was not correct. But anyways, I got the fellowship anyway, and I'm now on their board. So it always got with me. But I had to learn the definition. But it's a movement first, before it was a theory. It was founded by women of color, particularly Black women in the early 90s. I was reading, and Ricky Solinger and Loretta Ross have a book about reproductive justice, and as the story goes, as I was reading it, some women gathered at a conference, so things come out of conferences. It was in the middle of the Clinton health reform, and I really felt like the reform efforts did not speak to them at all. It did not include their needs. And this was also under the backdrop of the belief that the traditional white-led reproductive rights movement also was not inclusive of them and did not consider all of their health needs and rights, recognizing that having a constitutional right was not enough. Even then, they recognized that would not lead to many women of color, in particular, many low-income women, immigrant women, turning into access. And so Roe meant sort of, it could just be on paper. And that's also the reason I started to tell that story about me not knowing the definition of reproductive justice. Maybe I should have, but also it's because, this long after the reproductive justice movement was founded, I didn't see myself as a part of reproductive rights. I mean, I thought, okay, I support it, but it's a traditionally white women movement. I supported abortion, but just wasn't really where I saw myself doing work. I wanted to do health equity, and I thought that was sort of my career path, and it has been. But once I learned about how reproductive justice is about centering all those different threads, so many of the things we talked about today, reproductive justice at its core, like I said, was about centering and making sure the needs of the most marginalized were included. So yes, that includes trans people. Yes, that includes immigrants. And yes, that includes young people. And so I think, as it relates to our conversation today, I think you cannot, from my perspective, be truly doing reproductive justice if you aren't also taking the intersectional view to consider young people's needs. And yes, some of us, I was young and still am Black, but I was young and Black. And so, considering, I lost one, I kept the other. Some of us get to choose one identity. You have to consider all of those in order to truly achieve reproductive justice. And also the last thing I'll say is that it includes access to contraception, abortion, maternal health, but also includes, I have 2 Black sons. They're little babies now, but I won't be able to effectively raise them if there's fear of them being killed by the police. So that's a reproductive justice issue. I can't effectively raise them or even, or birth other children safely if I don't have clean air, if I don't have a house to go to. So it's a big view and considers a lot of different issues in addition to some of the core healthcare services.
More parallels. I also did not get the job the first time. You did. I do remember the answer I gave, and it was terrible. Because I didn't really know anything about the child welfare system. And now, if you know me, I'm a broken record about family policing. But what Jamil said, part of the rights of reproductive justice are not just the rights to have or not have a child, right, through way of contraception and abortion, but also the right to raise a child if you want to in a healthy and stable environment. And the family policing system can really limit those rights in young people, and particularly for young people who might be in the foster system. And of course, there are wonderful foster providers, but for many, statistics show that the foster system itself is not a safe or healthy environment. So I went to a couple ways that the state limits youth's ability to raise their children or to make decisions about their reproductive health care. So first, there are many studies that say that teen parents are more likely to abuse or neglect their children. And I take issue with that framing. I take issue with any framing that says that some group of people is more likely to abuse or neglect children, because what it really generally shows is that that group of people is more likely to be accused of abuse or neglect and dragged into the family policing system. And a lot of what is categorized as neglect are really symptoms of poverty which could include substance abuse, mental health, things that are related to trauma and poverty. And it really makes sense for teen parents if they are not able to finish high school, if they are unhoused, if they are facing other challenges. It makes a lot of sense that they would be more vulnerable to state intervention. Second, if youth are already in the foster system, or if they have been pulled into the family policing system as parents, they are really vulnerable to state intervention themselves because they are under state supervision. Sorry, as foster youth, they're vulnerable to state supervision. And that really means that they then risk removal of their own children because they are constantly under the surveillance of the agents, caseworkers, and their foster parents. Also, if youth are in foster care themselves, studies show that they're more likely to get pregnant in the first place. There can also be high rates of sexual abuse in the foster system that can really complicate reproductive decision-making due to shame, due to stigma. I read a study where a young person disclosed sexual abuse in her foster home and went as far as to show her caseworker her bloody underwear, and the caseworker responded that she was probably just menstruating. So if you're going to disclose something so traumatic and have the response be, well, you're probably lying and just menstruating, there's a lot of shame around then being like, well, I need help in this scenario. And many foster care agencies are also religiously affiliated, which may complicate access to contraception and abortion. Additionally, a lot of foster youth experience extreme instability. So they move from home to home, and due to that instability, they never really have a model of what we might think of as good parenting, such that you wouldn't have state intervention, right? So I saw a study that said that 1 in 5 teen mothers in foster care were investigated for child abuse and neglect of their own children. And the author said that this was strong evidence of an intergenerational pattern of abuse and neglect. And I would argue that it's strong evidence of what I said earlier, which is that they were vulnerable to the conditions that might lead to family policing intervention, but also they perhaps didn't have strong models for what we consider good parenting behaviors. So we tend to learn parenting from our own parents, from the parents around us. So if in your home physical discipline is appropriate, or what you learned of as the way to deal with misbehavior by children, that is probably what you will do because that's what you know. Also, you may not have had anyone talk to these youth about contraception. No one might have ever talked to them about where babies come from, because whose job is it? Is it the parent that they were removed from? Is it their foster parent? Is it the agency? And they might not have basic information about sexual health. And just to pick up on some of the themes of the earlier panels, gender affirming care is reproductive health care. And allowing parents to make healthcare decisions about their children is also part of a reproductive justice framework. So if we were to use the reproductive justice framework in thinking about youth, we would give gender affirming care to children if they need it. We would give young people access and education about contraception and abortion. And if youth choose to parent, we would support them in raising their children. And I think also when young people are making these decisions about whether to have a child or not, we would also describe the options in a way that doesn't glamorize or preference one option over the other, because any of the options can cause harm to an individual, right? Adult or youth. And I think, previously we used to tell young people like adoption, you're going to give a gift to someone else, which may be true. But we are now getting a lot of research about the impact of adoption on the birth moms. I highly recommend the book I just finished called Relinquish by Gretchen Sisson. And, I was really struck by the health centers that were described on the first panel. I can't imagine young people everywhere having access to a place where they could get access to a pediatrician when they are young, and also have access to the same pediatrician for their child. That to me sounds like a dream. Young people may need more support to parent if they so choose, but that's okay. And I think we just have to be all right with that.
In a moment, we'll turn to Dobbs. Before we turn to Dobbs, Dr. Maslowski, I wanted to ask if there was anything else you wanted to add on the developmental piece when we're talking about. So we've heard it said that youth is a marginalized identity, and we've heard lots of examples how, from access to credit to movement to the need for state or the perceived need for state supervision and custodial care. Is there anything else that should be on the table in thinking about youth as a marginalized identity before we turn to sort of decision-making and care?
Yes, so a lot of great examples were already raised about all of the ways that youth don't have access to a variety of methods of care. But I think something I would raise is on the point about feeling that your community is a safe place for yourself and for your current or future family. So we know that adolescence and into young adulthood is the time when people figure out who they are and who they are in their society and who they are to their society. And so we've been doing a lot of research where we're hearing directly from teens about how they are interpreting restrictions on reproductive rights and changes in reproductive rights. And what they are saying is that even if they are someone who is not sexually active or has, is not currently in need of sexual health services or has not considered abortion, that restrictions on their rights are having deep impacts on very important aspects of their lives. Everything from their mental health to where they want to live and work to who they're willing to date. We have data showing that sterilizations, so tubal ligations and vasectomies among 19 to 26-year-olds have spiked post-Dobbs because people are no longer willing to be childbearing. So although abortion sometimes feels like a niche issue and is treated like a niche issue, access to reproductive rights is affecting every aspect of young people's lives and how they're deciding where to live and work. We know that in restrictive states, they're losing about 30,000 young people per year because young people don't want to live in those states. So I think it just doesn't feel safe. People are not feeling protected or valued by their government at this point. And so it gets to the larger issue that this is impacting everyone.
Thank you. So let's talk about Dobbs for a moment. I'm going to start with Joanna and Naomi on this question. So in a post-Dobbs world, we're seeing lots of news stories about all the horrors inflicted, but actually quite very few news stories about youth for all of the systemic reasons we've talked about here. And so I'm wondering if you could give us a sense of what the landscape looks like post-Dobbs as a youth navigating, particularly in a restrictive abortion state, what that looks like in terms of reproductive health.
Go first and do the draft.
You live in a abortion restrictive state.
Texas
Yes,
trumps
true.
Virginia on the question.
And Trump was the right word, right?
But thank God for Mississippi, because yeah, so I'll just do some sort of some general landscape and then let Naomi talk about some of the trafficking efforts. Is that okay? Sure. The big shift, obviously, post-Dobbs for everybody is the adoption of bans in some decent number of states. The shift for minors is slightly different, right? In the sense that in any state with a ban, they're all covered by the ban. There's no difference in those rules. In some of the states that previously that did not adopt bans, but actually have now taken efforts to shore up reproductive rights. So the Massachusetts, New York, Colorado, California kind of states, in some of those states that minors are actually slightly better off because a couple of those states got rid of parental involvement laws as part of their effort to generally protect reproductive rights. So Illinois, for example, since Dobbs has repealed its parental involvement law. But you end up with this very checkered map in which, first of all, it's ridiculous that we would expect a minor to be able to even figure out within any state what their rights are, if they have any, where they would go if they didn't. Because we end up with states that have a general abortion ban and no special rules for minors. We have states that do not have a general abortion ban, but still have parental involvement laws, but the constitutional protection that demands bypass has been overruled by the Supreme Court. Currently, those states all still have judicial bypass proceedings, but it's unclear whether that will stick because they don't have to have them. So it's possible that in the medium term, we'll see some of those states get rid of bypass, but retain parental consent rules, even though generally they have not restricted access to abortion. And then we're seeing in some states the tightening of restrictions only for minors or special restrictions for minors. And that's what I'll leave Naomi to talk about. So restrictions on trafficking. And then in any given state, because of the unique situation of minors and their ability to consent to healthcare and custodial rights and parental rights generally, it was just a complex set of things. So just like in Texas, for example, there's no particular rule affecting minors' ability to travel yet. There's one pending in the Texas legislature, may or may not pass. But there are custodial interference laws that leave people open to risk of being charged with kidnapping or custodial interference if they are not the parent and help a minor leave the state. And so it's even for the advocates and the lawyers who do nothing but abortion law and do nothing but study abortion law, there's a lot of gray area and a lot of risk that goes into all of those things. So I think what the minors are facing is lack of information, but even when they have information, a lack of clarity just in the law. And then when you sort of add to that, the things I talked about earlier, they're kind of general restrictions on autonomy. There's no question that we're seeing that minors have suffered more of a restriction on abortion access since Dobbs than adults. And because the abortion bans we know have triggered a pretty stark increase in maternal mortality, in infant mortality, and in some other things, they're going to be disproportionately harmed in those ways because they are more likely to be forced to give birth and less likely to be able to prevent pregnancy in the first place.
I have to say, I mean, as you started, Jamie, with this question, I've been surprised that there have not been more stories and more legislation in the area of minors, except for what you mentioned, Joanna, which is that in abortion restrictive states, if you're going to ban abortion, you don't really have to pay particular attention to minors. It's banned for everyone, and it doesn't matter your age. So that's one explanation for what's going on, obviously, in the abortion restrictive states. The Kaiser website list, just to give you background on parental consent notification requirements for minors seeking abortion. It looks like it's pretty up to date, but what it says is that 21 states require consent only. So you have to get parental consent. 6 require notification as well as consent. I mean, consent implies notification. So essentially 27 states require consent and 9 require notification. Massachusetts, most of the states you'd imagine, of course, are in the notification/consent. Massachusetts requires consent before a minor reaches the age of 16. So variations in what consent and notification actually mean. It does mean about a third of the states, my math right, a little bit less than a third of the states actually have no restrictions on when minors can access abortion. But yeah, that's changed a bit in the post-Dobbs era, with some states allowing minors to have access. And I should note that notwithstanding the 21-6-9, I think but one of those states still has a judicial bypass procedure for purposes if a minor cannot get consent or notification or doesn't want to do so. The one thing that has been getting a lot of attention, has come up repeatedly, came up in the last panel as well as here, this idea of, and this is the terminology they use, abortion trafficking. So, which is preventing anyone from helping a minor obtain an abortion either within the state or going outside of state lines. And so the laws, there have been two laws, one's partially enjoined, one's adjoined in Tennessee and Idaho. Montana just did not pass one, speaking of Montana, although it was seriously being considered. And what these laws have a chilling effect, both for purposes of the First Amendment, as well as more pragmatically with respect to minors being able to access abortion. In an abortion restrictive state, where there's likely to be a parental involvement or some form of parental consent laws, minors are going to need to be traveling out of state. And so although the laws do create penalties for helping minors within the state, the question really is what happens with respect to their out-of-state impact. And all of that is still up in the air because the laws have not yet been directly enforced. In Idaho, the statute prohibition on helping a minor to get an abortion by harboring and these are their words, harboring and transporting them with the intent to conceal the procedure from the minor's parents was likely, the appellate court said, to be found constitutional. That part of the law could be enforced, but the law's prohibition on, quote, recruiting, unquote, pregnant youth violated the First Amendment. So that's the Idaho abortion trafficking law. Tennessee has a similar law that is currently being enjoined, but those are the attacks on minors' rights to access abortion that we've been seeing.
Thank you. And Dr. Maslowski, did you want to weigh in on this? And if you want to weigh in as well, just to give voice to these sort of hidden harms and the ways in which youth are being explicitly and implicitly targeted.
Well, I think it's helpful to dig in on parental consent for a minute, because I think on the face of it, it sounds a little innocuous, like, oh, parents are there, they can help their teens. And that's often the pushback that we get from legislators or from the general public. So one thing to note about parental consent is that in states that have passed ballot initiatives to protect reproductive rights, the opposition has used really extreme scare tactics, like they're trying to take away your right to help your child if they're having an abortion. So I'm in the Midwest. This happened in Ohio. This happened in Michigan. And so there were attempts to include revocations of parental consent requirements that were ultimately removed because the fear was that it wouldn't pass. And so this is one of the concessions that we often see, is that minors' rights are used as a bargaining chip. But I just wanted to give a little bit of what we know in terms of evidence on how parental consent works. So what we know is that the vast majority, like 85% of young people whose parents are around will involve their parents in their abortion decision, right? So the vast majority of young people, their parents or a parent-like figure, right? They will involve someone in their decision. And so who we really need to worry about when we have parental consent requirements are adolescents who maybe don't have access to their parents or are in non-biological parenting situations, right? So you can think of, for example, if you are in sort of an informal custody arrangement, you live with your grandmother and your biological parents aren't around, right? Grandma maybe can't fulfill the requirements depending on what the requirements are in that state. Children who are in state custody have to have different parental consent notification requirements, right? So is your caseworker able to provide consent? Children who are victims of family violence, right? So if you're a victim of incest, we also hear people feeling like they have very legitimate concerns that they would be harmed by their family if they were to bring this up. And so these are the young people who are really harmed if we have really rigid parental consent requirements in place. So I just want anyone, if you ever find yourself discussing that matter, to say, like, you know, most teens who are safe will involve their parents, and we really need to look out for those who can't for a variety of very intersectional reasons that we've talked about today.
just weigh in because Missouri, I'm in Missouri. I teach in Missouri and I'm also from there. And so obviously Missouri is one of the first states who had a trigger ban go into effect and banned abortion as soon as Roe was overturned. And related to our conversation and picking up on some of these threads that are mentioned here, you know, before, probably like many states, even before Dobbs, Missouri had a whole host of restrictions on abortion. They already had parental consent laws, has restrictions on private insurance coverage of abortion, has restrictions on requirements around waiting periods and gestational bans and a number of other restrictions. And so even before Dobbs, Missouri was only about 150 abortions. I saw some recent data that's being performed in the state of Missouri. That does not mean only 150 Missourians are getting abortions. You know, if you've missed the exit to my law school, you'll end up in Illinois. So people go over to, and I have done that. So you look into Illinois. And so I bring it up in the context of this conversation because this note you mentioned earlier that often the restrictions we see get put on young people first. We're seeing that right now with a lot of the gender affirming care restrictions. And I think that it allowing those restrictions already set the tone and made it more palatable when we get a full overturn, right? It was a chipping away. And so, that was always a part of the plan. And people can be very comfortable of like, well, yeah, I support abortion, but not for those kids, right? And so I think Missouri is an example where that was already happening. And then fast forward, in November, Missouri passed a ballot initiative, a constitutional amendment to make reproductive freedom as the language a right in the state. But even before, as the language was getting put on the ballot, a lot of the reproductive justice groups are raising the alarm, saying, "Hey, the mainstream groups that are pushing the ballot are again leaving out the people we always leave out, including young people." And so Missouri has got this ballot initiative. It's now been enacted, which I'm grateful for, but it's still has left in place some restrictions. And we saw some of the Planned Parenthood and some other groups challenge to get the ban overturned and to get many of the other restrictions overturned, which is great, but they did not challenge getting the parental consent. As I mentioned before going to academia, as an advocate, I understand the idea around strategy and all those things. But as we were talking about earlier, I think we have to also consider what moral compromises we're willing to make and who are we actually pushing for. Yes, if we get a reproductive right, but if we aren't pursuing reproductive justice, whose right are we actually getting? If we still have people who can't afford abortion access, we still have young people who can't for all practical purposes, actually get access without a, judicial bypass, then we're actually not pursuing reproductive justice.
Shanta, no pressure, but last chance to raise any harms, and we're moving to hope for the whole rest of the 12 minutes.
No, did you want to go?
No, go ahead.
Your team hope next, Naomi.
Yeah, I am team harms for sure. So, one thing that we had been talking about is sort of what happens when the state is involved and like, how do they balance the line between treating kids like kids or treating them like adults when they're parenting teens? And in my experience, they want to have it both ways. They want to treat them like kids sometimes and treat them like adults sometimes. So we're talking about young people who may not even be able to consent to their own healthcare. They may not be able to consent to an abortion. They are called too immature to decide whether or not they can have an abortion, but mature enough to parent, make it make sense. But then if they do have a child, they're held to the same standard as an adult. So taking Dr. Venkat's lead, I'll use a story to explain what I mean. I had a client who was 16 years old. She had 2 children, 2 and 4. And the reason she was in court was because her boyfriend, who was also a teenager, had hit her. And there were some issues of control. He was older than she was. And they also said that my client was neglectful because her kids were sometimes unkempt, like dirty clothes, dirty diapers. Okay, my client is 16. And they wanted my client to take a parenting class. And the real thing that they want her to do was to keep herself and her kids away from their father. And one time she violated that order because the kid's dad wanted to see them. And she brought them home with dirty diapers past their bedtime. So the state files to remove her children. And my client was devastated. She was in foster care herself. And the only upside was that her foster mother had agreed that they could all stay in the same household, but the kids would be, my client's children would be in the foster mother's custody. But what was unique about this case was that the conditions that the court set were that my client was to not see the father and was to not mouth off to the foster mother, was to keep her room clean, to meet her curfew. But then on the other end, they weren't extending her any grace as a child, but treating her like a child. And they also weren't raising the fact that she had been in a relationship where there was violence. She had been raised in foster care. No one had ever talked to her about contraception, about reproductive health care. No one had really taught her how to parent. And similarly, I had a student who was clerking and called me on her lunch break, horrified, because the case that was in front of her judge was a teen mom. And the judge told her in chambers, kids shouldn't be raising kids. This mom needs to have her rights terminated. And the child has a good relationship with the foster mother and he's little. I think this is the way we should go. So my poor student is like, how do I get him to change his mind? You know, and we strategized. But what struck my student most was that in the file was the fact that the mother, who was a teenager, had been in foster care herself as well. And there was a little note that said, suspicion that mom was trafficked while in foster care. It's in the file, and nobody ever talked about it in the courtroom. And nobody had ever raised the possibility that the fact that she was trafficked in foster care may have impacted her parenting and her life. And the instability that was present in her life, that was the result that led to this case, that might have been a result of her own experiences in the foster system. And again, we were treating her like an adult, but failing to acknowledge her youth and the fact that youth might process trauma differently, or it might show up differently, especially when they're young. So in that way, we hold youth to this very high standard of parenting, while simultaneously doubling down on the fact that they're children in other ways.
So symbolically, I worry that over the course of the day, lots of our conversation has had folks acting upon youth from the state to systems of oppression. So symbolically, I want us to end this conference with the question about youth as transformative agents. So what are you seeing in the ways youth are contributing in civics, in reproductive health, information sharing, social media? What is an example of youth changing the conversation that we can all celebrate and learn from? We're not just teaching youth, we learn from them too. Do you want to start? Yeah, wonderful.
Yeah, so we have a program in Texas called Youth Testify, where people, most have either had an abortion and had a judicial bypass, or have had some other involvement in those things, and they get trained to give legislative testimony and trained in public speaking and trained in narrative storytelling. And it's been really powerful to sort of watch, 16, 17, 18-year-olds, or sometimes they're 20 or 21, and often parenting a 5-year-old at that point, or have had 2 abortions. And it's been I think nothing in Texas is changing for the better at the moment, but it's still really important to have those voices at the table, telling the actual story of what it's like to be a pregnant minor who is has been deprived of sex ed, has been deprived of birth control, has been deprived of control. I mean, it's been a really powerful effort. It's not my project at all. I'm just observing and lauding it.
I'm gonna I was involved in the project that Julie authored that on adolescent access to abortion. And I will say one of the amazing things about that project was you involved youth. You had youth voices at the table whenever we were discussing the issues and in the report. And so, yes, amplifying youth voices is so important. I mentioned that I've done a little bit of work on children and social media. In Illinois, a high school student's project became law because she called up her local state legislator and made the legislator aware of the problem. And I think she was just starting. I think she was a freshman in high school, and she was able to get a state law passed. And so that also that does go to acting locally, having students speak at school board meetings where they're allowed to speak, having just advocacy, teaching our youth that they really can make a difference on their own.
I'll be quick. Our law school, If When How chapter lobbied for years to get a reproductive justice class. We didn't have one. And they went to the administration repeatedly. And now we have a reproductive justice course as part of our curriculum, which of course we should. And recently, I found myself in the very strange position of testifying against a parental rights bill when most of my career has been dedicated to advocating for parental rights for many of the reasons that Naomi said. It was a fake parental rights bill. There was actually an anti-trans, anti-CRT bill, but I almost ceded my time because there was a string of high school students who, some of whom were sitting in their high schools, like in rooms, testifying on Zoom about how hateful these bills were and how harmful they would be to them, their colleagues. And they were incredible. And I think by far they were more persuasive than the adult advocates. So I encourage youth to testify. The government obviously affects you. And it may seem crazy to testify in front of your legislature, but trust me, watch a couple of people do it and you'll realize that anything you say is valid. And it's really, really important. So you can do it on Zoom. If you live in Maryland, you can do it on Zoom. You can show up in Annapolis. And if anybody ever wants to do that, feel free to reach out.
Yeah, so I give a specific example then a general thought. When I was at HHS, I was a part of team leading the first effort to develop a national strategy on youth health and adolescent health in particular. And the thing that it's most amazed me, we got all these stakeholders, we would talk to all these, very credentialed people, and that's a privilege of being, sitting in the federal government. But we also wanted to talk to young people, and so we work with advocates for youth to organize folks. And the young people were so both knowledgeable and sophisticated in what was going on, and very clear about how these broader systemic issues impacted their lives. And I think many of us as we get older can forget that, or like maybe once we knew something, and we shouldn't discount sort of the voices of those who are, it's impacting them now. And again, back to the RJ idea, you can't do RJ work without listening to the most impacted, including listening to young people. And then I heard someone recently also mention that, most of the big social justice movements that have happened in our life, civil rights, LGBTQ rights, it's been young people who led those and were at the forefront. Like someone earlier mentioned, young people are all about tearing it down. And sometimes that's a good thing because things are messed up. So you do need to tear it down, and you need people just that audacity and boldness. And so, I think it just reminded me of being young doesn't mean you can't, and that's how the world has changed actually.
So my least favorite stereotype about adolescents is that their brains are not mature. Come to me later and I'll tell you about how that's a vast misinterpretation of the neuroscience. And actually adolescents have great brains. And if you listen to them testify on all sorts of things, they know what they need, they know about their bodies, and they know how to advocate for themselves. So my example, I was an expert consultant on the FDA approval of O-pill, which is the first over-the-counter contraceptive. So my job was to bring all the data data. But to our keynote speaker's point, you know what convinced that FDA scientific review panel that they should approve this and that they should not have a lower age limit on it, make it available only to age 18 or 21, was the impassioned, highly effective testimony of young people who said, for example, I grew up in Appalachia in a contraceptive desert, and let me tell you what it's like to be a young person who is being told and being shown that I don't deserve to control my body, right? And giving that impassioned testimony in addition to having, right, the solid data that of course this is safe and effective and should be available to people over the counter. Every single member of the scientific advisory committee said, those young people convinced me.
Maya, have I failed as a moderator? Do we have time for a question, or do I have to do the moderator walk of shame?
We gotta get at least one question, and I'm sure we have. Really, I think you, is anyone, there's someone else? Go for it.
So my question is about adult allies, and I so appreciate you recognizing the complexity of parental consent laws and how most minors I've been in options counseling with do bring in a trusted adult, a parent or somebody, because adolescence is about supported decision-making, and adolescents fall between that space between child health policy and adult policy, and the regulations often are confusing to them about, you know, what their rights are. But my question is, have you seen anything successful in terms of investing in adult allies, both as part of the solution and as advocates for young people? Because people ask me as a teacher, who should have the conversation with the kid? Who should be teaching them? Is it schools? Is it parents? And I find that in my work, supporting parents, having conversations with the kids and being involved has just been so much more fruitful. And if we could get those parents to kind of stand up and speak to their experience and support kids, I just feel that sometimes gets lost in the conversations about confidentiality and keeping parents out.
I mean, I'll just say quickly, I mean, I was thinking of this in the last panel that, you know, I think we do have to do a better job of giving parents education about reproductive health in particular in order to help them support the young people in their lives. You know, I think a lot of times in repro, we often have this idea, and I fully support it, that the young person needs to be able to make their own autonomous decision. And that's true, but often many of us, when we were young, went to trusted people in our lives, whether it was our friends, our parents, and often they also didn't have any information because they also were poorly educated, given sex ed conversation from earlier. And so I think, you know, I don't know the solution. I mean, we alluded to this, you know, sort of the gutting of Title X, and I think that only is exacerbating the problem. That there have been trusted health centers like that where people could go get information, whether it was parents or the young person themselves. And so, you know, that some of that is falling away, but there are still some places where people can go get information.
Well, we know you all are doing such important work by day. Thank you for taking a day out of your work to be here, to travel. We have folks here from Texas, Michigan, Missouri. Thank you for taking the time to be here to share your wisdom and expertise with us.
All right, so I have the joy and privilege of doing the 1 minute, I promise, wrap up here. You know, as I've been in this room today, I feel in some ways both exhausted and energized. And I think that's okay. I think it's okay that we acknowledge that, but we leave on that note of energy and enthusiasm for the work ahead. I also realize that when we gather together like this, it's very powerful. When we share our stories and our experiences, it's powerful. I also want to end on that same note of hope that we have had just a tremendous crowd of engaged American University law students here today in the room, online, also from a few other law schools. I just want to acknowledge your engagement, your presence. You are the change makers at American University. We're proud of you, and we hope that you'll take the learnings from today, and that will be energizing to you as you move forward in your careers. Thank you very much to our wonderful panelists here now, as well as throughout the day. Our wonderful moderators, Professors Abrams, Williams, Budzinski, and Porter.
Also, Professor Weitz, who we met earlier today, who is from the Center on Health versus Society. They have been such a wonderful partner for us. Professor Tamar Pearson-Brown, this map is an incredible tool. And, you know, I think it's really just a best practice for us to try to think about having tools in the moment that can be really practical for us to take our learnings into the future. I also want to thank Dr. Venkat, you know, hearing from you, being inspired by your work. And again, it motivates us and it helps us really think about what you said about that local outreach. Reaching out is a way to have an impact. And I think we're all going to take that to heart. Last but certainly not least, I want to make sure we thank Professor Manian. Maya, this has been, I think, really just a passion. I mean, something that she has put all of her energy and heart into for several months. Many of us have heard many of these topics in different ways, you know, reproductive health, LGBTQ, mental health, but to tie it all together from the perspective of youth is something that we haven't necessarily seen the emphasis so far. And to bring this together is, I think, so thought-provoking. Thank you, Maya, for your leadership. We are wrapping up on time. I like us to run a tight ship. We are also going to be, as you know, it's been recorded. If anyone missed something or wants to check it out later, we have a YouTube. We're going to send it out to everybody. Remember that we did a lot of great events this spring, so you can catch those other programs on YouTube. You can follow us on LinkedIn. We'll have a lot of great programs coming up in the fall, so I hope people will participate. Thank you all so much again. Enjoy some more coffee and cookies. Take care.